morning, everyone. A very warm welcome to all the participating speakers, panelists, representatives from various ministries of health, distinguished members of various fertility and embryology societies, healthcare professionals, and our dear Merck Foundation alumni who have joined us today in person and online for this fertility care and sexual and reproductive health session under the auspices of Merck Foundation More Than a Mother movement at the 7th edition of Merck Foundation First Ladies Initiative Summit 2025. My name is Dr. Shadab. I'm a scientific and medical manager with Merck Foundation, and I'd like to introduce the co-moderators for this session, Dr. Gabriel Mulimbi from Zambia and Dr. Enid Chivanga from Tanzania. Merck Foundation continuously strives to improve access to quality and equitable healthcare solutions in underserved communities by strengthening the local capacities and enhancing the clinical management process through its various scholarship programs offered under the Merck Foundation More Than a Mother movement. Merck Foundation offers hands-on training programs in fertility and embryology at its various partner institutions. Besides, it also offers scholarships in 44 critical and underserved medical specialties, including one-year postgraduate diplomas and two-year MSc degrees in sexual and reproductive medicine, women's health, family health, biotechnology of human-assisted reproduction, clinical psychiatry, urology, and more. You can visit our website, merck-foundation.com, or download our very own Merck Foundation app from the Play Store or App Store to access the full list of available on-site training programs and online courses and stay updated about our various initiatives. Having said that, I would now like to request Dr. Enid Chivanga to kindly begin the session by introducing our first speaker for the day.
A very good morning to you. Thank you, Dr. Shadab, for the opportunity. Now I would like to invite our first speaker, Professor Oladapo Ashiru. He is the President of African Reproductive Care Society, President of the Academy of Medicine Specialties of Nigeria, Secretary General of International Federation of Fertility Societies, Nigeria. His area of research interest is mainly in the field of reproductive endocrinology, infertility, and assisted reproductive technology. He is considered as the pioneer of in vitro and embryo transfer in West Africa, and has been a long-term partner of Merck Foundation in its various programs. The topic for his first presentation today is the strategies for mitigating lifestyle-related infertility. Over to you, Prof.
Thank you very much. It's a pleasure to be here, as usual, at this Merck academic session on reproductive medicine. I'll be talking on the strategies for mitigating lifestyle-related infertility, if I have the first lines. Now, so I'm going to look at this is very important, as I was explaining yesterday, because if all this is avoided, there might be no infertility to some extent. So we'll talk about, endocrine disrupting chemicals, strategies for mitigating, conclusion, and call to action. Now, the concept that we're exposed to toxins right from birth is very critical. So human beings are exposed to toxins while in utero, toxins like pesticides. Climate change is very critical. Environmental toxins, and women are 14 times more likely to die than men in natural disasters. Now, so you look at the maternal and newborn health, you talk about the environment, you talk about women's health, and then you talk about the role of maternal and newborn health. Altogether, they are intertwined. And This was from the Secretary General of United Nations, Kim Moon, who said, climate justice now, we need to look at it. The climate is being endangered. There's a lot going on in the climate. Now, what are these things going on? What are the exposures? Air pollution, water pollution, mining, deforestation, then personal products that we put on our body, cosmetics. A woman is supposed to use 1 ton of lipstick in her lifetime. So if you don't look at the quality of the lipstick, you'll be talking about lead poisoning. Pesticides. Pesticides are critical because they go beyond 1 generation, and they go 2-3 generations, and endocrine disruptors. So what are these agents? They include industrial chemicals, BPA, PFAS. These are in plastics containers, agricultural products, heat, radiation, and byproducts of combustion, industrial processes. Then you talk about food nutrients, blood glucose, prescription drugs. Some of them. Yes, so thank you. Prescription drugs, some of them are teratogens, and then lifestyle choices, tobacco, alcohol, recreational drugs like amphetamine, and the rest of them. Then social economic factors, they're also there. Now, I mentioned this, lipsticks. So what are environmental toxins? These are toxins that exist in air, water, in food, in the soil that we grow our food products, like tubers, yam, potatoes, dust, and in the air. CDC showed that you could find in human samples like urine, blood, serum, milk, meconium, over 300 environmental chemicals. Why should we be concerned about this? Look at this. This is cancer. This is the rising trend. From 1973 to 97, this data was produced in this publication by Bingham. Breast cancer is on the rise. Increased diabetes, increased prevalence of autism, hypospadia, sperm count on the decrease. And we've made this publication even in recently in studies between Nigeria and South Africa to show declining sperm count and asthma and other attention deficit syndrome, ADH. This is why we have to be concerned. And now, this committee opinion came by the American College of Obstetrics and Gynecologists about toxic exposure. This was as far back as 2013. That if you are going through conception, if you plan to have a baby, you must avoid these chemicals because they are toxins in our food, in our diet. We reported, shown that environmental toxins can affect male abnormal sperm and female unexplained infertility. Heavy metals has impact on female reproductive system, and also there are toxic cyanobacteria in the air that we breathe. So, taken together, you could see that the routes of exposure of these toxicants are plenty. For your emphasis, you can see pesticides, fumigation in industrial agriculture. You could see cosmetics. You could see tin products. You could see these plastic products, especially people who drink water and then leave it in the car or in the sun. They are melting those plastic products into the water. And so many of them, retardants, diesel, gas, industrial waste, and so on and so forth. Look at Nigeria, and especially also in Africa. This area, this is the map of Nigeria. These are the people who are producing oil. These are the oil-producing countries of Nigeria. Even though Nigeria is an oil-producing country, there are consequences to this. Patients who come to the clinic from these areas, you find out that they find it difficult to conceive unless you remove those environmental toxins from them. And this is what we found out, that even when you transfer normal euploid embryos to them, they don't get pregnant. Because the gas flaring, like a town like Port Harcourt in the rivers, when the gas flare, if you leave your room and you dust it, by the time you come back, you find that you see soot on your tables. And this is what you inhale, and they become toxic to you. Climate change, of course, we're talking about this in terms of what it can do to children and what it can do to, in terms of increased heat, temperature, and also the association between preterm birth and pollution. This shows you the global pollution and preterm birth. You could see the rate of increase, high rate in these countries that have low control on emission. Air pollution and heat exposure in preterm and low birth weight. This has been shown. About 32, almost 33 million births that were analyzed shows significant association in air pollution and heat exposure with birth outcomes. Pesticides. I mentioned this because all this, especially the food items that you don't have to boil, like vegetables that are grown in the soil, these pesticides, they get into them. So as a preventive measure, when you are eating salad and things like that, you are supposed to soak it in water or in salt water or in vinegar for about 20-30 minutes first to get rid of these products before you now clean it with water, before you now eat it. Otherwise, you'll be exposing yourself to pesticides. And the issue about pesticides is that it goes from mother to baby, and to be baby to be born by that mother. Then organophosphates are also there. Just for the sake of time, I will just quickly go through some of these. This perfluoroalkyl substance, PFAS, are also some of the things that you get exposed to. You can see these so-called forever chemicals. They exist in the soil, and they are emitted like from these products, stain retardants, and all these fire extinguisher, all these plastic and toys used by the babies. Phthalates, these are these products, canned foods, vinyl floor, and you see all these plastic containers, all these sports equipment. Some of them have phthalates, epoxies, adhesives, they all have phthalates in them. Food packings. Then we have volatile organic compounds. I'm just going through these effects. See, chemicals in menstrual products, a systemic analysis, it's been shown that even the menstrual flow has some chemicals in them. Urinary concentration of phthalates, this has been shown, and then association between them and pregnancy loss. So I'm emphasizing the fact that these events, research has translated science to figure to identify these compounds, and you could see that we are trying to make advocacy to let people be aware of some of these problems that can happen. Heavy metal contaminations, some of these prenatal vitamins, some of them are not they're not well made, and they have problems in them. So most of the time now, if you look at vitamins that are tablets, some of them have talcum in them, and you need those ones that are capsules. You see, all 26 prenatal vitamins tested were contaminated with toxic heavy metals. And this is lack of restriction to the industry. We talk about serious misconceptions about food. For example, all these vegetables that are not, they can erode my digestion and the rest of them. I mentioned this in my talk last time. Women, because they don't want to use a high heel, they use their feet on these pedals, and it contains antimony. Large fish, mercury, and stockfish. Rice has arsenic. Vegetables, and lead. And these heavy metals, they can lead to miscarriage or prevent conception. So what are the effects of these endocrine disrupting chemicals on health? It's been shown that these disrupting chemicals, they can affect different parts of our body. This was published in ASRM, and you could see there is growing relation between these substances and various reproductive outcomes. This summarizes where they can have their effect, starting from the brain, pituitary, hypothalamus, down to the ovary and the testes. So no one is spared, and no organ system is spared. You could see here, it has growing evidence about it reduces premature in boys, and childhood obesity are related to these organophosphate compounds. So, what in summary are the effects of this EDC? Difficulty in conception, miscarriage, abnormalities in babies, and I said pesticides can afford 3 generations. You could see it can affect the mother, can affect the baby, and the fetus. Those are the 3 generations that can be affected by pesticide. So be careful if you're in that area. And we've done some work with the oil to show that oil in the Nigerian burning light can affect both male and the female, especially the testicular composition of the oil. You could see it can affect sperm motility and morphology in the experimental animal we looked at. And association between pollution and birth weight, we've expressed that before, as well as preterm birth, air pollution and spontaneous fertility, and those who live in highways, they are also exposed. And then you could see the product of lead in water in Michigan. This is some of the contamination we have. You could see all these various sources of lead contamination. We realize that in Michigan, the water they use is not even safe. And a lot of people with lead poisoning are having problems in that area. So this is the impact of health on that area. Fertility fell by 12%, and fetal death increased by 58% just from that contamination. And today, from the work that we published in Reproductive Update, this is an IFFS consortium, we showed that fertility in 1950 was this high. Today, you can see that there's a dramatic decrease in fertility in many countries. No country is spared. Even the African countries that we thought we have high population is decreasing. And what I was saying is that by 2050, countries below replacement level, 93% of countries will not be able to replace their population unless this trend is reversed. And so today, 1 in 6 people have problem with fertility. 1 in 6 have problem with fertility, and yet the access is not there. So what strategy have we used in Nigeria to mitigate this problem? Because, as I said, we are a country that we have a lot of exposures to this. So we use the strategy of mother male detoxification. And this was formed, this gentleman, Frank Zevermeyer, was the pioneer of modern male medicine, which is detoxification medicine. And what he did, where he was a medical student who went through, had graduated summa cum laude, practiced during the World War, and he died. But this is what male medicine is all about. Detoxification, the process by which toxic substances are eliminated from the body and thorough intestinal cleansing is achieved for a healthy digestive system. You clean this digestive system, the liver, and this area. By that process, you achieve better immunity for the body. And it is shown by a publication from studies shown in Japan that there is a relationship between the gut microbiome and polycystic ovarian disease. And this is how some of the fact that there is a linkage between the gut and the hormone system. This is some of the experimental work that was shown. Potential mechanism explain how the gut microbiome triggers polycystic ovarian disease. So what do we do? It's a new approach to preventive medicine. It has gained widespread acceptance in Europe, particularly among workers in the high-risk industries, and also its effectiveness in driving down the cost of curative medicine. What are the common therapies in male therapy? We use oxygen treatment for the body through inhalation. We use chelation, all these heavy metals that we talked about. You can use these substances, electrolytic body detox, chlorella, all these to chelate the heavy metals. And then you drain the lymphatics. And then these are some of the equipment which we now use. The first center in Africa is there. Oxygenation, saline oxygen like antioxidant, electrolysis body detox that takes the heavy metal, lymphatic drainage, and then, let me see, yes. And then we have this infrared cabin to sweat out the toxins, and hydrotherapy to activate the skin lymphatics. And we published this work and showed that if you do the detox in this system of people, you see a significant improvement in the number of oocytes, in the number of positive HCG, and take-home baby is high. And we did study to show that we can use this bioenergetic system to, you can see the various things that are being shown, radioactive elements, coal or arsenic, you can see here, and silver. It shows what you have in your body. And the possible role of male therapy before IVF is that if patients go through IVF, you can remove nutritional toxins, removal of heavy metals, improve mitochondrial quality, total body detoxification, antioxidant therapy, and automolecular supplementation. So this generally is what we do. We take the patient history. If we ask for their occupation, if they work in a paint industry, in an oil and gas industry, or in a petrochemical industry, we immediately ask them to go and do this bioenergetic sensitive test. If they have unexplained infertility, we ask them to do this. If the test does not show anything, they can go through their fertility treatment. But if the test reveals some heavy metals or pathogens, we ask them to go through Mayer detoxification before going through fertility treatment. So what can you do as a team? What is the purpose or the hallmark of this lecture? Is that we all have to be aware that the health choices for patients are there. Need to be an expert to advise them about exposure to heavy metals. And we need to establish committee. I was in the committee for toxic environmental exposures in FIGO for many years, and give lectures to your hospitals and colleagues to let them know. Especially when I talk about this lecture publicly, and I tell women that driving barefooted has complications, many are shocked. I had a doctor who worked in my clinic and did IVF on 4 occasions. We had 14 embryos from her, and she was miscarrying until she went to Mayer and found out that she had a high load of antimony in her body. And she was asking me, how could she do that? How could she get it? She was living healthy. And I showed her, how do you drive your car? She said she removes her shoes. I said, yes. So you have been absorbing antimony by driving 2 hours a day to work and back for 15 years. Since you've been driving from the age of 20-something, 15 or 16, another 15 years at 28, 30, you already have high load of antimony in you. So we need to do advocacy for safe chemicals and reduce exposure. So we have to work together as a team to resolve and get this. Government, agencies, researchers, educators, and doctors to have a comprehensive, holistic solution to health. I conclude by saying that our environment consists of large numbers of toxins in soil, in the air. These toxins, like pesticides, have significant reproductive consequences in the males and in the female, and that male detoxification can help and possible implication. So it's better to prevent it than to leave it cured. And if you don't even have Mayer therapy in your centers, there are some medications that you can use, like selenium and cilantro, that can clip heavy metals from the body. And there are some antioxidants that you can use for your patients. And when infertility is being recurrent, then it may be worth its while for that patient to go to a center where she can be tested and cleaned out before spending money, 3-4 attempts on IVF. I've had a patient in my lecture yesterday at Zoom who said that she's done IVF on 4 occasions and it was not working. Repeated implantation failure. What are the causes? Number 1 is probably environmental toxins. Thank you very much. These are the people who work in our center, and I always end up my talk by saying that I recognize no superiority in mankind other than goodness. Thank you.
Thank you, Professor Ashiru, for the outstanding presentation. I would like now to invite Honorable Dr. Luis Poto, Minister of Health and Social Welfare, Republic of Liberia, one of the most successful alumni of Merck Foundation and a true inspiration for all. She will be discussing the topic, Strategies to Advance Fertility and Reproductive Care in Liberia.
Good morning to all. So I was in Liberia. We are almost, initially I used to say we're in the embryonic stages, but now we have given birth and we are have babies now as it relates to infertility specifically. So table of contents includes introduction, promoting what we are doing in Liberia, promoting healthy lifestyles for improved fertility, enhancing access to quality reproductive health care, strengthening education awareness, policy research, and collaboration, which includes public-private relationship. So as the previous speaker said, and Professor, and was also said yesterday, and Liberia is no exception. Advancing reproductive health care requires multifaceted approach. You have to holistically approach and address the individual. We noticed from our LDHRS that there is a decrease in fertility in the country. And what we have noticed that causing the decrease is it relates to education. We have a lot of a young lady now becoming educated. They are going to schools. We also notice that we have seen a lot of male trying to advance themselves, and it's taking time to get married, so they're not married, and environmental reasons as well as education, environmental reasons also contributing to the decrease in fertility. Also in the country, what we have noticed is that we have more young women becoming professionals. So they delay going and giving birth. Some, they are now having masters, they are banks executives. So they feel they have to delay giving birth before they now reach a certain age and wanting to have children. So what are we doing? We have a radio talk show. We started from having a radio talk show. So the Ministry of Health has a radio talk show that on Tuesdays, every Tuesdays, we have a different entity coming to talk to the population, and that radio station covers nearly all 15 counties that we have. We promoting healthy lifestyle. Like 2 weeks ago, we had an infertility specialist on a radio talk show promoting healthy lifestyles. We talk about balanced diet, avoiding harmful substances, how do they manage their stress, because when you go to work, there are a lot of stress at work, adequate sleep, because you have people in school and out of schools that are trying to make it to the top and they're hardly getting any sleep. Avoiding environmental toxins. We have these asbestos and other toxic substances that we have in our environment that we are now taking out of the homes. And regular timely intercourse, especially regular time intercourse in the villages and in the counties. We are using the health promoters as well as the community health workers to go in the communities and talk about healthy workforce, regular time intercourse. In Liberia, we have a huge community health workforce, and they are the ones that we talk to a lot. Sometimes people remain in the health in the communities, do not want to come to hospital because being stigmatized. So because of that, we use our community health workforce as it relates to reproductive health and as it relates to infertility. Male reproductive health, the men in our country feel that highlighting that they also have risk factor and they are also associated to infertility issues. They feel that it's a woman's stuff. They do not see themselves as being part of having infertility problems. So we are now encouraging men to come out to the hospital, as well as when the females are coming, for them to have some medication or assessment also. So at the Ministry of Health, what are we doing? We have the family health unit that we have now incorporated a person who is there specifically for infertility issues. And that person that is there, because I don't, in other ministries, I don't think that's happening, but for us, we have incorporated that. And it comes because I'm an infertility specialist, and I also have passion. There's this predilection for women and men who don't have children, so I've also incorporated that, and we So what are we also doing? Enhancing access to the reproductive health care. We now have improved health services, specifically as it relates to reproductive health and fertility. We have comprehensive family health services that is affordable and is accessible. We have early detection of treatment of STIs. We have maternal and neonatal care, infertility diagnosis and treatment, and preventive care and screening. For HPV, we have HPV vaccines that have now been incorporated into our routine vaccines, and we have also prostate cancer and screening that's been done. But what I want to emphasize here is that these things that we are doing is not only being done in the urban area, but also in the rural area. Policy, research, and collaboration. So we have now as I said yesterday, we have documenting and having a policy document for infertility. Also, we have a lot of policy document as it relates to reproductive health, but now we have having a policy document on infertility. We are working with partners, some international as well as local partners who have interest in sexual and reproductive health. We have
countries की जो first ladies हैं
also
Africa से,
spoken with the
it's
national
their
legislatures,
initiative, this
civil society
conference.
organization to promote interactive
That's
advocacy
why
meeting.
they were hoping
Currently,
that
we are
I'll
in the process, as I said earlier, in drafting our
In
first
fertility.
national fertility policy and strategy. Yesterday, when I spoke with the professor at our roundtable discussion, the IFFS, we met online yesterday. Some infertility specialists in the country, we met online yesterday to see how we can now become a member of the IFFS. We are doing IUI at the various hospitals in the country, the major hospitals, and we have had some successes that I did not bring to document. So at the JFK hospital, we have some fertility specialists there, public hospital that will do IUI. As it relates to the IVF, we haven't started yet. We have a private facility that has been established. As we were coming to Dubai, they were now bringing the instruments and the containers to establish an IVF center. So we are, for the past 16 months, I can probably say that we have made significant progress in formulating key strategies to promote sexual and reproductive health, and it's our desire that this comprehensive strategy can work towards a future where we have access to the needed fertility and reproductive health in the country. Thank you.
Thank you, Madam, for this enlightening presentation. We now have with us Professor Satish Kumar Adiga, Head Center of Excellence in Clinical Embryology and Coordinator at Center for Fertility Preservation, Kastuba Medical College, Manipur Academy of Higher Education, India. Prof. Satish has various path-breaking records and research to this name and aptly represents Manipur Academy, India, a highly valued partner for Merck Foundation. His first topic for the day is fertility preservation, how ART lab can involve in onco-fertility program. Over to you, Prof.
So very good morning to you all. First, let me thank the Merck Foundation for the opportunity to participate in this very interesting meeting. And this is my lecture. Is on oncofertility or fertility preservation. The fertility preservation is gaining importance these days because there is a rise in the cancer survivors. The credit goes to oncologists for their excellent treatment modalities. We have more and more survivors entering into reproductive life. Unfortunately, many of them experience difficulty in conception. But from the, as I said, from the fertility perspective, we are more concerned about the toxicity of the agents which are used in cancer therapy. They have a differential impact on the gonads. Some of the agents used in cancer therapy may be more detrimental, some of them less dangerous to the reproductive health. But it has been shown that these agents do act on gonads, both male and female gonads, because the gonads also have the proliferating cell population. For example, if you look at the impact of radiation on the testes, as you see here, the testis has both the proliferating and non-proliferating cell component. And if you look at the impact of radiation, the radiation is known to influence the germ cells. But what is important here is that the low dose radiation may not have any detrimental impact on the adult supporting cells, but in case of prepubertal children, the low dose of radiation is affecting not only the reproductive germ cells, but also supporting cells. That means there is a risk of gonadal failure. Even if the child receives a low dose of radiation, there is a high risk of becoming infertile. And this is one of the oldest papers, but still the value remains true. What it tells is that we are concerned about, okay, after the treatment, how much time does it take to recover, to come out of the toxicity induced by the cancer therapy? This is an oldest study which says that the sperm concentration, this is by the Mistrich, who has done a lot of work in this field. What his study says is that the sperm concentration reaches almost, they say, the normal, maybe in about, if it's about 18 months' time. And if the dose is higher, probably it may take more time. Maybe the radiation dose is higher, it may take about 18 to 24 hours, 24 months. That means by the end of 2 years, most of them come back to attain normal spermatogenesis. But what is important here is that we have to show you here, though it comes back at the time of maybe at 48 to 72 or 96 months, maybe about 4 or 5 years, the concern is that about 80% of them, the spermatogenesis become normal, but we are concerned about this 20% population. That means 20% of the individuals who receive this therapy may still remain infertile, azoospermic. So the fertility preservation plays a primary role here in helping these individuals who are at the risk of losing fertility. So similarly, if you look at the ovary, the situation remains same because ovaries also have proliferating cells, and as we all know that the ovulation, there are a lot of physiological changes happen during ovulation, like the proliferation, atresia, apoptosis is quite normal. But what happens if the patient receives chemotherapy? All these processes are accelerated. The accelerated process eventually leads to complete the destruction of the germ cells and supporting cells, which eventually leads to premature ovarian insufficiency, POI, or the patient may at the risk of losing fertility at the early time, at the early age. This is our own study. What we wanted to study here, what we looked at is that impact of cyclophosphamide exposure and its impact of long-term effect. This is done in collaboration with the Professor Richard Anderson from Edinburgh, who is pioneered in the field of fertility preservation, oncofertility. What we found here is that if the ovaries are exposed to cancer therapy, the impact need not have to be only immediate. It may be long-lasting. The impact may be seen on the ovary, on the oocytes, on the early embryos. In fact, there is the quality of the blastocyst and embryos are also significantly affected. So that means there is a concern with the exposure to the anti-cancer drugs or the cancer treatment. So this field of oncofertility has emerged. This is nothing but bridging the oncology and fertility. So I am going to discuss more about how the ART lab can involve in oncofertility practice. There are different ways we can help the individual who are at risk of losing fertility due to cancer therapy. The fertility preservation options in female, there are several options. The most popular one for the patient is a prepubertal girl. The recommended one is, or the patient is at the malignant disease, then the most recommended option is ovarian tissue cryopreservation or OTC. So this technique is almost established. The ovaries are removed before cancer therapy, and eventually they are processed, and then they are frozen by different techniques, which I'm going to discuss later. And if the patient is post-pubertal, and then if there is some time, then there is a possibility that you can retrieve the oocytes, and the oocytes can be frozen directly. The partner is available, then you can fertilize, make the embryo, and then you can freeze. So ovarian tissue cryopreservation is now no more experimental. It's a well-established technique. It is available for both pre and post-pubertal patients, where you can retrieve hundreds or thousands of primordial follicles. There is no medical delay. Sometimes oncologists always pressurize because they want to start the treatment as quick as possible. So in this case, you can retrieve. There is no medical delay. You can do the tissue retrieval immediately. There is no need of ovarian stimulation, and it doesn't require male partner because you are going to take out the ovary and process and freeze. But there is a surgical procedure. The ovarian tissues are retrieved surgically. Now the question is how it is going to help. How are you going to attain the fertility restoration? It's the most recommended way is by the orthotopic transplantation of the ovarian cortex, and there are several reports. There are more than 300 children are born through this transplantation. It's the most established technique. And if there is a risk of the cancer cell in the ovarian tissue, then it cannot be transplanted back, because that means you are reintroducing the malignant cell back in the patient. So then the option is take out the immature cells or the follicles and then mature it in vitro in the lab, then do ICSI and do the embryo transfer. So let's look at what are the laboratory considerations here. The number of patients, the handling and freezing media, because you require a special culture media and devices. So you need to procure it as and when there is a need. Many times what happens, you don't know when are you going to get the cancer patient, when are you going to get the call from the oncologist. Your lab should be prepared for this, because the concern is that the media you're going to use here also has a shelf life of maximum 3 months. And it is expensive. There are not many companies offer this media, so you have to keep it ready. If you don't get patient, and it just goes to waste. And preparation of OTC, again, keeping the lab ready. If you are a busy IVF center, it is going to be difficult because the processing of ovarian tissue takes a lot of time. You have to prepare the cortex and then freeze it. So lab should be kept exclusively ready for this purpose. And most importantly, there should be a coordination with the clinical team, because who is going to retrieve the ovarian tissue, whether it's a surgical oncologist or a reproductive specialist who is going to retrieve the ovarian tissue, the person should be aware that, okay, this tissue is going to be reused. So the precaution should be taken to minimize the damage to the ovarian tissue while taking them from the body. And tissue handling and holding, this is very, very important. You have to maintain the conditions. If the facility is not available in your city, you want to be very careful that the tissue should be maintained at low temperature. Ideally, the recommended temperature is 4 degrees centigrade. It can hold up to 24 hours. So if the facility is not in your city, you can take it from the other place and then it can be brought to the central facility. The processing and cryopreservation requires a special technical expertise, and most of the time embryologists do not know how to do the ovarian tissue cryopreservation. It needs a special technique. The person should be trained for this. And consent and storage agreement, this is very important. Who is going to take the consent? Normally the treating consultant is going to take it. And if the tissues are stored in a central facility, then there should be a storage contract, because the storage is not immediate here. The storage could be long term, maybe 5 years, 10 years, or 15 years. So the proper consent for the storage should be taken by the center. So this is our own study. We wanted to see how long tissue can be maintained in vitro. Suppose if the facility is not nearby, how long you can hold it at suboptimal or low temperature. And we have done a study in collaboration with Italian partners, and we have shown that up to 48 hours, the ovarian tissue can maintain the viability. The follicle viability can be maintained up to 48 hours. So if the facility is not nearby, no problem. You can use a proper condition. They create a box which maintains at 4 degrees. Use a right holding medium and can be brought back to your facility for preservation. So the question now is, what is the right way of freezing? Historically, people have used slow freezing. So far, the children who are born through this technology by ovarian tissue freezing through slow freezing. But now vitrification has become very popular. Vitrification is a rapid technique, so it is becoming popular. In fact, recently Japan has demonstrated a pregnancy with the vitrification technology. So we have looked into which is the better technique. This is not a new tech. The study we published long back in about 10 years ago, we compared slow freezing versus vitrification, which is better in maintaining the ovarian tissue integrity. And we found that the vitrification is superior. And now we know that vitrification is a popular technique. The meta-analysis, which has also shown that the vitrification is superior in maintaining the follicle integrity for ovarian tissue cryopreservation. And as I said earlier, in certain situations, if there is a risk of the malignant cell contamination in the ovarian tissue, it cannot be transplanted. Then the option is to do mature the follicle, take out the follicles from the ovary, the tissue cortex, and mature it in vitro, and then do ICSI. But there are certain challenges, especially when you take the ovarian tissue from a prepubertal girl. So the follicles are not they are completely different from the adult ovary. So you have to be extremely careful. When you grow this tissue outside, the risk of the ischemia or necrosis, because there is a less oxygenation, the size of the tissue is thick. So we developed a model. In fact, this is a prototype known as the perfusion bioreactor, which we did in collaboration with Italy, where this has a kind of this is a permeable dish. We keep the tissue cortex on this dish, which has the permeable oxygen supply, so the tissue integrity can be improved, and we can get good quality follicles, and oocytes can give good quality embryos later when the patient comes back to you for restoration. And now let's look at what are the options available for males. It is easy in case of adult males, because you know that the semen cryopreservation, the semen cryopreservation is the most established technique, and it is suitable for suitable for pubertal males and children in adolescence. And you can add as many as sample. If the oncologist gives you time, then probably you can ask the patient to collect as many ejaculate as possible, and you can freeze. It is not expensive. It can be done in any ART center. And the response rate is about 30% in our center. Suppose when you do an initial counseling to the patient that, okay, the oncologist refers the patient to you and you counsel the patient, it is not that all the patient comes for give the sample. There are several reasons for not producing the ejaculate. So we found that in our center, the response rate is about 30%. The limiting factor for the semen cryopreservation is the urgency to start therapy, because sometimes oncologist is in a very hurry. They don't have any time, say that, okay, I'm sorry, I cannot allow the patient to give an ejaculate, so we have to start the treatment. So in this situation, it is difficult. And also in certain situation, the patient has patient underwent surgery, testicular surgery, not able to masturbate, not able to produce ejaculate. And in certain situations, the patients, by the time they come to oncology, they're very weak. They have the erectile dysfunction, they're not able to produce a sample. So in this kind of situation, it is difficult. So the other option here is that you go for testicular or epididymal sperm cryopreservation. But many times what happens is, this is good for the patient with the obstructive pathology or if the patient has ejaculatory dysfunction. But the problem with this testicular aspiration is this invasive extraction. So sometimes the oncologist may not allow you to go for the testicular extraction. And very few sperm can be retrieved here. It's not that we get in millions. So the challenge is during fertility restoration, you have to handle only, you should be able to do something with the very few sperm you are freezing. And there is a risk of breaching blood testis barrier here and eventual complication. These are the issues related to the testicular tissue cryopreservation. So now let's look at the laboratory consideration with respect to the semen cryopreservation. It can be done by cryopreservation technique is well established, but the only thing is that we have to, they are very, very precious. We cannot do it like we do for routine infertility patient. We have to store them in multiple aliquots, which gives the opportunity for multiple attempts later when they come back to us for fertility restoration. And again, the patient counseling is very important. You should be able to tell about we should tell them about the cost involvement and how to collect the sample. And sample handling, as I stated earlier, the analysis with the minimum sample. We should not waste the sample. The minimum sample should be used for analysis and subsequently should be frozen. And as I stated earlier, the multiple small aliquot cryopreservation, the safe storage, because the storage is not for a short time. We may have to store for 5 years, 10 years, or 15 years. So we have to be extremely careful with the quality control of the storage device here and consent and storage agreement. These are the factors should be looked into during cryopreservation. So these are some of the devices which are useful when you have very few sperm available. You can directly place them on this kind of dishes and then vitrify them. Restoration will be easier. As and when there is a need, you can take them out directly and pick the sperm from here and then use it for ICSI. So these are the devices which are available commercially. And now as you all know that how much sperm we require for the fertility treatment, because it is not possible to use go for IUI, because as you know that intrauterine insemination requires millions of sperm. Here sperm are very, very precious and we cannot attempt IUI here. The recommended one is ICSI because we can use only one sperm for establishing pregnancy. So challenging option here is if the patient is a prepubertal boy, because as you know that spermatogenesis becomes fully established post-puberty. So in the prepubertal boys, if you look at the HRA guidelines, if the boy is a prepubertal, there's straight away you can take them for biopsy, testicular biopsy. There is no need of intraoperative analysis. The biopsy can be done and subsequently freeze the immature testicular tissue with the immature testis protocol. The protocol is different. And if the patient is pubertal, the borderline is about 12 years old, you are not sure whether he has sperm or not, then biopsy requires the intraoperative analysis. As and when the surgeon is doing biopsy, parallelly the embryologist look for sperm. If there is sperm, then probably you can directly take them for mature testicular tissue freezing. If there is no sperm or unlikely, then take them with the immature testis protocol. And if the patient has, the pubertal patient is able to ejaculate, then straight away you can take the patient for the normal semen cryopreservation protocol. So we wanted to see, because we have been doing it in our center since 10 years, and so far we have done about 50 prepubertal boys. I think we are the only center in the country offers the fertility preservation for the prepubertal boys. And we wanted to see whether the type of cancer is anything to do with the quality of the ejaculate, because there are concerns that the cancer may also compromise the fertility. So this is a study we looked at in about 14 patients with the type of cancer, and we looked at the spermatogonial number, and we also looked at the Sertoli cell number. But interestingly, we did not see any difference. What I want to tell you here is that with this data, there is no association between the type of cancer and the quality of the germ cells in the prepubertal boys. So, though this technique is available, there are certain considerations with the immature testicular tissue cryopreservation. One is that the facility is not commonly available, and patient counseling is very, very important, because you are counseling a kind of vulnerable patient. He's a prepubertal the boy. The counseling should be done along with the parents, and most importantly, we should be able to tell that this, and we should tell the patient that it should be purely experimental nature, because so far we are not successful in establishing pregnancy with the tissue, the immature testicular tissue from the prepubertal boys. It is still experimental, but we hope that when these boys come back to us after 5 years, 10 years, we will have the technology so that we will be able to help them. But remember, this is the only technique available for the boys who are at risk of losing fertility due to cancer therapy. So these are the possible options, because it can also be transplanted. You can take out the stem cells and can be transplanted, or it can be cultured and can be transferred to rete testis, and then probably spontaneous. These are just a speculation. But so far we are successful with the primate model which is done by the Pittsburgh group. They could be able to do the transplantation, and then they could be able to get this grady through this graft-derived monkey in the primate model, hoping that this will be successful in the near future. So these are the other possibilities of in vitro spermatogenesis. We can also derive sperm in vitro by keeping the testicular tissue taken, culture, and probably will be able to get the mature sperm and do ICSI. But again, we are successful with in certain animal models, but not in human, because passing through meiosis is very challenging process. So probably it takes more time to develop this technology. So what is important from the embryologist perspective, lab perspective, is that the technology optimizing the timing. These are some of the priorities: optimizing the timing, what is the right time for cryopreservation, how long we can hold it. Still, we need to work on this. The protocols still needs to be optimized, and optimizing the age range. We still don't know which age group is most appropriate, can give better outcome during fertility restoration. We need more data on this. And importantly, the quality assurance and testing. This is very, very important, because the storage is not for short term. The storage is for long term, 5 years, 10 years, 15 years, and we do not know what is going to happen to the germ cell during the long-term cryopreservation. So we need more data on this aspect. So in summary, the fertility preservation options, these are the techniques available, and these are the established technique. Most of the techniques are established except the deriving mature sperm from the prepubertal germ cell, and also in vitro maturation of oocyte from ovarian tissue or experimental, hoping that in the near future we'll be able to we'll be successful in all this technique. So thank you very much for your attention, and we have done a lot of work in this area in collaboration with the global partners. We are closely associated with the Oncofertility Consortium in US, and try to develop fertility preservation at various in various countries, and what is the right way of offering fertility preservation to our population. Thank you very much for your consideration.
Thank you, Professor Adiga, for this presentation. I would like to request the attendees to keep their question noted till the end of the session. Now, please welcome our next speaker for the session, Dr. Vipin Chandra from India. He is the Chief of Clinical and Lab Operation at Indira IVF, India's largest chain of IVF clinics. His first topic for the session is advances in the management of male infertility. Very interesting topic for discussion. Over to you, Prof.
Good morning, all. As always, I'll get a baton passed by Dr. Satish. And incredibly, this topic is like a sequence of, means what he has told is about cryopreservation in case of an onco. But a step earlier, there can be a lot more can be done for those who doesn't need a cryopreservation. And there also, uh, till now, nothing much was there. In the recent decade, in last one decade only, lot many evaluation and revolution has happened up in the management of the male infertility. I'll just walk you through what all has happened up in the recent past and which are giving a good outcomes in those cases where where we thought of that these are the cases where donor sperm is the only choice, where patient won't be thinking about, and doctor also not counseling about their own biological use of sperms. So to begin with, male infertility is in rise. Why we are discussing? Because as you can see, with every decade passing by, male infertility is increasing because more and more often we are diagnosing difficult cases, and because of the other reasons also. And varicocele, and you can say these are the more major causes, and you can see varicocele is a major one, idiopathic are also the major one, obstruction, cryptorchidism, and testicular failure. Out of these, varicocele is repairable, we all know. Idiopathic, there are some medical managements are there. Obstruction, all you must be practicing in time, and it's a well established, there is a TISA and PISA for obstructions, and there is a reconstruction surgeries are also there. What we will be focusing on today's topic is about testicular failure and cryptorchidism, because these are the one which were been not being dealt in a proper way, and there was only solution for these kind of cases were donor sperm. Going forward, I always begin my slide where you I want you all to stick to a routine protocols. We should not bypass and just jump onto the final treatment to be advised. Everything should be meticulous as we do in our medical practice. There should be a clinical history, there should be proper physical examination, and then after that go for semen analysis. And also again in the semen analysis, don't jump to the conclusion by just seeing one report. It may be abnormal. If it is abnormal, definitely ask the patient to go back. If the person is on any steroids or anti gonadotropic toxics to the testicular sperms and all, so those could be removed and stopped. Thereafter, call up them for after a week or two, get the semen analysis done, and then define whether it's really abnormal or not. Exclude once, even if it is abnormal, exclude whether there is a gonadotoxic agents are there, and do endocrine evaluation, do additional testing in form of a genetic evaluation, ultrasound, and testicular biopsy. I'll want to emphasize on testicular biopsy. People on urology, they often say that do testicular biopsy before deciding about the treatment. But I say here, now this is not the way one should treat it. Testicular biopsy is only limited. I'll tell you in the algorithm later that now the testicular biopsy has a very limited role, and only in cases where we are not able to exclude the cause of testicular failure. Otherwise, there is no role of testicular biopsy. So basis this, once we know that there is an azoospermia, which we call it as a testicular failure, we'll divide them into obstructive and non-obstructive. How to divide? On the basis on the physical examination itself, we can do some little bit of a division, but there is some overlapping. Testes which are normal size, where epididymis is normal or enlarged, vas deferens is palpable, non-palpable, then this is really an obstructive one. In case of a non-obstructive, we can go for, we can again divide between where there is a spermatogenic failure or there is a hypo, means there is a HPO excess which is involved, and that is leading to the end organ failure. So in case of an hypo, again there is a clear-cut way you can able to exclude, because testes will be small, epididymis will be small, and vas deferens will be palpable. But where is the problem? Problem lies in area of the spermatogenic failure, because it's overlaps between the two, and testes can either be small, can be normal, epididymis can be is usually normal, and vas deferens is palpable. So basis this, again, once you have done the physical examination, next is to do the endocrine evaluation. So who are the candidate where endocrine evaluation should be done? Wherever there is a sperm concentration less than 10 million, where there is a erectile dysfunction, hypospermia is there, or there is a sign and symptom of endocrinopathies, along with any case of azoospermia, definitely. So minimal investigation which you should do for endocrine evaluation is FSH, because it tells you about the germ cell activity, serum testosterone level, total serum testosterone level, because it tells you about the Leydig cell activity, and E2 help in managing the NOA. How it helps you, I'll come back to you. Free testosterone and LH and prolactin only in case where you are not able to distinguish between the various kind of NOA, then it only required. Otherwise, for initial assessment, FSH, T2 and testosterone and E2 are enough. So basis these investigation, first of all, these investigation are all these hormones have diurnal variations. So best is to do these tests early in the morning around 8 to 10. So to have a standardized values. Now in case of an obstetric azoospermia, FSS definitely will be normal, LH will be normal. When I say normal, it should be between 1.2 to 1.5 to 7.5, 6. LH will be in the same range. Testosterone, which is normal, when I say normal, it should be more than 300 nanogram per deciliter, going up to the 800 nanogram per deciliter. In case of a hypo, again there is a clear-cut diagnosis you can make out basis the hormone values, because there is a HPO axis which has gone wrong. So there is no GnRH, no FSH and LH. So FSH LH value will be less than sub-physiological values. And since there is no LH FSH, they are not acting on the end organ, which is the testes, to release the testosterone. So testosterone will also be the low. So this is a clear-cut diagnosis. But again, just like physical examination, spermatogenic failure, here also in the hormonal assessment, still there is some little bit of gray area. Because FSH can either be elevated, which we usually think as per the physiology, that for testicular failure, FSH will always be high, but it can be normal. LH again can be normal, can be elevated. Testosterone, usually it should be low, but it can be normal. So again, there is no clear-cut distinction for spermatogenic failure. And that's why it's difficult to treat a patient with a testicular failure. I'll just summarize quickly on the requirement of genetic testing, because these genetic testing helps you in individualizing which patient to be offered medical management or should be put under the knife, which should not. So for obstructive azoospermia, CFTR mutation karyotype is enough. For hypo, only karyotype is okay. If patient is willing, definitely we can go for whole exome sequencing to know any specific mutation which causes the suppression of HPO excess. But in case of a non-obstructive azoospermia, we should do karyotype along with the Y microdeletion. And in case of a Y microdeletion, we have to focus on the 4 foci, AZFA, AZFB, AZFC, and AZFD. If there is a deletion in A and B focus, then definitely these are the end patients where you won't get any, you cannot expect any kind of sperm retrieval even after medical management or even after the micro TISA also. So for AZFA and FB, only way is to go for donor sperm. But for AZFC, the successful retrieval is possible in almost 60 to 70% patients. So these are the group of candidate which will which can be offered medical management, and they have the ray of hope through the medical management and the micro TISA. See, this is, we have already summarized obstructive, non-obstructive, spermatogenic hypogonadism, and that's how they should be classified. Now, in case of an obstructive azoospermia, we know that there can be congenital, acquired, and idiopathic, and treatment available. We know there is a reconstruction surgery is available when it is, we can do directly sperm retrieval. In case where it is not treatable through the and reconstruction surgery, then again we can directly go for the sperm retrieval. And these sperm retrieval have got a very good prognosis. As you can see, almost 90% of the patency can be achieved through the reconstruction surgery, and almost 60 to 70% patients after reconstruction surgery can achieve natural pregnancy. But if it's not, the reconstruction is not possible or is irreversible, then we have a sperm retrieval techniques, and most of the sperm techniques have got a very good prognosis, close to 100% in case of an obstructive azoospermia. But what should be the choice of sperm retrieval technique? Now, if you want to harvest for certain reason, say for future, then definitely MESA is the possible way. Otherwise, PISA can also be the possible chance. If you are not comfortable with the PISA and MESA, then directly TESA and TISA can also be done. Those are more easily be done. This require a little bit more expertise. But if you want to harvest and cryopreserve sperms, then only option is the best suited option is MESA, because it's 100% cases you can be able to get good harvest which can be cryopreserved. And pregnancy outcome is as good as donor sperm. So for those patients who are having an obstructive azoospermia, it's a crime to go for donor sperm. If you can't do, or your colleague who is an andrologist cannot do a sperm retrieval, please refer them somewhere. But don't do this crime of prescribing and offering donor sperm to obstetric azoospermia cases. Now let's come to a difficult ones, which is hypo. Now I say this is difficult in the terms of management only, because it requires patience from the clinicians, patience from the doctor, from the patient side also, because it needs at least 6 to 9 months to achieve good outcome in these cases. But they have a very good prognosis if being treated properly through medical management before, and majority of them, if being treated properly, will eventually get sperms and ejaculates. Otherwise, sperm retrieval is always be possible. So how to way go forward? Again, these can be congenital, acquired, and idiopathic. In congenital one, Kalman and Prader-Willi syndromes are the most common, which you can evaluate through their sign and symptoms. Acquired one, because of the surgery, exogenous steroids, systemic diseases, all these you have to rule out before going for a medical management. Now this you have to divide to come to get out a best prognosis. You better evaluate and distinguish them into prepubertal and postpubertal. Prepubertal definitely will be the congenital one. Postpubertal will be most likely be acquired one. Now in case, as you can see here, the prepubertal will not have any kind of any sign and symptom of the secondary sexual characteristics. The penile, the scrotum are of a infant only. While in the post-pubertal, there will be some sign and symptom of androgen activity. And that's how you can distinguish between the prepubertal and postpubertal, because the treatment is dependent on them. Now, so in case how to treat hypo, the basically since there is nothing is coming from HPO excess, one solution is to replace the GnRH. Okay, so GnRH pumps are available, but again there is a lot of non-compliance are possible with the GnRH, and the cost is also issue. And since we have to give it in a pulsatile way, any discontinuation or non-compliance will jeopardize your whole treatment. So the better treatment is, and which is more compliant, is replacing the directly end organ hormones, which will act on the end organ, which are going to drop in. Here, as I said, prepubertal, postpubertal. Prepubertal will be a difficult one to treat, and there we should start with the double therapy, which is HCG plus FSH, recombinant FSH, in a doses of 1000 HCG in 1000 to 2500 IU twice a week for 8 to 12 weeks, and FSH in doses of 75 to 150 IU 2 to 3 times a week up to 18 months. Whereas in case of a post-pubertal one, HCG monotherapy should be the first choice. If they become refractory, then we can go for the combined therapy. But it needs almost 6 to 9 months to get the best outcome out of these two therapies. So you have to wait at least, and you have to be patient enough. You have to counsel properly to the patient also that they have to be compliant with the treatment for at least a longer duration to achieve a good prognosis. And you have to give them a ray of hope by saying that almost 90% of the patient can achieve sperm, can have a restoration of spermatogenesis, and even can have ejaculates, sperms in ejaculates. But if not, then definitely once you achieve the desired hormone level of FSH, LH and testosterone, after 6 to 9 months, you can go for micro-TISA in such cases. Now, difficult one is non-obstructive azoospermia, where there you feel like there is a spermatogenic failure, testicular failure. And we all have discussed that these has to be individualized before going into any kind of management. Don't do that. Yes, anybody can be taken up for the medical management. Those who have a AZFA, AZFB, they should not be taken up for the medical management. Only AZFC should be taken for medical management. And as I said, in those cases also, collectively all focus microdeletion together, 50% possibility is there. But for AZFC, it's almost 70%. Now, how to do? As I said, you have to do microdeletions, why microdeletion, and then come up. Now, as we can see, what is the basis physiology and pathophysiology why we wanted to do the medical management in case of an NOA? For normal spermatogenesis, we know that there should be high intratesticular testosterone level, which are essential along with the FSH for the natural spermatogenesis. Now, for these, FSH is coming from up, and Leydig cells is giving us a testosterone. Now, since in case of a testicular failure, we already have a very high FSH, so we don't need FSH as such. There is abundance of FSH in the system. What we need is now high intratesticular testosterone. Now, to achieve that one, we know HCG, which has a subunit of an LH, can act on Leydig cells and increase the testosterone over there. So that's the approach over here. So always the base, once we do a HCG in therapy, we have multiple studies have shown that before and after, there is a significant increase in intratesticular testosterone level, and which will increase the DNA expressions also in the germ cells, which will anyway it ends up in giving you the sperms thereafter. We'll come to this in individualization. We have another topic on individualization of the treatment management. I'll come to on this slides in my next topic. So how to go ahead with the treatment of NOA? Definitely, you do LH, FSH, and testosterone and E2s, and then divide, and then starting dose should always be HCG as we discussed. So this is the start always start with SCG, which should be 1000 to 150, 1500 IU. Then keep monitoring every month LH, FSH, testosterone, and E2, and add on aromatase inhibitor or recombinant FSH as when required. When is aromatase to be added? When the T by E ratio is less than 10, and FSH to be added when the FSH, serum FSH values goes below subphysiological, which is less than 1.5, 1 or 1.2. So I'll directly come to a live example. So this is a case who is a 46-year-old idiopathic NOA with a history of previous negative sperm retrieval by TESE. And these were the baseline: FSH 32.6, LH 8 very high, LH normal, testosterone 194 less than 300. So what should be done? We should have started HCG. And we started HCG, kept it for 4 weeks, and after 4 weeks of 1000 IU of SCG, now FSS has come down. Why FSS has come down? Because SCG acted on the Leydig cell, testosterone has increased, given a negative feedback, FSH has come down. FSH has come down, testosterone level has increased. We continued with increase because this FSH is still a little bit on a higher side, testosterone is okay, so we increased the dose, gone up to 1500, kept it for the 4 weeks, and this is how the values are. Now again further FSH will drop down. As you can see at the 16 week, FSH value is 0.6, LH is 0.1, and testosterone is 487. So this is the time FSH is below subphysiological, added FSH, and after 24 weeks of LH-FSH combined therapy, these are the achievements. And in this case, we achieved spermatogenesis. Another case, cryptorchidism, which are difficult to treat, but if test has been brought down at time level at a proper time, though it's in a 28 weeks, where karyotype is normal, there was no microdeletion because it's a case of a cryptorchidism. Hypertrophic testes, very small, 8 cc, FSH is high, testosterone is low, and multiple agiospermic specimens were done after and been declared as agiospermia. Diagnostic TISA were done, which should not have been done, but there was a rare motile and abnormal sperm. And in these cases also, as you can see, we started with since FSH was 11.6 and 180 is the testosterone, we started with SCG. Testosterone has increased, FSH has come down, added FSH at a proper time, and then after almost 24 weeks, we saw sperms in ejaculates, and then we did a ICSI, and the patient achieved pregnancy after this. Something more to be added: wherever there is a NOA, always evaluate for varicocele, and if varicocele is there, definitely it is always good to treat varicocele before the medical management, along with the medical management also, and then you can achieve better sperm retrieval with these. And what should be last thing, what should be the surgical retrieval technique in case where there is a medical management is done for NOA? You can do TISA, you can do TESE, but the best is the micro TISA because the sperm retrieval possibility chances are almost 60 to 70% in case of a micro TISA. And within the when you are doing micro TISA also, you can prognosticate the cases basis the diameter of the sperm tubule, and those sperm tubule which are having a diameter of 250 plus of micrometer, those are the tubules which should be picked up and taken up for the wincing, and where those only the spermatogenesis should be going on. Lesser than that, there is no meaning because spermatogenesis may not be going. So this is a whole cycle. You take up open up the testes. As you can see over here, there are two kinds of tubules. One are fluffy, healthy, pink, and a little bit thicker one. Those are the minute one, which will not give us any spermatogenesis. Will not be able to retrieve sperms because spermatogenesis will not be going over there. Go give it to the embryologist. They will mince and give you sperms from the healthy tubules. This is the whole algorithm which you can follow in your protocols, and as I said, diagnostic TISA is not a mean now, only in case of an undefined cases. That's all from my side. If any question, we'll take it up later on. Thank you.
Thank you so much, Dr. Vipin, for this wonderful presentation.
Thank you. I would now like to invite our next speaker, Dr. Rinois Sridharan. He's the Chief Infertility Specialist and Executive Director at Indira IVF, India. He will be presenting the topic, New Guidelines Management of Patients with Recurrent Miscarriage, a very crucial area in the obstetric field.
Hello, good morning, everyone, and thank you to the Merck Foundation for giving me this opportunity. It's a pretty vast topic, and it's something that we've all been faced with at the beginning of our careers, I believe. Because if you're doing even a general gynec practice, let alone your particular infertility practice, you are going to face this situation. Many times we are left with the question is what to do next, and what will work for this patient, what will not work. Many a time the cost constraints is something that comes into picture when you want to manage this situation, whether it be with regards to testing or whether it be with regards to the medication. And there is a lack of clear guidelines, though a lot of guidelines have come up. Some of the bodies like ESHRE, ASRM, they have given us guidelines to work with. But what we need to understand is, at least in my country, healthcare is not insurance driven. Most of the things are not covered by insurance when it comes to fertility or even managing pregnancies. So we have to cut our coat accordingly, means according to what we have available, and then proceed. So, yeah. So I'm Dr. Rinois Sridharan. So how do we define this recurrent pregnancy loss? So you've had a loss of 2 or more pregnancies, and primary is when there's no previous viable pregnancy, no heartbeat, and secondary is if you've had at least 1 or more pregnancies, losses with a heartbeat. And some studies say that there's a 1% prevalence, some say that's a 5%, it may vary population to population, and correct identification is key. The most important thing according to me is psychosocial support, that you have to reassure the patient that there have been this ample evidence available that many couples who have had recurrent miscarriages have continued and gone ahead in their reproductive lives and have had live births, some even without treatment. Sometimes we just equate it to stress. It might be due to some environmental exposure. We shall see some of those factors. So if any of you wants to set up an RPL clinic, some of us have RPL clinics back in our country. So you need to have courteous staff who will not basically shout back at the patient or who will not be rude to the patient, because they're already hammered by what they've been faced with. And this should be the last of their concerns, that someone is speaking to them in a very bad manner. So I believe that good staff is one of the main things that definitely helps in the patient to relax. Then you need patient listening, you need an excellent ultrasound and facility for lab tests, because there are quite a few tests that are involved in the management of RPL. You have to choose your test according to what information is available. Individual evaluation is necessary, because you cannot have a blanket approach to RPL. It's not that I like this kind of test, so let's get this done for all the tests. You need to have a individualized approach. Psychosocial needs must also definitely be considered. So let's quickly go back to the evaluation of the risk factors. So before this, I'll just say that counseling is something that is paramount in these RPL cases. And for sake of giving respect to the time, I would just ask everyone to pay attention to the letters that I've put in bold, because there's a lot of information that is as such over there. So when we consider age, so your pregnancy loss risk is lowest in the 20 to 35 years. Once you're reaching 35, that is from when it starts to increase, and beyond 40, it is very high. Exposure to environmental and occupational factors, yes, I believe Professor Edim was telling yesterday about how when there were people who were driving their cars barefoot, and that could lead to exposure to certain certain metals or minerals which may not be conducive for pregnancy, and which may lead to pregnancy losses or infertility. So environmental occupational factors. So the history has to be taken properly, whether the patient is working in a chemical factory. We've had patients who work with some of the big corporates for, they work in perfumeries. So that many a time we have seen that they consistently have very bad oocyte quality. Fertilization rates are lower, and we see a higher rate of pregnancy losses in them as well. Stress, of course, but with respect to stress, that we do not know whether that is a byproduct of the pregnancy loss, because by the time the patient comes to you, or we don't know if that is the cause for the pregnancy loss. So the odds of moderate to severe depression was more than 5 times higher in these patients. Next, chronic endometritis. This is mostly a hysteroscopic diagnosis that we see as more and more hysteroscopies are being done all over the world. We are adopting this. So chronic endometritis, again, how to manage it. Of course, we all have probably studied that you give a blanket course of doxycycline and metronidazole for maybe 10 to 14 days, 14 days preferably, and this will help you with most of your reproductive tract infections, but that's not always the case. There may be specific organisms as well. So we've seen there are certain studies which says that the vaginal microbiome is very important. So as a protocol, we have addition of probiotics to all patients who are undergoing IVF treatment at our clinic. Why? Because definitely there is some role. You do not always need antibiotics. You should give probiotics. Prevention is better than cure probably. Antibiotics were found to reduce endometritis with an improvement in the live birth rate in some studies. Health behavior modifications, then you have recommendations regarding smoking. Yes, smoking can have a negative impact. So smoking can definitely have a negative impact, so it's better to ask your patient to refrain from smoking. Then this is something with regards to endometrial deserialization and senescence, basically how the endometrium gets developed during the pregnancy, and what about the aging of the endometrium. So you have there are 3 or 4 theories with regards to this. So one is there is reduced recruitment of the bone marrow derived decidual precursor cells, which may be responsible. Then increased frequency of cycle with more of old cells, senescent cells, which is associated with RPL that has been demonstrated, and you try natural killer cells, variability and function. So these fluctuations in these have been shown to cause recurrent pregnancy losses, but again, it's not a one-size-fits-all theory. And there is a lack of clinical biomarkers, one which you can apply to all patients to study this. Smoking we covered. Next is obesity and recurrent pregnancy loss. Now, in terms of, we normally consider that up to 25 is like a normal BMI, but probably for the Asian population at least, we consider that anything about 23 we need to have a look at it, and 27 is probably where you would say 27 or beyond. From 28 onwards we'll say that the patient is obese, though normal categories is about 30 is where we say that they are obese. Now couples with RPL should be informed that maternal obesity or being significantly underweight is associated with obstetric complications, and of course your LBR is going to go down, and striving for a normal healthy BMI is something that we should definitely work towards. And if you do weight loss, your general outcomes are improved. Caffeine intake, yes, coffee is dear to us all, I believe. So coffee intake up to 200 mg per day is what is advised. There is no clear consensus on this. So how much is actually a cup of coffee with of 12 ounces? That would be your, if anyone has been to Starbucks, that's your tall glass, 4 by 5 inches by 3 inches diameter. So that's the 200 mg per day. Preferably do not cross this for those patients, probably for anyone in pregnancy. Exercise, there is lack of direct evidence in RPL. General benefits are of course there. I wouldn't say that they should not exercise, and there is a mixed evidence. So basically the thing is you should refrain from high intensity physical work. I guess there's not much scientific thing to that. Alcohol, of course, it increases the alcohol increases the risk. If you have regular drinking of more than once a week, that increases your odds of getting pregnancy loss. Your paternal alcohol and semen quality. Now, this paternal alcohol, the semen quality is something that was always something that we always overlooked. Like with time, I'll be covering that as well. That is DNA fragmentation index. More and more evidence is emerging that DNA fragmentation index is definitely it definitely has a role to play in the recurrent pregnancy losses. So paternal drinking, it was seen in one study, is associated with early pregnancy loss. Now couples, we know about the fetal alcohol syndrome as well. Unclear risk factors. Now, sex during pregnancy, there is actually no evidence, and what is advised is it's not evidence-based, but avoidance, it may lead to guilt also in the couple, and the couple should probably talk to each other about it rather than we recommending that to not do this. Soft drugs like cannabis, there's no proven link with RPL, but of course, I think as all of us as doctors would probably tell our patients to stay away from any sort of recreational drugs and rather to practice maybe like meditation, going for a walk or some light exercise to relieve their stress rather than using cannabis. And radiation exposure, yes, high dose radiation. So when we talk about high dose radiation, I think that would be with regard means what we try to mean is actually probably a CT scan, but not a normal X-ray. So we get this presentation very commonly in the clinic where the patient has undergone an X-ray for a low backache somewhere maybe 2 or 3 weeks into a period, and she'll miss her periods, and she'll come and ask me, I've missed my periods, I got an X-ray, so I think I need an abortion, right? So that's not the norm. The amount of radiation that's there in a normal X-ray is very low, somewhere around 5 centigrade, so that should be very low, and there's no need for that. So clinicians should explain that there's no evidence that sex or imaging increases the miscarriage risk. Now this is the important part, that is investigations in RPL. There are too many investigations that you can do for a patient for RPL, and you need to understand which one would probably work for which patient. So we'll go through some of those investigations. So most important factor, what we have studied in our in our post-graduation is that genetic factors is what gives rise to pregnancy losses. And I believe that this gives rise to the maximum chances of pregnancy losses. So 86 to 91% of early miscarriages show morphological abnormalities, and they may be sporadic or there may be recurrent losses. So it is possible that one time the patient had a loss because of one reason, the other time it might be because of another reason. So that makes treatment all the more difficult. Sometimes causes may coexist as well. So chromosomal abnormalities is prevalent in miscarriages found in nearly 45% according to some studies. So there are various types of testing available. There is karyotyping, there is FISH. This is, I'm talking about the POCs, the FISH, the array CGS, NGS, SNPRS, lots of technology available. Costs are also pretty high, but what the recommendations say is array CGS is probably what is preferred. And the clinical strategy and limitations are that karyotyping the second miscarriage tissue may just help you guide for the next steps. It will not necessarily predict the future. It will just guide you a little bit as to what could happen the next time. Now, parental genetic factors, abnormal parental karyotypes may be found in 2 to 3.5%, and carrier couples have lower birth rates, but prognosis remains generally favorable. And higher loss reciprocal translocations and inversions versus Robertsonian, and in the unbalanced translocations, it will be more common. One important thing that this is just a clinical note that we have noticed in our group. So we have these patients who have had recurrent pregnancy losses. You've done your PGTA, you've transferred them, they're still having pregnancy losses, all other causes ruled out. You've done your immunotherapy or you've done your immunological investigations, you've done the thrombophilia profile, and in your KT, there is just a normal polymorphic variant of some chromosome in the father or in the mother, and the patient has recurrent pregnancy losses. We have seen that many times. Despite all the best that we can do, these patients continue to have recurrent pregnancy losses. They will conceive beautifully, they'll have a good beta HCG value, but they do not continue. And some of them have actually done better by actually going with a donor sperm or a donor egg in those cases. I'm not recommending them, but this is something that could make the difference, because genetics, even though we had mapped the genome somewhere as early as 2000 by Sanger and Celera, but there's a lot that we still have to learn in terms of the implications of all the changes that happen in the genes. And what is normal, we do not exactly know completely, and what is a normal polymorphic variant, these are just many times assumptions. Now coming to the hereditary thrombophilia screening. Now this is where it gets a little bit costlier, the thrombophilia screening. So the cost for these tests, they usually means they may cost anything between say $100 to $200 at least for doing these tests, all the thrombophilia. So you have the factor V laden, we read about the mutations in the factor V laden and prothrombin, but both these mutations are actually weakly associated with mutations with no evidence which says that testing improves outcomes. So therefore, please do not do this as your first thing. Next is protein C, protein S, and antithrombin. In the cascade of testing for thrombophilias, probably you should keep them at the very lower end. And postpone testing until 6 weeks after pregnancy loss. Many a time when the patient comes to us, we are at this we have this thing that how do we perform, what do we recommend to them, that what test do we need to do, but refrain from any testing, counsel them that we'll have to wait for a few weeks before we actually go ahead and test it. What about hereditary thrombophilia screening in MTHFR? Again, no consistent link. When we go to the clinical recommendations, so therefore ESHRE says that routine screening is not advised, and only if there is a strong family history. Yeah, now this is the pet topic, that is the acquired thrombophilias. Yes, we definitely need to screen for the acquired thrombophilias. You have LA, ACA, that's lupus anticoagulant, anticardiolipin antibody, and your beta-2 glycoprotein. And you can screen for them. Testing after 2 losses is reasonable. That means it is definitely not a bad idea to check it. And lupus anticoagulant with RPL before 24 weeks has a good response, and ACA, IgA and IgM is linked to RPL, and beta-2 glycoprotein is findings are less consistent. But what is the recommendation for this? LA and ACA, that is part of the APS panel. Testing can guide APS diagnosis and reduce the risk of RPL, so therefore there is no harm in testing for this acquired thrombophilias. Test after 6 weeks post-loss and confirm after 12 weeks. So again, that's at added cost. So probably means what we usually advise is you go for testing maybe after 8 to 12 weeks. Another thing that commonly comes positive is ANA. We'll be going to that as well. Yeah, HLA screening. So basically, what is HLA? That is a human leukocyte antigen. Pregnancy is not just about estrogen, progesterone, and the implantation and the genetics. It is also related to immunology. So that's where your HLA comes in. And HLA determination in RPL is not recommended. And only HLA class 2 determination is has been shown to have some benefit. Anti-male specific minor histocompatibility antigens, again, no need to test them. Yeah. Cytokines. Now, again, when we talk about recurrent pregnancy losses, we have to look at TNF alpha and interleukin 10 and their ratios, and they are linked to miscarriages and euploid losses. And higher TNF alpha in secondary versus primary, this is also something that was studied, and we saw that there were higher levels. TH1, TH2 imbalance, T helper cells 1, T helper cells 2. You don't need high or low of either of them. We need a good balance. So you have the pro-inflammatory T helper cells higher value, then you are likely to get a miscarriage. Now, routine cytokine testing again is not recommended and useful only in research. We do it only in those cases where the patient has done all the tests and they've come out negative. That is when we actually go ahead to this battery of tests. Anti-nuclear antibodies, again, one of the favorites of fertility specialists. And this is something that persistently we see so many reports, patients coming with ANA 1:32 and low ratios saying that we have ANA positive. So what is the outlook for our current and for the next pregnancy? So what we need to understand is that ELISA-based testing is not very useful. I have n number of cases where the ANA test was positive. Patient is worried, oh no, what will happen in the rest of my life? You actually need to go for the immunoblot testing, which could actually tell you what is the actual ANA status. You need to look at the subtypes of ANA, and many a times it is negative. I've even seen obstetricians doing ANA testing during pregnancy, which is absolutely not when it should be done, because pregnancy itself has a change in the profile of thrombosis, and therefore you should never do it during the pregnancy. So, and anytime you want the confirmation, you go for immunoblot. Again, immunoblot is a costly test that again costs somewhere around $100. So that these are some of the things that limit the usage of these tests. So ANA testing, it may help to identify a subgroup of RPL patients, and however, we need more research regarding these. Peripheral blood natural killer cells, endometrial decidual NK cells. Now, these are all things that you will put lower down the spectrum. These are not your initial investigations. So evidence is inconsistent, and routine NK cell testing is not currently recommended. Somewhere early in my career, I used to do some amount of NK cell testing, and believe me, it gave no benefit in terms of treatment. Anti-HLA antibodies, meta-analysis found that there's no significant effect, and celiac disease markers, again, slightly high IgGs in RPL, but testing is not advised unless there are GI symptoms. You cannot just blanket test all these patients just because you're looking for what test can I offer to this patient. The rest, all of the tests have been done. This is not how you should deal with it. Next is anti-sperm antibody. Again, routine testing not recommended. Other immune biomarkers like IL-2, anti-protein Z, anti-protein complement activity, please limit them when you're actually doing some research. Otherwise, these again are not to be done on a daily basis. Thyroid dysfunction, yes, hypothyroidism is linked with complications like miscarriage, but no direct link to RPL. Of course, you should correct it always before proceeding for your next pregnancy, whether that be in the form of giving antithyroid medications or whatever. And hypothyroidism subclinical outcomes are not consistently worse. So there is higher prevalence, but do not deal with it in that way. There is thyroid autoimmunity, which is associated with RPL. So I'll just we had seen this case about 4 or 5 years ago. The patient had around 4 IVF failures, and they just come to us for an opinion. We checked for thyroid autoimmunity, and we get some medication for that, basically correcting it. And we put her on a mild dose of steroids. I'm not saying that that works always. And we did something that is called as immunotherapy. And this patient conceived naturally in the, I think, around 8 weeks later. So immunotherapy is something that we are working on as a group, and we'll be soon presenting evidence at one of the world congresses. And I think then it will, we are hoping that it will begin to be seen as a standard of treatment, though, and Dr. Vipin is the person pioneering this immunotherapy in recurrent implantation failure. So it might help. Definitely, we use it even for the recurrent pregnancy losses. So TSH and TPO antibody screening is recommended. You can do it definitely. And abnormal TSH levels, you should do the management. Next is PCOS and insulin metabolism. Actually, they have worse metabolic profiles and they may serve as markers. However, assessment of PCOS, fasting insulin levels, and the FBS is not recommended. If you actually want to study, maybe you can have a look at the HOMA index. So, yeah, time. I know that time is okay. Hyperprolactinemia, again, testing is not routinely recommended. Diminished ovarian reserve testing, again, that's not routinely recommended. If it is just, you have to assess it based on the age criteria, how old is your patient, that will actually tell you how to manage this. Luteal phase is insufficiency, again, that is linked to PCOS, prolactin disorders, and your stress levels. But again, routine LPI testing is not advised due to limited clinical value. Then you have other tests, that is hypohomocystinemia, LH levels, all of these are not required. Sperm DNA fragmentation, yes, definitely you should test it. Use a good lab, probably the SCSA method if available. Otherwise, you can at least use the kits which are available, the HALO test, which you can use to see DFI. I think all the practicing reproductive specialists should definitely do this test. And treatment for RPL with genetic background, your PGTA, PGTSR, it might help. Genetic counseling you can do in indicated cases. Then for the treatment part, if we come to it, RPL and thrombophilia, anticoagulant showed no benefit, though I will confess I do use it. As a treatment, we are studying it. Steroids, no benefit. Folic acid and vitamins, it might help. For antiphospholipid, for antibody syndrome, you can use low dose aspirin or LMWH, probably use it in the dose of 1 mg per kg. We give a dose of around 60 mg per day in the cases of RPL with this. So overt hypothyroidism before conception, you will of course treat subclinical and RPL patients. If they are pregnant, then check the TSH again, keep monitoring them. Uterine anomalies, the metroplasties that has been mentioned are actually for the bicornuate, or what is called as a bicorporeal uterus now with a single cervix, or the didelphys, or the bicorporeal with double cervix. Please do not do any metroplasty for them. They, without those things, there is evidence of pregnancies going till at least 7 months. So you can take them up to 7 months and then deliver them, rather than going for something as ghastly as a metroplasty. Polyps, only if they are more than 1 centimeter, you have to remove them. If fibroids, it may help in removing. Additional-lysis, it may help. Cochrane review found that cervical insufficiency, there's no benefit of prophylactic cerclage. I do not totally agree with this. I work in what is just slightly better than low resource setting, and for us, if there is cervical insufficiency history, I am going to put a cerclage. We are going to put a cerclage. We are working on evidence for this, and I believe most of us who do not have access to very good NICU facilities where your baby can survive at maybe 24 weeks of pregnancy, getting this size of a baby out, maybe 400 grams, 500 grams, it is very glorious when we read about such things, but we also need to look at the fact that that if this pregnancy could have been carried to maybe 30 weeks of pregnancy, you would have a better child. At 24 weeks, what obstetricians or what common people often miss out is at 24 weeks, you have very less chance that the baby is going to be neurologically normal. There is very good chance that there will be some neurological abnormalities later on during life. So with this intervention, you could actually take them forward. Rest is smoking and obesity. Yes, we know that smoking is linked to DNA damage. So definitely cessation of smoking, medications like you should go off certain medications, varicocele, it may help. Sperm selection, PIXI has not been actually shown to improve. Antioxidants and diet, yes, healthy diets and antioxidants may help, but there is no clear data. Now, LIT should not be used as a treatment modality. This is what I was talking about. This is lymphocyte immunization therapy. Then it should not be used as what is recommended, though I believe that with time these recommendations will change. IVIG, again, it may improve, so we are using it in certain patients. Steroids not recommended for unexplained RPL. And GCSF, again, that is something that was studied and it is not recommended. If you look at heparin, low-dose folic acid, vaginal progesterone, intralipid therapy, endometrial scratching, these are some of the things that we do commonly. All of these are not recommended, or only vaginal progesterone may improve LBR in 3 or more PL cases, but I don't think that all of us being reproductive medicine specialists are going to let any patient who has had difficulty in continuing or having a pregnancy to just go off like that. And non-conventional treatments like Chinese herbal treatment, acupuncture, IVF or ICSI for RPL, unless there is genetic factor, and diet with antioxidants, these are actually going to help you. There is actually no evidence. So probably when patients, especially in my country, there's something called as I forgot the name, it's Panchatantra, or I forgot the name. So that is something that patients often resort to, but we've seen those patients again coming back for treatment after all of this. This is, you can keep a photo of this. This is basically a flow algorithm for managing your RPL cases. This is something that we usually follow in terms of testing. So at the end of the day, this is all that the recommendations say. What do I practice? So we just use a case-based use of aspirin, LMWH, steroids, PGTA. Yes, I do use PGTA. Thrombophilia investigations and prophylaxis, yes. LIT therapy, so for those who do not do LIT therapy, this is basically lymphocyte immunization therapy, wherein you'll take the paternal lymphocytes and sort of we'll make them more potent and then inject into the mother. So this is basically sensitizing her immune system to the paternal antigens and immunoglobulins. Yes, in indicated cases, we are using immunoglobulins. That's a lot of information, and I think at the end of the day, you will have to manage your cases according to what you see, rather than giving a blanket approach to all. But there is not every test holds value in terms of treatment. And we always have to look at the cost, because it's always weighing the cost versus the benefit. Thank you.
Thank you, Dr. Rinoy, for sharing your valuable insights. Please welcome our next speaker for the session, Professor Joseph Gichuhi, Senior Lecturer, Department of Obs-Gyn, College of Health Science, and in charge of the Infertility and Gynecological Endoscopic Training Programs, Kenyatta National Hospital, University of Nairobi. His topic for presentation is random start, controlled ovarian stimulation in IVF.
Okay, good morning. Thank you very much to Merck Foundation for offering this opportunity for this wonderful conference. So I'm going to start to talk to you on random start controlled ovarian stimulation in IVF. We know that the basis of in vitro fertilization is ovarian stimulation and may depend on the quality of the oocytes, the quality of the embryo, and eventually the outcome. So we'll start with just so synopsis will be ovarian physiology. The whole of in vitro fertilization actually is just based on ovarian physiology. It's the basic understanding actually of in vitro fertilization. And if you understand ovarian physiology, you can be able to manipulate that cycle to what you want, including what I'm going to talk about, starting IVF at any instant. Patient walking in, you do your investigations, and you start in vitro fertilization. We're going to look at the traditional antral follicle growth concept, ovarian follicular waves, which is the basis of this talk, and random start ovarian stimulation in ART. So, I think we missed one slide there. So we're going to look at the human ovary. This is one of the most dynamic organs we have in the body. In utero, we start by having almost 6 million primordial follicles. By the time of birth, you end up having 2 million. And by the time menarche is occurring, you're having 400,000. So you can see the changes start from utero and continue actually in premenarche and continue throughout until we get to menopause when all the primordial follicles get finished. We know that when we have menstruation, you'll be follicular. Is there a reflection? There's an echo somewhere. So we know very clearly that when menstruation occurs, we have folliculogenesis. We know that there's a progression and increase of FSH, and in the 5th day you have a dip, and then that's when you have the dominant follicle. And progressively you have folliculogenesis, and then you have estradiol going up, you have LH surge, you have ovulation, and that marks the progression from follicular phase into luteal phase, where you have the production of the corpus luteum, progesterone, and production of the progesterone. And if the pregnancy occurs because of the influence of HCG, then you continue with the progression of corpus luteum growing. If it doesn't occur, then because of dipping of the progesterone, you have regression of endometrium and you have ovulation, you have menstruation. A lot of studies were done through the post-mortem of oophorectomy and currently ultrasound to monitor what exactly happens in the ovary. So we have proposed 3 theories of antrofollicle development. There's continuous recruitment theory, there's single recruitment episode theory, which is the current thinking, but the most modern thinking is follicular wave theory, which I'm going to discuss about. There's what we call continuous recruitment theory. We know that the pre-antral follicles do not depend on FSH. The recruitment goes throughout. And that's why even if you give that a patient agonist or you give continuous pills, the progression of the folliculogenesis continues because the pre-antral follicle are not dependent on FSH, and you continue with the loss of the follicles throughout because the recruitment goes throughout. So what you have here is there's continuous recruitment of the antral follicles, and eventually when menstruation occurs, there's a growth of the follicle. It will reach about 10 millimeters, and it becomes selected, become the dominant follicle, and the influence of LH ovulation is going to occur. And that's what you're seeing. Antral follicle 4 to 6 centimeters in size were recruited for growth continuously throughout the menstrual cycle, independently of FSH. From the continuous pool of recruited antral follicles, a single dominant follicle developed in the early follicular phase, resulting in ovulation and mid-cycle. The dominant follicle was thought to be selected because it was at optimum stage of maturity to be able to respond to rising FSH following luteal regression. That's one of the theories. The current theory, which most of us seem to practice, is what we call a cyclic single theory. And if you look at all the textbooks of physiology, this is what you're going to see. But this is not the truth. So basically what you see when menstruation occurs is a multiple antral follicles here. And you have an increase in FSH. And when you reach day 5, because you reach critical threshold of FSH, it will select one follicle, then there's that dip. And that dip, that's when you have the dominant follicle. The rest become adretic. And eventually, as estradiol continues going up, when it reaches that critical level, 200 picogram, you have LH surge and ovulation will occur. And when ovulation occurs, it will form the corpus luteum. If pregnancies occur, HCG will cause the progression of the corpus luteum with production of progesterone. If it does not occur, then the endometrium will regress because of the progesterone going down, and you have menstruation. Can we have follicles here? So what this theory says, we cannot have recruitment of follicles here, here, and here. More so here, because of that inhibin A rises, and the estradiol, therefore you cannot have recruitment of the follicles here. And that's the basis for us. When you start IVF, we are going to start on the 2nd, on the 3rd day before we have that dip of the FSH. And if when a patient comes in and is beyond that 5th day, in fact, most people 2nd to 3rd day, then we tell the patient to come the next cycle because we don't have antral follicles here and here. But that's not the truth. Is as I'm going to show you, this recruitment can occur there, can occur here, can occur here throughout. That's what you're saying. That's the current theory. Because there are multiple waves of recruitment which occur. And if, in essence, if you're having a wave occurring here, another one here, and you start patients on gonadotropin FSH, then you can be able to get follicles. That's what you're saying. The other thing about this cycle is the current thinking about is not part of this presentation, is progesterone. Does progesterone have any role as far as ovulation induction is concerned as a trigger? All the literature says no. No, that's not the current thinking. Is we know now very clearly there's a small deep increase there of progesterone here just before there at the same time there. And now it is found it has a role as far as ovulation induction is concerned. And there's a lot of work going on to use progesterone as a trigger. That's another topic for another day. And of course, we know again, the other issue of IVF is LH suppression, because if you don't suppress that, and the dominant follicle produces more than 200 progesterone, then you have ovulation, you have the trigger. Ovulation, LH surge, and the rest will become adretic. So we suppress that with agonist and antagonist. But again, now we know that we can use progesterone to suppress that. We don't have to use agonist. We don't have to give injections. Those are the current changes we're saying, that their follicular waves, they're different. We may be used to produce progesterone, and we're using progesterones. And this is what you're saying about cyclic theory, is you're saying that there are small waves, but we know that actually it's when the luteal phase, there's recruitment of antral follicles here, when they start growing here, FSH will go up, and when you have the threshold, the FSH will dip and you get a dominant follicle. So this is single cyclic recruitment episode that actually just recruitment occurs there. And this is just a summary of what I've been saying all along, is that from a single recruitment, we have 2-5 follicle size. Dominant follicle is shown to be selected for prepubertal growth in early to mid follicular phase, resulting in ovulation. On day 6 to 9 of the follicular phase at the mean diameter of 10 millimeter, the dominant follicle continues to grow while the underlying follicles regressed. And thereafter, you don't have any wave of follicles under this theory. We know from the FSH threshold window gate hypothesis, that's when you remember that FSH will dip, and day 5 it will dip down. And that is the threshold. So it's the follicle with the most receptors which will be receptive under that particular critical threshold of FSH. And it will continue growing, forming the dominant follicle. The rest becomes adretic. And what we do in IVF is we just open this window. Because it's a window, we just open the window. Because instead of limiting, instead of dipping the FSH, we continue giving exogenous FSH. So we end up recruiting many follicles. That's the basis of IVF, giving on 2nd or 3rd day, is we are going to stop that gate hypothesis, open this window for a long time, and means more antral follicles will continue growing and we get multiple follicles. Increasing the duration of rise in FSH above the threshold, as seen with exogenous gonadotropin, using ovarian stimulation, thereby allows multiple follicles to be selected, and that's what we do in IVF. It's just what I've said. The earliest reports of follicular waves are follicular wave theory. In contrast to the notions of continuous recruitment or a single episode of cyclic recruitment, cohorts of antral follicles referred as waves has been shown to emerge multiple times during the menstruation, and that's what you're saying. It's not a single wave or a cyclic wave, it's multiple waves. The earliest reports were based on the histological evaluation of the ovaries and subsequent studies. Ultrasound was used to further the notion that multiple waves of antral development, follicles develop through the menstrual cycle. A follicular wave is defined as synchronous growth of a group of antral follicles 2 to 5 in size that occurs at regular intervals during the menstrual cycles. Follicles in each wave are similar but not identical. We know now that there are major waves and multiple waves, but there are two theories about the major waves. 68% of women developed 2 waves, major waves, and 32% developed 3 waves. In women with 2 follicular waves, the waves emerge on days 1 and 14. In women with 3 follicular waves, emerge on days 0, 12, and 18. And this is the basis of the follicular that you are saying, that actually there are waves which will occur even in the luteal phase, and there are waves which will occur here. And because of FSH dipping, in spite of the waves, you end up with a dominant follicle that will occur. But we know there are multiple waves which occur. Major waves are those in which dominant follicle develops. In minor wave, physiological selection of dominant follicle is not manifest, and that's why we end up with just in the natural cycle getting just one wave when we go to more often than not just one follicle developing. Knowledge of waves of follicle development has led to the global adoption of novel ovarian stimulation strategies in which stimulation can be initiated at various times throughout the cycle. Random start and luteal phase ovarian stimulation regimes have had important implications in women requiring urgent oocyte, egg donation, embryo cryopreservation, or prior chemotherapy. It's just what you're saying, what has been said by the previous speaker. You presented today, you have this 30 years old, has a CA breast, and she walks to you. And the oncologist wants to start the treatment like yesterday, so what do you do? She's on day 10, day 20 of her cycle. What do you do? What you're saying is you can start immediately, so long as you don't have a cyst or a follicle which is more than 14 millimeters. That is going to suppress. But that you can be able to overcome by giving an agonist for 3 days. So you can start any time, so long as you don't have a cyst. That's what you're saying. We have also patients who travel. Some, like those I come from Kenya, some coming from UK. Because the cost of IVF is very expensive, they come and they want to start IVF immediately. On converse, we've had patients of ours coming from Kenya going to India, and she lands. So what do? You tell her to wait for another 3 weeks for the menses to come. You can start the treatment immediately and transfer subsequent cycle. You know you cannot transfer because the embryo endometrial synchrony will not be there. So you have to freeze all these embryos. That's the only drawback, that you have to freeze when you have a random start, that you're saying. And then again applies to egg donors. She walks in today, she's on the 7th day 10, everything is good. You can start on treatment immediately. You don't have to wait for the next 28 days. And of course, sometimes some people in a hurry, I want to freeze my oocytes and I travel or anything like that. Of course, those who require embryo cryopreservation is very good because you can start any time, because you cannot transfer in this cycle. And of course, chemotherapy has been said, you can start immediately. Ovarian stimulation twice in the same cycle refers to double stimulation, may be used to optimize clinical outcomes with women with poor ovarian reserve to stimulation and fertility preservation before chemotherapy. Again, that's very important. We know that some of the women who get cancers may be in the late 30s, and you may not get adequate oocytes. So what do? You can do stimulation at the same time. Immediately you stop, as you're going to see, you start the stimulation at the same time. So the theories we have said, this is the second wave theories. This is actually at the follicular phase. In this theory, we have that wave which comes there. You can see that. And that is the one more often than not, we'll end up with ovulation. In spite of ovulation occurring and formation of the corpus luteum, we are going to get another wave starting here. That's another wave which comes here and then comes down here. Again, we can't predict exactly these waves are going to be. They can be anywhere there. That's why we're saying we can have random start. This is a major wave. We also have small waves which start all over, small waves. So the two waves theories, we have that one there. And so you can start your treatment anywhere on this cycle. That's what you're saying. You can't exactly time with these particular ones, but there's a wave. And again, as you come again to the luteal phase, you start with the growth there. Then there's a three-wave theory. Three-wave cycles. No, sorry, there missed something here. Yeah, this is three waves. Again, you can see this one will start on the one. It will be there on the 12th, and it will be there on the 18th. So there's this first wave here. Then we come to the 12th. There's another wave. Then you come to the 18th. There's another wave which comes there. And this wave will occur in spite of the formation of the corpus luteum, in spite of having high levels of estrogens, because we know estrogen is supposed to suppress, and in spite of having high levels of inhibin A. So initially it was thought it might not work very well because of the estrogens and inhibin A, but it does have those three waves you can see there. this is just a summary comparing the two. There's that and that, the 2-wave and the 3-wave. And what happens when you have the dual trigger? The dual trigger, basically what you're saying is you start giving the gonadotropins, you retrieve. She may be poor responder, or she may be a patient with cancer of the ovary where you need to get as many oocytes as possible. Then you can start on the 5th day and start on stimulation. So initially it was thought it is the residue follicles you're stimulating, but now we know that's not the case. We know that actually there's a wave which is occurring here. Even after you have stimulated, you have retrieved, there's a wave which is occurring here, and you're taking advantage of this wave. So you can be able to do dual stimulation at the same time. In this second wave, you see it is in the luteal phase. The estrogen, the inhibin does not affect it. The question we need to ask, the high levels of progesterone, can they suppress LH surge? No, it doesn't suppress. You still have to give the LH suppression here. The best option, of course, would be giving the progesterone. So that's what we are saying, talking about random start, is ovarian follicular waves during the menstrual cycle provide opportunities for initiating ovarian stimulation at multiple times during the menstrual cycle. Theoretically, stimulation at different times of cycle takes advantage of inducing the growth of follicles from whichever wave is present at that particular time. Prediction of wave emergency in women is difficult due to variability of wave emergency. We can't tell exactly, but therefore, practice of random start stimulation has a reason in which ovarian stimulation can be initiated at any time of the cycle, so long as you don't have a cyst more than 14 millimeters or a follicle 14 millimeters. In case you have a cyst, you can give GR antagonist for 3 days, and it will get lysolysis, and you can be able to stimulate. It doesn't mean that you wait until the next cycle. Endometrial development is not synchronized with ovarian function. In randomized start, I'm just about to finish. Protocols that require oocyte retrieval, oocyte embryo preservation in subsequent frozen embryo transfer will benefit from random ovulation induction. Oncofertility patient, has been said before, freeze-all. We know some centers now are practicing freeze-all completely to avoid ovarian hyperstimulation syndrome. Patients and freeze-all patients, egg donors, and dual stimulation patients. Thus, random start stimulation followed by oocytes or embryo vitrification is a novel approach in ovarian and uterine functions are decoupled to provide patient-oriented reproductive medicine. There's something, I'm going to the next slide, there's a small error which occurred. Don't forget, this is not antagonist trigger, this is agonist trigger. We were in a hurry to present this paper to Merck. Don't forget, this is not antagonist, agonist trigger before I come to that. So this patient is just a case presentation. She was an egg donor. She was at day 6. She came with gonadotropin. We always use progesterones. They're cheaper. There are no injections. You use less dose of gonadotropins, and then we use the agonist trigger. You can use HCG, but there's no need of using HCG because in the first place you're trying to avoid ovarian hyperstimulation syndrome. So this is a very novel way. You use progesterone. They're very cheap, and you use agonists. So you end up with no ovarian hyperstimulation syndrome at all. It's a nightmare when you get an ovarian hyperstimulation syndrome in a donor. So you can see, and these patients, we ended up getting 24. We have a patient from this patient, there are 22 M2s, and M1s were that. Again, the other patient is also a donor, and we triggered at about it was, I think, the 9 and 10. There are no big oocytes, and again, don't forget, when you get this is agonist, it's the same thing. We are starting progesterone immediately. Any progesterone can work, be it dihydrogesterone, Provera, whichever progesterone tablet you want to use can work. And this should be the last slide. And I hope this will help in your practice, because when I go to a conference, I always wonder, is this going to help improve my practice? So I hope the points I've raised are going to improve your practice. And I'm finishing now. In conclusion, women diagnosed with cancer or poor ovarian response will have a greater chance of success in ART with random start. Today, similar clinical pregnancy rates and similar or increased live births have been reported with the use of random start conventional stimulation. That would be the biggest concern. Am I going to get good quality oocytes? Am I going to get good quality embryo? Am I going to get good implantation rates? Am I going to get ongoing pregnancy and eventually? Studies have shown I didn't have time for that because of this presentation, that actually you get as good as when you're using the conventional way of starting immediately. It does not affect the outside outcome. The only question is in the luteal phase, you may have to get an extra day. If in a normal cycle you're using 10, 12 days, you may get an extra day. You may use slightly more gonadotropin when you trigger in the luteal phase as the only drawback. The primary benefits of random start and due stimulation include is just a patient-oriented approach, timely and efficient treatment, and a resultant lower dropout rate. Again, we know most patients sometimes they just drop out. You can just start at any particular time. Clinical pregnancy rates do not appear to differ in women undergoing due stimulation versus conventional ovarian stimulation. I think that would be the concern, but it's just the same. Thank you very much for listening to me.
But I would like to thank you, Professor Joseph, for such a dynamic presentation.
There is an attendee who asks, is there any role of steroids in NK cells positive cases? Dr. Vipin will take that question.
Yeah.
So if NK cell are high, definitely those are the will have those are T2 cells. So an NK cell will definitely will tilt the equilibrium of the TH1 TH2 towards the TH2 side, as well as TH17 versus Treg cells and towards the TH17 side. These inclination will make a patient more prone for immunological rejections. Yes, there is a definite role of prednisolone as a passive immunotherapy to be tried first if the patient is having few missed abortions or unexplained infertility or one or IVF failure. But in case of an IV, they are attempting, they are candidate for an IVF. Since IVF is a big pocket money, will consume a lot of money, you should not just go for a prednisolone as such. Evaluate more on immunological side, because if there is a really immunological reason, it will end up in failure until you are not treated it properly. So for immunological reasons, if you are trying naturally, trying IUI, prednisolone is good enough to as a supplement to tackle passively. But if you are the candidate for which you are trying to manage with an IVF only, then evaluate more over above just NK cells, do lymphocyte cross-match, NK cells evaluation also. If there is a derangement in this, high NK cells, high TNF-alpha and lymphocyte cross-match in both class 1 and class 2, then instead of the passive immunotherapy, go for active immunotherapy, which is called lymphocyte immunoinfusion therapy. And we just now we have finished one meta-analysis within our system also, and it's we had a prospectively we also assessed 1,500 patients with an LIT. Such patients who are immunological causes, those who once been transferred against the control and with LIT, without LIT, then those candidates who are having an immunological causes, they get in a similar kind of a success, even better success than a control group. So yes, if patient is for natural treatment, for IUI, prednisolone is enough, but NK cell is high, then if it candidates for IVF, do go for an passive along with elective therapy.
Can I just make a comment for Professor Joseph? Firstly, I agree that there is a place for steroids when the NK cells are elevated, and we've done that successfully. And also, you may end up using a IVIG in some cases, or the phospholipids. With regards to Professor Joseph, I'm not sure whether you mentioned it, that once you go into dual stimulation, or you use progesterone stimulation, especially for donors, that's fine. But if you use it for patients and you use dual stimulation, then you have to do a frozen embryo transfer, because the patient is now completely out of sync in her cycle. So if you transfer, you'll be transferring in a non-physiological status. So it's better to freeze those embryos you obtained from such stimulation, and then you can transfer in a natural cycle or in a plant cycle. Thank you.
I think my question is to Professor Diga. We now know there's a good evidence that even for a successful fertilization of oocytes, you need the oocyte needs to be activated, even in the cases of ICSI. And some of the patients that we do ICSI, sometimes they do have completely normal sperm count, and all other parameters in terms of sperm are normal. But still you don't get fertilization even with ICSI. And there's a very good evidence about the role of PLC zeta protein for that. So what is the current best recommended practice in such cases whereby you have sperm, you have oocytes, but even with ICSI you don't get fertilization?
Yeah, as you know, this total fertilization failure post-ICSI is not uncommon. It's in about 1 to 3% of the patients do experience fertilization failure post-ICSI when everything is normal. But the assisted oocyte activation, there is no evidence to use it routinely, but in situation where you see a lot of oocyte abnormalities, like you see a lot of granulation in the oocyte, central granulation, or you're using vitrified warmed oocytes or in vitro matured oocytes, probably that the calcium spikes are compromised. So in those situations, you can expose them to, subject them to assisted oocyte activation, and that is useful. And when it comes to PLC zeta, as of now, there is no diagnostic test, though immunological detection is possible, but it is not being routinely done in IVF lab. And the best way is to use in case of you use, again, you have you have severe oligospermia, sperm from very poor quality ejaculate, or you have used the testicular sperm, frozen thought testicular sperm with the high morphological abnormalities. These days we do see 0% morphologically normal sperm. Those situations, you can empirically, you can subject your oocytes to assisted oocyte activation. Probably that will prevent or minimize the risk of experiencing total fertilization failure.
Thank you for the questions and answers. But I would like to invite Dr. Diga.
Thank you very much once again. And the topic is stress. As you all know, stress is a part and parcel of our profession in ART, whether you are a fertility clinician or embryologist or patients, you experience stress at different time points. But I'm not going to talk about this stress because I'm not expert in that. I'm going to talk about the stress experienced by the gametes and embryos in IVF lab. As you all know, we embryologists are unique because we deal with the unique cell types in the body. The sperm, oocytes, and embryos, they are very unique with respect to their size, shape, the chromatin organization, the epigenetic, genetic, and also their ability to experience stress and respond to stress also different. For example, sperm, as you know, the sperm is a very simple structure, right? It's a very simple. But we also know that the sperm is quite resistant to any kind of stress because of its unique chromatin architecture. It has got a kind of the protamine. The protamination happens during spermiogenesis, and then you have some amount of histones remaining here. But if the process of protamination is affected due to abnormal protein folding, and then probably the sperm becomes more vulnerable to experience stress. When it comes to oocytes, as we know that the oogenesis is a very long process, and the oocytes are arrested at GV stage until they undergo maturation. And interestingly, the oocytes also have a limited checkpoint ability, a checkpoint mechanism. Checkpoint means if there is any stress, the progression is compromised. It is halted temporarily, and cells try to repair the kind of stress or the damage, whatever the cells are experiencing, and then they progress. This is known as checkpoint mechanism. And unfortunately, in oocytes also, the checkpoint mechanisms are compromised, at least during the follicular phase. That means during the follicular phase, during stimulation, if the follicular environment is stressful, the oocytes still progress. So you see here, it can progress from GV, breakdown, GVBD can happen, and they reaches M1 stage. And when the oocyte reaches M1 stage, it realizes, okay, there is something wrong. The G2M checkpoint gets activated here, and then they try to fix the problem. If the problem is fixed, it progresses to metaphase 2, and if the problem is still persistent, it is arrested at metaphase M1 stage. So when it comes to the clinical relevance, and this could be one of the reasons for seeing heterogeneity in the oocyte maturation in our program. It is not that always we get 100% mature oocyte. We get a very heterogeneous population, but if you see too many M1 oocytes in your stimulation, probably it's because of the checkpoint response is compromised, or oocytes must have experienced some kind of stress during or within the follicular microenvironment. The embryos, human embryos, are again very unique with respect to the stress response. As you see here, the pre-implantation development of approximately 120 hours. The cleavage takes place, and during the process of this 120 hours, a lot of changes happened in the early embryos. There is an increase in the cell size, increase in the cell number, and the embryonic genome gets activated, and the epigenetic changes happen. These are very crucial events happen during the process. Interestingly, the human embryos, if they experience any kind of stress in the lab, they keep growing. They don't respond to stress. If the incubator conditions are abnormal, if the manipulation is very vigorous, they keep growing, and we won't be knowing whether the embryo has experienced any stress or not, because it looks perfectly normal on day 3. If you're going for day 3 transfer, the embryos are beautiful, you select the embryo and transfer, because it has no ability to respond to any kind of stress. The stress response in embryos gets activated at the time it becomes blastocyst. The time of blastocyst, all checkpoint mechanism gets activated, so the embryo can respond to stress and try to fix if there is any problem. So this could be one of the reasons when you see a beautiful embryo transferred on day 3 resulted in miscarriage. Probably the checkpoint mechanism activated here must have eliminated more cells from the ICM and eventually leading to post-implantation embryonic death. So let's come to the IVF lab. There are multiple factors in the IVF lab which can be dangerous to the embryos. There are several exogenous factors, could be starting from the oocyte manipulation until the embryo transfer. They are subjected to multiple interventions in the IVF lab. They could be thermal, osmotic, chemical, or oxidative. Sometimes the combination of all this stress can eventually compromise the ability of the embryo to undergo implantation. For example, if you look at the sperm, the ejaculate has seminal plasma. Seminal plasma is a good buffering agent, and also it protects the sperm to some extent. As soon as the sperm are separated, you take out the sperm from the ejaculate during the wash, its protective shield is gone. Then what we do, we subject them to centrifugation, we subject them to wash, we freeze them. All these processes can compromise the functional and the genetic integrity of the spermatozoa and may eventually compromise its ability to fertilize the oocyte. This is one example. This is not a new study. We did long back. So what we have shown here is that the poor quality ejaculates are more susceptible to experience any kind of stress. We have to be extremely careful in the lab when we deal with the poor quality ejaculate. And here is the data which shows that when you freeze the poor quality ejaculate, the risk of acquiring DNA fragmentation post-warming is higher. So this is one example. Similarly, we have shown that even during ICSI, we keep the sperm in PVP. Those who are embryologists are familiar with the lab, you know why PVP is used. Once we process the sperm, we keep them in the PVP, then we manipulate. We'll be able to identify, select, and immobilize. PVP is, we cannot do ICSI without PVP. But PVP is a very inert substance. Ideally, it should not be dangerous to sperm. But what we have shown here is that when you keep the sperm in PVP for a long time, it can induce in situ DNA damage in the sperm. So my advice is not to expose sperm to PVP for a long time. So you mix it only when you are ready to perform ICSI. This is one example. Like that, there are several embryological interventions may compromise, may harm the oocyte or sperm, may induce stress in sperm and oocyte or embryos, and eventually affect the outcome. So in the IVF lab, as you see during the pre-implantation development, the embryos are exposed to multiple stressors. It could be the culture medium, the oil, the incubator, or whatever it is. And this can compromise, this can affect the process of genomic activation, can affect the epigenetic signature, and eventually affect the outcome. So it has been clearly shown that the IVF lab environment is the most important factor which decides the phenotype of the embryo. So it could be, there are multiple factors in the lab. It could be the lab environment, it could be the culture system or manipulation, which can negatively influence the embryo phenotype. So we have to be extremely careful when we deal with the lab environment. And one of the important aspects which I would like to discuss today is the oxygen environment in the IVF lab, in the embryo culture. We know that the embryos are ideally in a physiological condition are exposed to low oxygen condition. If you look at the female reproductive system, the oxygen environment in the femoral end is close to 8%, whereas in uterus it is more hypoxia, it's about 2%. So that means we are ideally keeping the embryos at low oxygen environment. Because of various reasons, maybe because of the financial reason, we may not afford low oxygen incubators. So if we keep them high oxygen or environmental oxygen level, that means about 20%, what can happen? It can be detrimental to embryos. It has been shown that if the embryos exposed to high oxygen environment can lead to senescence. The senescence means there is the cessation or the arrest of development. Embryos don't show any phenotype changes, they don't show any fragmentation, they don't show any abnormalities, but they arrest at certain stage of development. So this could be one of the reasons for seeing heterogeneity in the embryonic development in the embryo lab. It's not that all your embryos follow timeline. All your embryos progress to 4 cell, 6 to 8, or compaction in blastocyst stage. So if the environment, oxygen environment is not very conducive in the lab, probably the development is compromised. So these days, we are going for low oxygen incubators. This low oxygen culture is not a new technology. If you look at way back in 60s, people have used low oxygen, but they did it in a different way. They used this kind of desiccators and created low oxygen by pumping nitrogen and keeping the whole thing inside this box incubator. That was the concept these days. But now, later they realized that doing this kind of complex process is more expensive. And they also felt that the regular incubator is giving good outcome. So why not? Why we need to complicate all this process? That's why the people started using box incubator with the 20% oxygen. Now we realize that high oxygen is detrimental. Now we are going towards more and more sophisticated low oxygen incubator for embryo culture. So my friend Romaldo has done a very nice review. He looked at several publications and found that they compared the physiological versus atmospheric oxygen and found that low oxygen is superior with respect to pregnancy rate as well as implantation and live birth rate. So always there is a recommendation to go for low oxygen culture in your IVF lab. Another important intervention which I would like to discuss is about the cryopreservation. The cryopreservation is again a part and parcel of IVF program. Without cryopreservation, it cannot work. But during cryopreservation, the embryos again experience several types of stress. Because, for example, if you look at the oocytes are usually kept in the incubator at 37 degrees centigrade. During cryopreservation, we bring them to room temperature. Then we subject them to osmotic shock. The medium, freezing medium, what we use has osmolality of 5,600. This is a normal osmolality of the culture medium, whereas the freezing medium has osmolality of 5,600. So they are subjected to 20 times higher osmotic shock. Once we attain this, again we drop them to minus 196 by using a very high cooling rate. High cooling rate is very important to attain good survival of the oocyte post-warming, but the process can eventually compromise the genetic and epigenetic integrity. And unfortunately, we do not have any adequate data to prove the safety of these techniques, but they are giving us good outcome, good survival, good embryos, and good babies. So we are happy. So far we are happy about that, but we do not know what is the long-term health of the children who are born through this intervention. So what can happen? The impact could be, there could be epigenetic disorder, there could be malignancy, there could be the birth defects, or there could be the obesity or other kind of problems in the children. There are several studies which are discussed about the impact of all this intervention, embryological intervention or ART on children, and studies. This is a study which I found recently, which looked at the association between the fertility treatment and cancer risk, and found that this study has shown that the higher incidence of cancer in children who are born through the frozen third cycle, the embryo subjected to cryopreservation warming. Similarly, there is a study which again looked at the association between the ART and non-ART, found higher incidence of hepatic tumors, higher in the children who are conceived via IVF compared to the spontaneously born children. This is a world study. I like this. This is the Australian study which looked at about 300,000 children who are born through ART. And this study has also shown that the risk of birth defect in ICSI-born children are slightly higher compared to the ART, the IVF or other medically assisted conception procedures. So the question is, why it happens? Why does it happen? What are the reasons for iatrogenic stress? The primary reason could be the inadequate infrastructure. You don't have adequate machines, you don't have adequate the requirements to perform the ART, or it could be inadequate staff, or it could be high volume of patient. So in general, these things can happen in centers where IVF is done in batches. You recruit many patients at a time, but you don't have many machines or people to handle, which can eventually increase the risk of stress in gametes and embryos. The other reasons could be poor or no quality control system in place, no SOPs, lack of scientific knowledge by the embryologist, the use of untested technology and material. You have been given some material for free or buy one, get one free, and you wanted to use it, but you do not know whether it's really going to be useful. Or it could be negligence or ignorance about the outcome. These are some of the possible reasons for experiencing for the iatrogenic stress in the embryology lab. So let's look at what are the strategies to de-stress. So if you look at, there is a keeping the optimal conditions of the external factors. What are those external factors? If you look at the Cairo consensus, which says that there is only one thing that is truly important in IVF lab is everything. That means each and everything in IVF lab should be looked into, and it is important. You cannot ignore any of these factors. And specifically, if you look at the gametes and embryo specific protocol, unfortunately, in embryology lab, most of the protocols which we use are very generic. Our fertility clinicians, they customize, they have patient specific protocol. Unfortunately, in embryology, whatever has been given by the companies, those protocols are being followed, which is not right. Ideally, our protocols also should be the gamete specific or the embryo specific, because as I told you earlier, the poor quality ejaculate or the poor quality sperm or the oocytes are more susceptible to experience any kind of abnormalities. And insemination, IVF or ICSI, we know that ICSI is not really useful in case of non-male factor infertility, but we still do ICSI because one of the non-medical indications for doing ICSI is the fear of fertilization failure, because if there is no fertilization, what do we answer to clinician and what clinician can answer to patient? That's the reason we do ICSI. And embryo culture, again, going for whether it's short, extended, one-step sequential. It is not that sometimes some center they go for only blastocyst, which I don't know whether it is really required or not, but according to me, the blastocyst of course gives better outcome, but if the lab conditions are not all right, during the process of next another 40, from day 3 to day 5, can induce more stress to the embryos. So you can also balance this, can go with the 2 day 3 embryos compared to 1 blastocyst. But if there is a strong indication to go for blastocyst, yes, you can go for blastocyst culture. Oocyte and embryo cryopreservation, again, we should also look into the embryo stage, the equilibration time, number, depending upon the quality of the embryo. Again, we cannot follow the generic protocol given by the company. We have to optimize according to the quality, the stage of the embryos. There is also a possibility that we can use some supplements. In fact, this is our own study. We have also used some kind of antioxidants and micronutrients to the culture medium during cryopreservation, during sperm preparation, which has shown to improve the quality. But again, this needs more validation. And these days we are using microfluidics, because microfluidics has shown to be beneficial because there is no manipulation. The ejaculates are directly kept on the device. It follows the idea of the natural selection based on the chemotaxis, thermotaxis, and rheotaxis. No centrifugation, no pipetting, so they are safe. So it has been shown that it can also helpful in eliminating the ejaculate with high DNA fragmentation. And this is one of the, I don't have any conflict of interest, but this study has shown that there's a multi-channel, the microfluidics, which has shown to increase or improve the sperm quality. You can also get in earlier devices, it is very difficult to get more numbers. So they are only ideal for ICSI. But now these days the devices can give you in millions, which you can even go for intrauterine insemination. This is our own product. We have also developed a device known as MIGLIS. It's based on the sedimentation, this migration sedimentation. It's a very simple device. As you see here, there are 4 different parts, and keep the ejaculate liquefied semen, overlay with the culture medium, and then cover the lid and incubate for 1 hour at 37 degrees centigrade. And after 1 hour, you have from the central tube, you can aspirate the motile population, and you can directly use it for insemination. So this is the prototype of, we call it as MIGLIS, and we have shown that this is very good in extracting sperm with the high viability, the longevity, and with the mitochondrial integrity, and also reduce the DNA fragmentation significantly. And avoid unnecessary steps, interventions in IVF lab. As I told you earlier, if everything is fine, good quality sperm, good oocyte, why not IVF? Give some scope for natural selection, and it has been shown that IVF derived embryos are more robust compared to ICSI derived embryos. And IMSI has not, these days no one is using IMSI because it has not shown clinically beneficial. Assisted hatching, again, there is no evidence that assisted hatching is useful. Normally it is done only in indicated cases, like you have transferred good embryos, no implantation, probably, or if there's the zona pellucida is really thick, probably you can go for assisted hatching, but it cannot, not useful in the routine practice. And again, extended culture. One thing I would like to mention is about the embryo development during compaction. From day 3 to day 4, the process is very, very sensitive. During this process, embryos experience a lot of changes. The cell-to-cell connection happens, and the differentiation happens, the formation of the 2 germ layers, the trophectoderm and inner cell mass. What I want to tell you is that this is a very crucial phase in the human development, and ideally, embryos should be undisturbed. So it is better not to manipulate the embryos on day 4, avoid transferring the embryos on day 4, avoid freezing the embryos on day 4. So because any kind of the intervention during the process may compromise its genetic and epigenetic integrity. You can ask me, okay, I have done it and I have got a good blastocyst and I got pregnancy. Yes, you can get pregnancy, but we do not know what is the long-term impact of all these interventions on the health of the child. Maybe after 2 decades or 3 decades, we do not know. So since it is not physiological, it is better to avoid any kind of interventions during this period. So these days we have the technology, we have AI has come to the picture, in our system, where we don't have to take out the embryos from the incubator, and there's a good algorithm which can also give more information what is the best embryo for selection and transfer. We have non-invasive PGT where you don't have to harm the embryo, use the medium and subject it to proteomic or metabolomic analysis, and which can help in selecting the competent embryo, but still we need more data to validate the benefit of this technology in IVF practice. So what is finally the last factor which can cause stress in the lab? I'm sure you have this, you have seen my slide, you have the answer, right? Is the embryologist is the most important factor. If the embryologist is not trained adequately, is not competent enough, probably he or she is the biggest stressor in the lab. So it is important that the embryologist should have, embryologist is not just the technician. Always you remember that the embryologist is not just a technician. He or she should acquire all these factors, you should be the good manager, researcher, collaborator, scholar, communicator, and mentor. If your embryologist acquires all these, the characters, then probably he or she will be the biggest stress buster in the lab, not the stressor. So thank you very much for your attention.
Once again, thank you, Professor Satish, for such a mind-blowing presentation. Now I'd like to invite again Dr. Vipin Chandra from Indira IVF. Kindly step on the stage for his second lecture for the day on optimizing fertility outcomes, advances in ART, AI, and personalized medicine. Over to you.
Good afternoon. This is going to be a very interesting topic because now era has come up where we should not treat in a blanket approach because every patient is unique. They needed their individualized treatment. Starting from this investigation to the pre-stimulation to the stimulation and the embryo transfer and even in the luteal phase. All these things has to be individualized because every patient behave differently and those treatment modalities should be adjusted to the what they actually want to arrive at the best outcome possible for them. So we will discuss about few things. We'll discuss about how pre-stimulation can be optimized, how we can do the individualization of the control over in stimulation, how should be the sperm quality can be improvised by doing some individualization, genetic analysis, immune therapy, intermittent receptivity, and lastly, role of AI in IVF. Now, pre-stimulation, lifestyle, definitely these all, a lot of speakers have already spoken about it. We need to do certain modification in terms of a BMI has to be keep and control, recreational drugs should be avoided, limits of alcohol and caffeine, and consider exercise and healthy lifestyle. Type A personalities has to be told about keeping their stress under control. So these are things. Other than that, nutritional supplement, yes, folic acid, vitamin D, and coenzyme Q and DHA has a role, and we have already talked and listened a lot about it. Next. Endocrine and reproductive evaluation, yes, thyroid evaluation, diabetes evaluation, as well as ovarian reserve testing has to be done so that we can do certain more individualization. Going forward, yes, we should do a diagnostic lab in hysterospos if ultrasound is suggestive of that there is a hydrosalpinx and large fibroid who are typically type 1 to type 3, who are up to having some indentation or any sort of those fibroid who are touching to the endometrium must be removed, whatever the size is. But but those who are not indenting or touching to the endomyometrial junction, then size matters. Anything beyond 3.5 centimeters should be removed laparoscopically if we have a history of unexplained infertility or there is a recurrent plantation or a pregnancy losses. In concern to the male partner optimization, American Urology Society has already considered that WHO's 6th edition should be considered for semen analysis. I want to bring your highlight over here that DNA fragmentation in test has to be done, and we will discuss about whom to be offered and what individualization has to be done basis the inference once the report has come up. When it comes to control ovarian stimulation, we know that there are a lot of varieties of protocols are there, which is best suited to what and that which will optimize the outcomes in which category of a patient that has to be considered. But overall, if you are not doing so, one protocol which suits for all is your antagonist protocol. It is the most preferred protocol for either whether the patient is a normo, hypo responder. And because it's at the end of the day, safety is also a concern, they reduces the risk of OHSS. Long GnRH agonist protocol has lost its sheen in the long run. When I started my practice, we were having only long agonist protocol, and we have seen that those the time when only SCG was available for us to do a trigger, to give a trigger, and we used to tap almost 4 to 5 do a tapping of ascites every day, and those were the right nightmares. But now, thanks to the antagonist protocol, now no more this is required. In our protocol, in our centers, we have SOPs to attain OHSS free clinic protocols so that no patient should have an OHSS at least. So in our scenario, we don't do any GnRH agonist protocol now onwards once the agonist protocol has come up. Once this has been done, before treatment, pre-treatment to the protocol, in luteal phase or a cycle before, you can do some more standardization. Previously, many people were like using OCPs, a cycle, two to three cycle before the stimulation being started, but this is not at all recommended nowadays. Those which are now recommended are estrogen in the luteal phase, progesterone withdrawal, or sometimes GnRH agonist treatment. Who are the candidate? Estrogen protocol is been recommended especially when cases of post-estrogen group 3, 4 as well as 1 and 2, where you need to synchronize the follicles so that you can optimize the retrieval rate. Progesterone, for anyone who is like a normal responder or first timer, you can use progesterone. GnRH agonist again is recommended wherever your estrogen is not, you have been failed, you still want a synchronization further, and is recommended only in cases where severe endometriosis is there. Otherwise, we usually do in our clinic, we follow only progesterone and estrogen in a pre-stimulation cycles. DHA and androgens, yes, for category post-estrogen group 3 and 4. Otherwise, again, these are no much, but there is insufficient evidence for their routine use in all other cases. So Poseidon has already classified people into 4 groups. Definitely group 3 and group 4 are very obvious from the first day of the investigation. They were like in the group 3, age 35, group 4, age more than 35. And these are the ones who have a biological ovarian reserve lesser than the subphysiological. And these are the candidates whom you can, because they are expected to go for a poor outcome, expected to have a poor outcome, so you can do something extra for them. We'll discuss about them. Group 1 and Group 2 will be having a hypostimulation in the previous cycles, and those can further be refined. You can understand them, why they have gone for wrong, and what should be done extra for them. Now, what is the physical? Let's understand the physiology of group 1 to 4. As we discussed, that group 1 already had a suboptimal follicle recruitment despite being normal reserve. Most of the time, they they require higher doses because the pathophysiology is that they have some kind of a polymorphism, either in form of FSH or LH polymorphism. We'll discuss this in the upcoming slides. Group 2, again, though age is on a higher side, which relates to the oocyte decline in the oocyte quality and possible pharmacogenetic resistance. And again, because of these reasons, they also require higher gonadotropin, LS supplementation. Again, we can consider dual stem and embryo banking in these cases. Group 3 and 4, yes, they are the one who already have a lower reserve their side, and group 4 also have an advanced age on their, which will adversely affect their outcomes. And in these cases, oocyte pooling or embryo pooling is one good idea. And these may have some receptor polymorphism also, especially the LH1, and they can we can go for some adjuvant in these cases like growth and androgen, growth hormone and androgen, and dual stimulation and embryo pooling can be the way forward. In group 4, extra what can be done is assessing embryos for genetic testing. In case of hyperresponders, yes, the primary goal is to achieve prevent OHSS along with the decent number of follicles being recruited so the goal is to do a mild stimulation for them and enough to not to do the cycle cancellation. So what should be the advantage in case of hyporesponders? Yes, you can give metformin because it reduces the insulin resistance, improves the ovulatory response, lowers the risk of OHSS. Letrozole, yes, it's an aromatase inhibitor, reduces the estrogen level, and that's how it can prevent the OHSS. Cabergoline, it's a dopamine agonist, reduces VEGF-mediated vascular permeability, so that's why it reduces the OHSS risk. Inositol improves insulin sensitivity, just like metformin, and improves the oocyte quality. Coenzyme Q10, antioxidants in a smaller dose of 100 milligram BD can be good enough for these kind of cases. But out of these, coenzyme Q still has a limited evidences. I think with time, some more, once the evidence has been gathered around, we may think that can be given up coenzyme Q, just like to the group 3 and group 4. Now, as I was talking about, the most important factor by which we can individualize is LH-FSH receptor. We know major cost of an IVF cycle goes into the stimulation. And we have gone wrong in the stimulation protocol in deciding the dose and titrating the dose of gonadotropin, then it's all gone way. Whatever the money we have put in, the patient has put in, that has lost. So losing that one cycle can be saved by having some idea around the LH-FSH receptor polymorphism. And that's how you can do, and one must do, especially for group 1 and group 2, because these are the patients who already have experienced one failed cycle. But yes, for group 3 and group 4, I still recommend that they should also be offered LH-FSH receptor to individualize their treatment. Now, how to interpret and what action to be taken? Let's see. In case of an FSH receptor polymorphism, there can be on exon 10, SN series, and SER kind of a genotype. Out of these, the major implications come from SER associated, which will result in the blunted ovarian response to the FSH, whereas the ASN have a sensitive responders, even with the normal estrogens, and they have that risk of overstimulation. Now, if you know that from the beginning that this is there is a patient who is having a SER kind of a polymorphism, you know that this patient will have a blunted ovarian response to FSH. We need to have a higher threshold, higher FSH from this beginning, require higher dose, more than 300, maybe up to 450 also, and they are associated with the low. If you are monitoring your FSH IVF cycle with estrogen, then you need to be very cautious that these will have a lesser E2 compared to the other routine cycles. Whereas if you have a patient with this kind of a genotype, you know that they are sensitive to the FSH and they have a risk at overstimulation. So these doesn't require your even routine dose of 2 to 5 also is not required. 150 is enough for such patients. Yeah. In case of an LH receptor polymorphism, there are variants possible, and these variants can affect the LH response for maturation, and that's why wherever there is an LH receptor polymorphism is there, LH supplementation is required. So in nutshell, if in a case of a normal responder, whereas ASN kind of genotype is there, we predict optimal response to the FSH dose. Whereas in case of a poor responder, SER kind of will explain the poor response, and they require higher dose of FSH. We can consider LH supplementation wherever there is LH receptor polymorphism with the dose of LH 75 to 150 IU. And in case of these poor responders, we prefer to go for a dual stimulation or dual trigger also. Whereas in case of a hyporesponder, where ASN is the kind of a receptor polymorphism, where you can expect a hypersensitivity to FSH, we can start with a lower dose. And antagonist is the protocol, agonist trigger, and freeze-all strategy to avoid OHSS. So just by doing a polymorphism, you can prevent the bad outcome, even a normal responders or other poor responders from the way beginning, and you can save the one cycle just by doing a one investigation on a receptor polymorphism. So adjuvants are like, you can consider dual stimulation, especially in those who are responding poor, especially SER kind of a receptor polymorphism, and LH receptors. Androgen priming is required, especially in SER polymorphism, recombinant LH supplementation when the LH polymorphism is there. Long-acting FSH, choleutrophin alpha, may overcome mild FSH receptors resistance, which is seen in SER kind of polymorphism. Dual trigger with agonist plus SCG, it should be done for all kind of a patient who are having a blunted response because of the polymorphism. And document these, and while doing a patient counseling, that there is a polymorphism which can really impact your outcomes. You can justify your higher dose as a lower dose, as well as adjuvants, by explaining them that polymorphism is there, and you can emphasize on the personal approach instead of having an umbrella approach for all. Basis these, again, you can decide your gonadotropin doses. Hyporesponders we can start with a 100 to 150 IU per day. Normal responder 150 to 225, basis on the BMI also. Low reserve patients can have a 300 to 450, which these are the patients with group 3 and 4. Poor responders, group 1 and group 2, can start with 300 IU, and consider LH addition. Now, when LH is to be added, there we have 2-3 options. Either we can add HMG, or we can start only HMG cycles, or we can add HMG to the recombinant FSH, or lastly, we can add recombinant LH, which is available in the form of lot many brands are available. or we can add a combination, new combinations are coming where LH, recombinant LH and recombinant FSH are available in a prefix formulas. Now coming to the male pattern optimization, as we discuss, we need to do a sperm DNA integrity, as well as if there is poor sperm qualities are there or pure sperm parameters are there, then definitely certain adjustments in the drug can be done. We should not rely that we have ICSI, we should not boost our collar that yes, we have ICSI, why I need to treat this low sperm count or abnormal morphology or low motility patients. This is not the way to deal with it. If you have any patient with a moderate or severely abnormal sperm parameter, do a hormone analysis, do DFI, and then give them a treatment. Now, how to give a treatment for such patients? So definitely varicocele, if they're there, do the corrections. Any infections are there, put them on antibiotics. Antioxidant therapy should be there for dealing with a high DFI. And hormonal treatment, as I said, is must for these cases. Now, to standardize these, to standardize the male management, even in a mild abnormal to mild or moderate abnormality to severe abnormalities, Dr. Sandro Steves have come up with a classification just like Pasodian for the male one, and this is called Aphrodite criteria, where he has divided them into the 5 group. And group 1 who have reduced FSH, LH and testosterone level, and they can be azoospermic to severe oligospermia, and the treatment is like this. Group 2 can have a lowered semen parameters including NOA with a normal FSH and LH. This is because there is reduced gonadotropin actions and functional hypogonadism. Here the treatment is FSH monotherapy. Group 4, where there is a lower sperm parameter including NOA, where the FSHs are normal, there is reduced testosterone, and this is again because of the reduced gonadotropin action and the biochemical hypogonadism. The treatment is FSH plus minus HCG. Group 4, where lower semen parameter they are there, this is where majority of the NOA will be there. They will be having a high FSH with a low or normal testosterone. They have been classified as a functional hypogonadism, and HCG is the first therapy. As when needed, FSH can be added. And group 5 is most notorious. They have unexplained infertility. They have a normal FSH and testosterone and semen analysis parameter, but they will have a certain poor outcome even after the ICSI. And then, for them, FSH monotherapy can be used. Sperm DNA fragmentation, as I said, is going down near future, maybe in the next WHO. WHO has already recommended that whichever the clinic, if they have a facility of assessing the DFI, should do, and gradually it may come up as one major pre-investigation for male infertility. Now, who all are the indicate? So when should DFI be recommended? Any patient with unexplained infertility more than 3 years, recurrent implantation failure, recurrent pregnancy losses, advanced paternal age more than 40, severe varicocele, exposure to the toxin and any high oxidative stresses, mild to moderate semen abnormalities. All these are the patient, and as well as the paternal age, as I can say, more than 40. Those are the candidates for which DFI should be done before proceeding for the ART treatment, especially the high cost treatment like IVF and ICSI. So there are sperm sorting techniques available. In case of a high DFI, we know that there are high DFI cases to be dealt with an antioxidants, and antioxidants can be given for 6 to 8 weeks, and then thereafter we can recheck on the DFI. But still DFI is high, there are sperm sorting techniques which help us to collate those sperms where DFI is less, and there is a max is available. We can do PIXI, we can do microfluidic sorting. So there are technologies available which help us in guiding which sperms to be used for ART. Coming to the genetic analysis, we in our country have a very strict laws for the genetic assessment of the embryos. But yes, wherever it is available, we should do, especially for those cases of RPL and RIF and advanced age. So PGT-A must be done in our country. We can do only for these 3 indications. But if you have, you feel like unexplained infertility is one area which should be sorted for, which should be in such cases, because there must be some genetic abnormality because of the maybe the high DFI is contributing, or chromatin level at the in the oocytes, spindles and all being affected because of the advanced age in the mother side. So those indication in our country we are not able to do, but yes, anybody who have relaxed norms for using a genetic analysis of embryo in their country, I think even for the unexplained infertility, PGT can be done. Coming to the immune therapy, we have discussed this about, and again, as I said, we have a very robust evidences in our country now available to support that the immunological cause are there for which are the cause of failed IVF, unexplained infertility, recurrent pregnancy losses, and our recurrent implantation failure, where immune system is been tilted towards more of rejection side rather than the helper side. So what all tests we should do? We should do the uterine NK cell, we should do serum NK cells, T helper Th1, Th2 ratios also can be tested, and we can do a lymphocyte cross match also for class 1 as well as class 2. So what the treatment should be done? So there are 2 ways to do it. As we discussed also, there is a passive way of management, there is an active way of management in immunological cause. If immunological cause is there, then there are tacrolimus is available, some TNF-alpha inhibitors are there. Along with that, prednisolone, IVIG are there, which we are using it as a passive immunomodulator for those cases who go for ART treatment. But if there is an indication for IVF, we do a lymphocyte immunotherapy, which will allow us to desensitize the woman against the paternal antigens. Endometrial receptivity, the last leg of any ART treatment, where you have to individualize which woman has to be transferred at what age and all. So again, ERA can be done in case, but recent time this has lost its sheen because not much good responses and evidences has been come out in support of these the ERA, but still routine use of ERA should not be done. But yes, when you have good oocytes, euploid oocyte, but still they have failed in the previous cycle, in the subsequent cycle, you can individualize the transfer, you test around the window of implantation for those people and then can transfer. So this has a limited scope, but yes, in very selected patient where even after transferring good grade 1 euploid embryos still being failed, there can be, you can do you can test the window of implantation and then transfer accordingly. Now coming to the last last leg of my talk, which is about AI. Now AI is again is been included in our lot of judgments which we do where we do the planning of the patients. There AI can coming up and has a helping tool. I hope AI may guide us in near future and will be engaged in a lot of planning patient in the treatment planning as well as stimulation planning as well as the endometrial planning. But presently the AI is there to help us in 3 ways: identifying the oocyte, identifying the embryos, identifying the sperm, identifying the, there is a protocol AI is also there to identify which protocol and what dose should be taken up for stimulation. So AI is there. I'm not naming them because of the which are the tools available. AI tools are there for embryo selections, which help us in understanding which embryos are there, because they understand the whole journey from the timeless is very important in those patients which you understand, who have failed even with the transfer of an euploid embryos. Since the Dr. Adhika will always help be on my side on this, that even if the euploid embryo has been transferred, it's a journey where how the embryo has been developed will guide you more rather than just the euploid testing. So this is where timeless will help us, and will, because of the deep learning and the IDA score which are there with the time lapse, will guide you which embryos to be transferred. Even they are morphologically better, then this will help you in doing the some individualization. Then gonadotropin dose individualization is there. We at the Indra also using one tool for identifying, which help us in guiding what should be the dose, starting dose, and then subsequent doses for IVF. Then again, AI can help you out in various cases. Lastly, endometrial receptive assay is also AI is there, is coming in and giving us an idea. So there are ways, there are AIs there which can help us in identifying the potential in form of from embryo, from oocyte, from a genetic assessment of the embryo can also be done from AI, and lastly from the endometrial receptivity. So all these put together will help you and guide you to give the best outcome for the patient. So I hope and I feel like in the near future, a lot of our decision will be guided by AI. So, just to conclude, we should not do a umbrella sort of treatment. The strategy should be that we should have a personalized and individualized approach, because it's a very costly treatment. We should do a genetic, hormonal, immunological, and microbial profiling of IF for each and every patient, especially for those who are going for already had a history of a failed IVF. We should use technologically advanced AI wherever is possible, so that we can avoid human error. And to end up with this, few things which may be not having evidences right now, because a lot of communities are not been research has not been done. But I'm very confident that going forward, immunomodulation will be a game changer in the coming futures. Yeah, that's all from my side.
Thank you so much, Dr. Vipin. Thank you. Yes, Dr. Nicholas.
Thank you very much for a very informative presentation that you just did. I have a concern in terms of the prominent use of the antioxidants, especially for men who are trying to conceive. In the pharmaceutical industry as well have been pushing so much of these antioxidants, but I think one thing that we tend to forget, that as much as they are useful, but they can be harmful as well, because we need oxidants like reactive oxidative species to make sure that the sperm can capacitate, can get hyperactivation, but they also play an important role in signaling pathways. So what is your opinion with the current practice? Should we allow all male with infertility to go through antioxidants?
Yeah, it's a very relevant question. As I in the second slide itself, I told you that for antioxidants also, be it a coenzyme Q or any other one, they should be individualized. We should not give them very as a blanket to everyone, because first of all, you need to know where it's indicated. It's indicated only when there is a high DFI. Otherwise, avoid them. And if at all, if there is a high DFI, you can use them for 6 to 8 weeks. And thereafter, it's still, if you do a repeat DFI, and then if the things have been controlled, but it's not that the antioxidant is just the one way. DFI may have some modifiable causes. So you should rule out whether the patient is having any thyroid disorder, any diabetic is there, any varicocele is there. So all these things or any lifestyle modification if possible, or infection. If these are things been taken into control, then antioxidants will definitely will help us in reducing in ROS and control the DFI in such cases. Otherwise, there is no much role of antioxidants.
Thank you very much for that informative presentation, but I just wanted a few comments. You talked about controlled ovarian stimulation. You only mentioned agonist cycle, and now ourselves use a lot of progesterone primed ovarian stimulation with reasons. It's cheaper, it doesn't involve injections. Most literature shows that actually you use less of gonadotropins, especially for us, that's a major factor. The other factor is when you have polycystic ovarian syndrome, the results are better. They don't have, that's what literature says, they don't have clear evidence why it is so. And if you're going to freeze, then that could be the ideal. Most people are moving away from either antagonist, agonist. That's the first comment. The other one is follicular synchronization. I don't think there's clear literature about follicular synchronization. One, two, physiologically how it really works. You're trying to suppress FSH, but we know that the preantral follicles don't depend on FSH. So I don't know how that synchronization is going to work.
Yeah, I agree.
Let me just finish. That's two questions. Just put it down. Or you want to comment first?
I agree with you, dear, in some form or shape. Yes, there is a role of progesterone prime stimulation, and especially in case of where you think that cost can be optimized for, especially on the donor cases, and even normal responders. Progesterone prime has a role, and also for the mild stimulation where you think you would want to do a multiple stimulation for group 3 and 4, progesterone prime have a role. I not mention it, but because a lot of things still the things are been evolving on those lines, and antagonist is a well established. That's why I have not mentioned about it. On terms of follicular synchronization, see, any one oocyte, even if I can recruit one more oocyte because of the follicular stimulation, follicular synchronization, especially in case where there is that is only relevant in case where I know that reserves on a lesser side, FSH can kick in a little early, and then I can have some more oocyte because of just follicular synchronization. Even one follicle will have a say, will help us in getting an outcome in cases where post-student group 3 and 4 is the condition. Otherwise, there is no much role of, as I said, only progesterone primed cycle is good enough.
The other issue is on inositol, because when you look at the ESHRE guidelines, it's not there, it's expensive.
Yes.
It's not clear evidence it works, and the metformin, as you have said, can suffice. So why not use metformin? And inositol is very expensive, and there's no literature clearly it does work. There's a lot of hype.
Yes, that's why it was at the bottom of my table. Okay. Metformin was at the top of the table.
Yeah, precisely. So there's no need of inositol. It's expensive. Yes, it doesn't work. The other issue was the PGTA, because again, if it most likely is supposed to do it in the late 30s or 40s, or somebody with poor ovarian reserve, but it will depend, one, on the number of embryos you have, because if you have 3 or 4 embryos, and the issue of self-correction, embryos can correct themselves when they are transferred, then I don't see the need of doing PGD unless you have multiple embryos. There's no need. 2, there's no clear evidence that actually PGT works, actually, when you look at the literature.
So again, it's a matter of debate to do a PGT or not. You don't want to waste a cycle because we have a lesser number of embryos. Yes, you can do, but if as I said, we have a very limited indications for PGT to be done, and so those are like recurrent implantation failure, recurrent pregnancy losses, and any cases where high DFI sperms have been used. So those are the only limited cases where PGT is helpful. Otherwise, for blanket approach, I'm with you, dear. it should not be used because it adds to cost and don't give any other advantage.
Okay, thank you very much. Thank you very much for the lectures. Maybe we should give more round of applause. Thank you very much. Now the panelists will going to discuss about the strategies for setting up infertility care centers in underdeveloped countries of Africa to share their thoughts. So I would like to invite Dr. Gilbert Nibitanga, President of Burundian Association of Fertility, ART, expert, consultant, OBGY fertility specialist at Polyclinic Umigireza Fertility Service and Merck Foundation alumni from Burundi. Next is Dr. Lucas Jata, Senior Medical Officer, Maternity, Brikama District Hospital and Merck Foundation alumni from Gambia. Next is Dr. Gabriel Mulimbi, OBGYN fertility specialist, sexual reproductive health policy expert, Kabwe Central Hospital and Merck Foundation alumni from Zambia. Next is Dr. Harrison Rababanasi, specialist, OBGYN, United Bulawayo Hospital and Merck Foundation alumni from Zimbabwe. Dr. Hildegard Alois, specialist OBGYN, Muhimbili National Hospital and Merck Foundation alumni from Tanzania. Dr. David Mwesigye, consultant obstetrician, gynecologist, director of Women's Health Fertility Specialized Clinic and Merck Foundation from Rwanda. Dr. Adolf, consultant OBGY fertility specialist, head of OBGYN department, Pentecostal Hospital and Merck Foundation alumni from Ghana. Welcome our esteemed panelists. I think we have already seen what we are going to discuss, the strategies for setting up infertility care centers in underdeveloped countries of Africa. Please, Dr. Ntibanda, can you tell us a bit about what is happening in Burundi?
Thank you very much for this opportunity given to me to talk about strategies to use for setting up fertility center in underdeveloped countries such as Africa, for example, Burundi. According to my experience, the first step is training. Training is the first step to take before thinking setting up a fertility center in Africa. And after attending that training, someone who really wants to set up a fertility center must have a business-oriented mind. That is the very important thing because, for example, in 2019, when I was here in India for training at the Milan Fertility Center, it was a good opportunity for me to be trained by a specialist, Kamini Rao. That time I was very interested in knowing how to conduct fertility business because the fertility business is very broad. I remember when I was there, I was with some of my colleagues who are here, Professor Morocco, they remember it very well. That time we asked Professor Kamini to invite some business companies to come to the center. And that time it was the best time to ask them some questions about how to find some equipment, some product. And we went back to Burundi. After going back to Burundi, you know, poor countries such as Burundi, there are not too many things like medicine, product related to fertility. So, before beginning setting the first fertility center, I used the principle, do it yourself. Don't rely on other people. I start to import small medicine by myself. Because other companies, they can't accept to import small quantities because they don't see any profit inside. So I made up my mind to do it myself at the beginning, and then I set up my first fertility center, which was doing timed intercourse and IUI. And step by step, I got experience. And after 3 years, many people in Burundi was getting knowledge. They get knowledge about infertility, what is going on, until the first lady of Burundi asked me to set the first IVF center in Burundi. So that time, it was not easy because setting up such a special service in Burundi, where we don't have any company who is dealing with those products, I take the opportunity to contact one of my friends who is here, Dr. Nicolaus from Arusha. I asked him, what can I do? He really connected me with some companies, and it was very helpful. And from that time, we start to make some contracts with those companies. They came to Burundi, and we set up the fertility center. Until now, the center is running very well, and many babies have been born thanks to IVF. Thank you very much.
Thank you so much, Dr. Gilbert.
Thank you very much for giving me this opportunity. For me, considering the situation in the Gambia, I think one of the foremost that we should take into consideration is that we should start with what we have. Considering the human resources, the infrastructure, the technology, and the other resources that are available. If you consider the human resources, for example, we have few doctors that have had some training through the Merck Foundation. If we have them, and they are trained across the country. And we have these infrastructures, like health facilities, that are also built across the country. So in these particular facilities, we have like at least radiological laboratory facilities. So if you consider these doctors, the infrastructure, and then these technologies that are available, we can use them and start with this. As for me, in my hospital, Brikama District Hospital, I started like this. I was trained from Indira, Bangalore. So when I went back, I started an infertility clinic. So I used an ideal infrastructure, which is ideal for me to see patients, and then the resources that were there, like the ultrasound machine, and then the little lab that we had, I used it. And then with this, I was able to start, and then I had a very large influx of patients, because where I work is a very densely populated area. I think if with this human resources, infrastructure, and the little resources that we have, in collaboration with the Ministry of Health, and then other collaborators, and then we work and improve on this infrastructure, the technology we have, and we create further what you call human capacity building for the staff. I think eventually we will build and set up a very good infertility centers in the Gambia. Thank you.
Thank you so much, Dr. Lucas. So now this is going interesting. From Dr. Gilbert, we got the first point, that is training, I guess. From you, we got the key point as infrastructure and capacity building. Now this is going interesting. If we can get 7 main key points from the 7 panelists, I think we can have a lot more fertility centers across Africa in the next 1 year until we meet again. Please. Dr. Gabriel.
Thank you very much for giving me this opportunity. I would like just maybe to discuss what happened to me. Is at the beginning, when you start the training, you need to inform your management at the hospital that I'm starting a training under infertility. And when you have completed your training, you have again to go back and inform your management, have completed, and I've got the idea to start a clinic or a specialized clinic within the hospital, within the settings of the hospital. So it's better you choose a day where it's not very busy, and you propose to your management, because you need a day where it's not very busy, because you need more time to sit with the patient, because they need more counseling. They need also privacy. So we need that room which is going to give you that environment. Then after that, you need also to discuss with them that I'm not going to bring new thing or to give you another budget on top of what is existing. I use the same building, the same furniture, the same register. I use the same personnel just for the beginning. And your idea maybe is to start maybe for diagnostic and also referral, where there is IVF for the patient who need to be referred. So for another point, you need to really know what investigation you can do within your setup, within your hospital. And if you cannot do any investigation, or for those investigations you cannot do, you need to look around your area where you can refer those patients to conduct those investigations. That is very key also. And also you need to present to your management a plan of improving your clinic, because you cannot just remain at the level of basic diagnostic. Yeah, I think that's what I can say. Thank you very much.
Thank you. So I think collaboration and the right set of services, selecting the right set of services that you can offer, and collaboration with other organizations around you is the key point that you suggest. Thank you so much. Dr. Harrison, please.
Thank you very much for this opportunity. I was trained in 2019 in India. Then I also did postgraduate diploma with the University of South Wales. And these two qualifications gave me an opportunity to be working with somebody who already had an established IVF clinic, and the experience has been very valuable for me. I've not yet managed to set up my own IVF clinic, so I'm just going to talk about some of the challenges in my country that we have to overcome for you to set up an IVF clinic. The first one is speaks to the cost. The cost of setting up buildings, because you really need custom-made buildings, and also the cost of procuring the equipment. It's a huge barrier, and in the public sector, at this point in time, we don't have any funding for fertility treatment. So it's a huge barrier. We are exploring possibilities of partnering with the corporate world, so that those that are trained can actually set up. But so far, we have not yet made any significant headway. And then the other issue pertains to the availability of support staff, especially the embryologists. I know that in our country, a few embryologists have been trained, but they've all left our system. So those that are doing IVF primarily have to import embryologists from neighboring countries, particularly South Africa. And for that reason, they're having to do batch IVF. And then you also need to have very good medical laboratory support. Is the lab there? What is their turnover? Are you able to get your results in time during the cycle for you to make important decisions? And then we also have a challenge of drugs, like what Gilbert said. Our pharmacies, our pharmaceutical companies are not stocking the drugs that we use in IVF. And you find also that most of these drugs are actually not registered by our pharmaceutical regulatory authorities. So you actually have to get a special permit to import these gonadotropins. You have to sign what is called, what is popularly known as the Section 75 in our system, for you to be able to get the drugs that you need. And then there is also the issue of how, as medical practitioners, we approach medicine as a business. There is this competitive approach rather than collaboration. We really have a serious challenge. So considering the cost that is involved in this, it would have been better to come together and work as teams so that you can be able to raise what's required. But culturally, in our setting, this doesn't. It's very rare to see people coming together to come up with an IVF clinic. And then we also have a challenge of power supply. It's erratic, and as you know, for an IVF lab, you really have to have consistent power supply. So it's one of the things that, one of the barriers that has to be sorted out. I thank you.
Thank you so much, Dr. Harrison. Please.
Okay, thank you. In our country, Tanzania, we have at least 9 IVF centers, one of which is a public one. And the entire process for setting up of that public IVF started with the idea was sent to the hospital board. Then we identified the old building, which was renovated, and the lab was installed. Installation was done. Then it took about 5 years to be complete. Initially, it was supposed to take about two years to be completed. But unfortunately, because of funds, it was not possible to be completed on time. And training of the personnel, we got the opportunity to be trained by Merck alumni. Dr. Nicholas trained us even before we joined the Merck scholarship for embryology training. Then later we started the service officially last year on November, and we have done at least 3 cycles. The first cycle, we had 5 clients. The second cycle, we had 4 clients. And the third cycle, we had 4 clients as well. But the challenge is we have a lot of clients with infertility, but the problem is the cost is very high because the drugs are not available, and the system for getting the drugs and the consumable at a cheaper price is not there. So those are the challenges. The funds to start, maintenance, buying, and if there is a way we can improve to get the drugs so that the IVF services can be at a cheaper price. Because people, they have notion that once the IVF service is available in a public hospital, it will be available at a cheaper price compared to the private one, which is not. So we have another challenge is that even the culture around people, religious issue, people, some religions, they don't agree on IVF services. So that's another challenge. And also male participation is also difficult. Once we call the men for investigation, they don't come. Those are the challenges we are facing. Thank you.
Thank you so much. Those were some really ground level practical challenges that we are almost in every region and place. Please, Dr. David.
Thank you. Thank you very much, Merck Foundation. Thank you for giving us this opportunity, and also those following us online. I can tell you that helping infertile couples is just about motivation within yourself. Identify yourself as a key player in whatever settings you have. When we got training for Merck Foundation, we saw that everything is possible. You know, treating infertility is like any other professional. Like if you want to be a best footballer, you have to identify yourself. Also, if you want to be a best fertility treatment gynecologist, identify yourself. You may be in a government setting and like you're employed by the government or any Catholic institution, but let those around you know that you have that passionate to treat infertile couples, because infertile couples in our setting, they are just looking for who can comfort them, whom they can talk to. You find that when you're in a government hospital, you find that you have PPH, you have cancer, but when these mothers, couples know that, even your colleague know that you have that passionate for identifying, talking to infertile couples, you're going extra mile to see them, you find that even your colleague will say, Dr. David is one with you to manage infertility couples. So they find cases and they want to just group them to you. So that is the advantage. So when you have the training from Merck Foundation, you have that weapon, you have that confidence. Please stop complaining that you don't have materials, you don't have what. What you have is the training. Let it, if you're employed by some people, let those people know that within infertile treatment, you're the best. Just take your time, love them. We have social medias, you have WhatsApp. When you're in that WhatsApp group, just post yourself. Say no stigma to infertile couples. Those things, they will pull you to the public who get to understand. Call the media group. Let one of the media group in your country get one person. Let that person come to you, interview you, and you inform the public. The public will say, oh, Dr. David is interested at managing, explaining. You know, in my country, when I give talks, they come to, oh, doctor, we saw on the television, on the social media, that you're explaining about diminishing ovarian reserve. You're explaining about IUI. Oh, they start coming to me. So that kind of thing will sell you, and you will tell them, because these couples, they want to know whom should I approach, because you don't have to, you give them time, approach them. So whereby, if you want to set up your clinic privately, you can even have private practice in other setting, whereby these people find you. So like that, slowly, if you can't manage them, look at your neighboring country where Nicholas is or another person. Call, if you're like a consultant like me, identify your embryologist is, you do some kind of IUI. Do you know that when like we come in such a conference, because I have that passionate, I may go with few of the IUI catheter like here, or even where to get them for my pocket, and I treat. When I do one IUI, which I took, and I do one patient, you find even others are coming to me. So if you have passionate, courage, everything is possible. Slowly, equipment will come, but whatever knowledge you have, you are ready to help these couples. They want someone whom they can tell, cry, listen to them, counsel them in professional point of view. You understand? Please, in our setting, let us help these couples. They are vulnerable. At whatever thing you have, the little you have, you can spare that time and treat them. Treating infertility is like other setting. If you're treating malaria, you can treat malaria at health center. If you find that it's complicated, you transfer it to the district hospital or referral hospital, even tertiary. So infertility, treat them where you are, the way you can. If you find that then let them know that what you have, you can treat them. So if you explain to them that there is other option, transfer them to neighborhood country, your colleague from Merck Foundation, or other setting, but you've done a great job. These couples have money, but they don't know how to use it, how to be treated, at what cost. So use what you have in the same place, and identify your colleague for another country or region who can help that person. So they are stranded in so many treatment, witchcraft, herbals. There's some herbal, they deceive them. They are in that cycle, spiritual. So also let them know that you can offer that professional, and they divert. So with the train for Merck Foundation, we can do something without complaining.
Thank you so much, Dr. David. Thank you. I'd like all of us to have a special round of applause for one name that kept recurring in almost all the panelists' discussion, Dr. Nicholas Mazuguni. Can we please have a round of applause for him? He seems to have a silent but very significant contribution. Next, we have Dr. Egbefome Mensah Adolphe. Sir, I'd like to ask you about 2 challenges and 2 key strategies only regarding setting up of infertility care centers in your country, Ghana.
Okay, thank you very much for this opportunity to address these questions. Compared to other illnesses like malaria, maternal mortality that bring a lot of mortalities, fertility has not been seen as in that light, so there are no policies regarding it. So challenges like the costs and lack of expertise has been ongoing. However, Merck Foundation has set up the blueprints, has shown us the way. So I got my training in 2023. So when I got back, I have to start something. So where I found myself, we don't have laparoscopic setup and all that. So what I did was to get a vaginal probe, transvaginal probe, that helped us in the assessment through the cellular infusion sonohysterography, in assessment of the fallopian tubes and also the whole uterus and the ovaries. And then we also got things for like the AMH to check the ovarian function and all that. And our health system is set up in a 3-tier system, the primary, secondary, and tertiary level, just like the hub and spoke model. So what I did was that I went around some facilities around to tell the nurses, the midwives, the doctors there about my expertise, and because they are the frontliners in those places. So they kept referring such cases to me. And what I also did was to engage the community radio stations. Every 2 weeks, I go to talk about fertility, to stigmatize and also educate the women on the fertility. You'll be surprised that some women, although they know they have the flow up and all that, they are not able to tell when they are exactly ovulating, how to time intercourse. So with all that, I also partnered with some private advanced IVF centers where some of my patients that will require IVF, I send them up there to have the treatment done. So I also engaged some doctors around, trained them. When I have the patients, I also trained them how to do the scan and all that. And I've gotten significant results. So looking at this very well, if you want to, like I said, Merck Foundation has started, if you want to make it a national issue, apart from the policy, I think we should set up training centers in Ghana, like the simulation centers that we had in Indra, across the 3 belts of the region. That will help not only train the doctors, but also the other nurses and all that to help with the management. And then so that has to do with the infrastructure. And then the other main that Dr. Vipin said is that the main problem or the main cost has to do with assimilation. With the fluctuation of our currency, the exchange rates, it's really made the importation of the drugs, the IVF drugs, very expensive. So if governments can partner with the private sector, maybe give a tax even for some of these drugs to be produced in the country, it will go a long way to keep down the price of the IVF costs. So in summary, setting up the simulation centers and partnering with the private pharmaceuticals will help a long way to beat down the cost and make it IVF accessible. Thank you very much.
Thank you so much, Dr. Adolphe. So I understand that setting up of local training centers within the country and cost-cutting techniques are the 2 strategies that you suggested.
Thank you.
Thank you so much.
Thank you too.
Yeah, I wanted to give some contributions in terms of this. I think that one of the things we need to do is to ask governments to encourage the pharmaceutical societies companies to start manufacturing those fertility drugs in our countries. Egypt has done this successfully, and so the price of IVF in Egypt is very low. So is South Africa. Now we are also encouraging our own government in Nigeria, rather than importing this drug, to start manufacturing it in our country. India has done it successfully. So, and it should be possible at least to have 1 or 2 centers in Central and East Africa that can be manufacturing this. In terms of manpower development, we have started the Institute of Assisted Reproductive Technology in Nigeria in collaboration with the University of Lagos, where we can now train the human capital in embryology and in the doctors in ultrasound scan and reproductive endocrinology. So we are hoping that this can be accessed by people. It's available, and I've passed my cards all round. If you don't have it, make sure you get it from me before I leave. And lastly, just as you were giving an example of Nicholas in Tanzania, he has been able to catapult, and Tanzania is now a member of IFFS, which is the International Federation of Fertility Society. I'm challenging everyone here from Burundi to Rwanda to take advantage. Gambia has joined the IFFS as well, because that exposes you to what goes on globally in this field. There are online training infrastructure, so you don't have to travel. You can access all this online. Even this simulation treatment, you can do so online. And then when they have the major conferences, which is almost every year, you can get yourself there and be training some of this. And these are areas in which you can use to develop yourself. And as I've told Liberia and other, if you want to develop all you need to do, get yourself together who are in this society or interest group, form a working group or a WhatsApp group, then I can advise you on how to set up your constitution and become a member of IFFS, and also the African Federation of Fertility Society. So you are just not a 1-man or 2-man in your national country. You are also relating and networking with Africa and networking with IFFS. And the Merck Foundation partners with the African Reproductive Care Society, which gives opportunity and collaborates with Merck Foundation to get us access to all this. So please make use of these advantages. Thank you.
Thank you so much for your valuable inputs, Professor Ashiru. For people joined us online, please note that we are taking a lunch break. Thank you.
For this afternoon session, I'll be your moderator. My name is Dr. Gabriel Mulimbi. I was introduced in the last session in the morning, and I'm from Zambia. Allow me to call Dr. Edem Yadzi. He's an obstetrician gynecologist, fertility specialist. He's also a founder and CEO of Lister Hospital and Fertility Center, and immediate past president of the Fertility Society of Ghana. Is going to discuss with us this afternoon hormonal and metabolic syndrome in reproductive health, evidence-based approaches in management of polycystic ovarian syndrome, and other endocrine disorders in obstetric and gynecology. Over to you, Prof.
Good afternoon. Yeah, so as you can see, the topic takes 5 lines, but let's get on to it. No conflict of interest, no financial or commercial interests. That's going to be the overview. We'll have a little on the introduction, look at the keywords, a brief history of polycystic ovarian syndrome, initial diagnosis, and then how the diagnosis has evolved over the period, and then evidence-based management as at current guidelines, and management, a brief touch on the management of the other endocrine conditions or disorders, and draw a conclusion. Yeah. before Fleming discovered penicillin, the greatest thing that would kill you is infections from other organisms. And then when antibiotics came and they were very broadly effective, the biggest thing that would kill you was then cancer. But now we know that globally non-communicable diseases account for more deaths annually than cancer. Metabolic syndrome, the risk factors significantly increase your likelihood of developing non-communicable diseases. So it means that they're becoming one of the things that can kill you. Polycystic ovarian syndrome is the commonest endocrinopathy in women worldwide, and beyond the reproductive challenges, have major metabolic dysfunctions that can lead to metabolic syndrome, among other health issues. So, how far are we addressing these health challenges as healthcare providers? The metabolic syndrome is one of the fastest growing non-communicable disorders globally, and it's a precursor of the non-communicable diseases. It is a cluster of conditions including high blood pressure, high blood sugar, high level of lipids, excess abdominal fat. That increases your risk of cardiovascular disease, strokes, and type 2 diabetes. And this is of interest to us because this syndrome impacts reproductive health negatively by a disruption of the hypothalamo-pituitary ovarian axis. Now, polycystic ovarian syndrome is characterized by chronic ovulation dysfunction, resulting in irregular menses, hyperandrogenism, leading to high levels of testosterone and its external manifestation of excess hair, facial and body, and acne, male pattern baldness. And so the presence of polycystic ovaries on ultrasound and high serum level of anti-Mullerian hormone would complete the essential presentation in addition to the two mentioned earlier. What about the endocrine disorders in obstetrics and gynae? I'm trying to cover the whole topic given. These are conditions affecting the hormonal systems that can impact pregnancy, childbirth, and the female reproductive health. They result from any interruption of the hypothalamo-pituitary pathway of hormone signaling, production, and their effect on the target organ. But we'll limit ourselves to those affecting reproductive health. Evidence-based approach. Okay, a little bit about the history of polycystic ovarian syndrome. What you'd normally find is the mention of Stein and Leventhal, 1935, in the US, publishing the first modern-day case of PCOS. But if we go back into the books, way back at the time of Hippocrates, before Christ, 460 to 377, he wrote in a book, Diseases of Women. But those women whose menstruation is less than 3 days, that's oligoamenorrhea, or meager, are robust with a healthy complexion and masculine appearance, hyperandrogenism, yet they are not concerned about bearing children. Who said they were not concerned? They just couldn't, nor do they become pregnant. So it's a disease entity that had been recognized long in history. But what have we done about it so far? So, after 1935, over the next 4 decades, most research was into the endocrine background of the condition. Then 1990 to 2000, the last 2 decades of the 20th century, shifted the research into understanding the metabolic background of PCOS. In the 21st century, Interest has been more into the molecular biology and the genetics to unravel the etiology and pathophysiology of this disease. Currently, there are about 30 genes associated with the development of PCOS. However, the pathogenesis is complex, multifactorial, and not properly elucidated. Okay. We gave some prerequisites originally, but there have been some diagnostic flaws as time has improved. With better ultrasound resolution, 20 to 30% of those who were previously thought to be PCOS were found that they were regularly cycling, normally ovulating, but were wrongly captured into that category. And this included significant number of younger people. And these people were inappropriately tagged as polycystic without prerequisite clinical or biochemical correlates. Most premenarchal teenagers, if you did a good ultrasound, you'd find that they'll have more than 12 visible follicles. But the original diagnosis was limiting it to 10. It should not be more than 10. So you would capture a lot of this in there. And that will lead to unnecessary investigation of these people, inappropriate management, and even stigmatization. First of all, the diagnosis itself is a big, bizarre, you have polycystic ovarian syndrome. Wow, that's huge. And so you felt already you had some disease that was not manageable. The sonographic criteria embedded in the Rotterdam Consensus had been challenged. De Wiley and Co. 2011, and then 2013 by Lujan et al., even 2014 by the Androgen Excess and PCO Society. They found out that the median follicle number per ovary in women of reproductive age was about 13 to 16. So at the time that this was being cut off at 10, it means that there are going to be so many people considered as PCOS. So they strongly advocated for increasing it to the threshold of 25. This was also supported by the International Society of Ultrasound in Obstetrics and Gynae consensus group. However, I think the accepted number now is 20. So, with all that confusion, in 2018, the International Evidence-Based Guidelines for the Assessment and Management of PCOS redefined and replaced that of 2003, which was the Bologna Consensus. This guideline development engaged a lot of professional societies, consumer organizations, and multidisciplinary aspects, including even women with PCOS directly. And their purpose was to improve the accuracy of the diagnosis, reduce unnecessary testing, increase the focus on education, lifestyle modification, emotional well-being, and quality of life. Emphasizing evidence-based medical therapy and cheaper and safer fertility management. So, at that time, it was decided that the biochemical hyperandrogenism should capture elevated total of free testosterone or the calculated free androgen index, dihydroepiandrosterone sulfate, and androstenedione. But not just with any kits. These days there are so many things on the market you can use in testing. They thought, for this, you should use liquid chromatography or mass spectrometry. And then for clinical hyperandrogenism, they thought the modified Freeman-Galway score greater than or equal to 4 up to greater than or equal to 8 was to be used. However, you should be cognizant of the fact that some ethnic groups may be naturally or genetically more hairy, like some Asian and Middle Easterns are naturally more hairy than Caucasians or some Africans. So that when you use that, then be careful to consider that aspect as well. Then for oligoanovulation, the cycles should be greater than 35 days apart or less than 8 menses in a year. Yes, that's what I said. With polycystic ovarian morphology, then it must be greater or more than 20 follicles per ovary, or either. And the volume, 10 centimeter cubed. And they also specifically mentioned that you must be using an ultrasound with frequency greater or equal to 8 megahertz, because today's ultrasound can see much better than those of yesterday. Now in 2023, there was a further improvement on the diagnosis and management. This was a huge group put together under the auspices of Monash University of Australia, together with the ASRM, ESRE, Endocrine Society, European Society of Endocrinology, 39 other professional bodies, consumer organizations, and PCOS patients over a period of about 9 months. It's a huge document that came up with various recommendations. These are a summary of their recommendations. PCOS should now be diagnosed using the revised 2018 consensus Rotterdam criteria, which had now been updated to evidence-based criteria. In adults, the diagnosis requires presence of 2 of the following: clinical or biochemical hyperandrogenism, ovulatory dysfunction, polycystic ovaries on ultrasound, or elevated anti-Mullerian hormone levels after all other causes have been excluded. In adolescents, however, both hyperandrogenism and ovulatory dysfunction are required because ultrasound and AMH have poor specificity in this younger age group and therefore are not recommended. In the adult ones, diagnosis is made, assessment and management should address the reproductive, metabolic, cardiovascular, dermatologic, sleep, and psychological features of this condition. A lifelong reproductive health plan focusing on preconception risk factors, healthy lifestyle, prevention of weight gain, optimizing fertility by consciously looking for risk factors of the metabolic syndrome through its disruption of hormonal regulation affecting ovarian function, fertilization, and implantation. The increased risk of miscarriage even after pregnancy is well known in this group, and efforts must be made to keep it under check. Then there's high risk in this group of developing gestational diabetes, preterm birth, and other complications. Now, peri and postmenopausally, this group as well have an increased risk of endometrial cancer from the high level of exposure of the endometrium to estrogen throughout their lifetime. Even though it's not an absolute risk, you should still have that in mind when you're managing them. Depression, anxiety, eating disorder symptoms are significantly increased in the PCOS patient. Should be screened, psychological assessment made, therapy offered. The impact of clinical hyperandrogenism and eating disorders on body image can also affect their quality of life. And you need to be aware of that. Currently, the dissatisfaction with the PCOS diagnosis and care is quite high. So it's important that we raise the awareness through educating the public, not just the public, but even the doctors, so that they can pick out these people early and refer them for early intervention. Shared decision-making and self-empowerment is integral to the model of care. So once it's seen, get the person involved in the decision-making of how you provide that care. Supporting healthy lifestyle, focusing on overall health, preventing weight gain, and weight management are all part of the management process. Yes, there's still room for pharmacological agents in treatment. The combined oral contraceptive pill are first line for menstrual irregularity, because young ones may be brought to you with this condition. At that time, the interest is not necessarily in having children, but being normal like the other colleagues who are having their menses every month, and they get it once in 3 months or even once a year. I've had somebody like that before. So you can put them on the pill. Let them know it's not because you think they are sexually active, but it's just to give them a period. Because in our part of the world, the notion is it is bad to be on the contraceptive pill, because that's an indication that you're already having sex. But that is not the reason why we are doing this. Preference should be given to the lower dose preparations to limit potential side effects. Yes, what about metformin? Yeah, it's recommended for metabolic features and has greater efficacy than inositol, but it's not routinely recommended for pregnant women with PCOS. Other measures, laser therapy for hair reduction, anti-androgens, where other management procedures are ineffective, can also be considered. Okay, what about the other endocrine disorders? Yeah. So that's why I said it's a big topic, because then it starts from head to toe. The hypothalamic-pituitary axis of the endocrine glands, the hypothalamus and the pituitary are the engine of the endocrine system in the body. The hypothalamus is responsible for maintaining the body's internal balance, heart rate, blood pressure, body temperature, fluid and electrolyte balance, appetite and body weight, sleep cycle, and all of that is the muscle regulator. This is a slightly busy slide, but I just brought it to show the 3 levels of hormonal regulation. At the hypothalamic, the releasing hormones are produced. Corticotropin releasing hormone, thyrotropin releasing hormone, the gonadotropin releasing hormone, prolactin releasing and inhibiting hormones, etc., and then the growth hormone releasing hormone. That's somatostatin. Now, That's the first level. The hypothalamus produces all these releasing hormones, which then go down to the level of the pituitary and get them to produce their stimulating. Each one of the releasing hormone produces their stimulating hormones, which then go to the other glands now, the adrenals, the thyroid, the testes, the ovaries, etc., to produce their effect. Yeah, so that's a list of the various releasing hormones. So these are transported to the anterior and posterior pituitary, prompting the release of the secondary hormones. And these can affect various organ functions. The secondary hormones now are transferred to the glands or the organs, where they bind to the membrane or the nuclear receptors of specific targets, and then lead to the release of other hormones, which then provide a specific result, as well as exert a negative feedback control on the releasing side. So hypothalamus will produce gonadotrophic releasing hormone, which will come to the anterior pituitary, produce luteinizing and follicle stimulating hormones, which will then get to the testes or the ovaries, and then produce testosterone or estradiol, which will then get attached to the target organ to produce what it has to produce, as well as provide a negative feedback at the level of the pituitary and the hypothalamus. For the purposes of reproductive health, we would focus on these pituitary hormones, and I think I just did that. Gonadotrophic hormone producing, follicle stimulating and luteinizing, and then estradiol and progesterone, and as such. So, how do you manage hypothalamic disorders? You need a good history, examination, and investigation to make a good diagnosis, first of all. The investigations will include various hormones working backwards. So you now start with estrogen, progesterone, go back to secondary level, FSH, LH, before you go to imaging. With imaging, the CT scan or MRI for the pituitary would give you information as to what's happening up there. Ultrasound is also useful, of the thyroid gland or the adrenals. Occasionally, you may need to do fine needle biopsy if you suspect malignancy. What about treatment? This may include surgery or radiation for tumors like prolactinomas, or treatment may require hormone replacement, whether it's a deficiency. For instance, hypothyroidism, you provide thyroxine. Appetite suppression medication may be required, dietary plans in case of overeating, and then obesity medication, quite popular these days, may be used, or bariatric surgery where necessary. Now, what do you do about thyroid disease? It's either too much or too little. It's managed in pregnancy towards euthyroidism, or just any time you want the thyroid to be in the normal level. So supplementation where there is hypo, or you may control with proper thyroxine in the first trimester, changing it to methimazole in the second or third trimesters. But then radiation or surgical resection may be considered. Diabetes, the management of diabetes mellitus, either pre-existing or gestationally induced, focuses of optimizing glycemic control to prevent complications. We've always known it requires multidisciplinary team approach. with lifestyle modification, getting your dietitian involved, your endocrinologist, and you may use metformin if not too severe, or insulin may be necessary. Adrenal disorders, these are rare in pregnancies, but associated with significant maternal and fetal mortality or morbidity if not properly managed. With congenital adrenal hyperplasia, this will cause fetal androgen excess, especially virilization of the female fetus. However, the placenta protects the mother against the androgen exposure. Metabolic syndrome is one of the commonest non-communicable diseases today. The pathogenesis of polycystic ovarian syndrome is complex, multifactorial, and still not very well understood. The complications of polycystic ovarian syndrome go well beyond the reproductive challenges that we face as gynecologists and involve several other metabolic dysfunctions. We need to look at the bigger picture of all the possible complications once the diagnosis is made and educate our patients and involve multidisciplinary teams in their long-term management. Thank you.
Thank you so much, sir. Dot in time.
Sorry, I had to rush through it because it's a huge topic, but I tried to touch on as much of it as possible. And when it's question time, we can address.
Thank you very much, Dr. Hedem, for this fantastic and beautifully presented topic, and very complex, but which give us always hope. At least when you see a patient with PCOS, you say, oh, I've got letrozole to give, and the patient can conceive. Our next presenter for today will be Dr. Rinoy Sridharan. He's going to discuss with us minimizing risk of OHSS, prevention, and embryo transfer strategies. Over to you, Dr. Rinoy.
Good afternoon, everyone. Once again, let's have a quick look at how do we minimize the risk of OHSS and what are the embryo transfer strategies. I'm pretty sure most of you must be aware of how to manage it, but we'll just be going through what are the current guidelines and what we can do in these scenarios. The aim of an IVF cycle, besides helping a patient to conceive, should be to the control ovarian hyperstimulation that we do. You need to prevent a premature LH surge, and the second thing is to avoid OHSS, because that is a dreaded side effect of IVF, because of which even many patients today, they are not interested in going for IVF, because when they search in Google, what are the side effects of IVF, this is one of the things that pops up, and because of which people get scared, because they read about ascites, they read about breathlessness, and all the complications, and they eventually have a lot of fear in their minds. So, yeah, death eventually, correct. So that is how the use of agonist came in, and then later on we had antagonist, like Dr. Vipin had said a while ago, that initially we used to do a lot of paracentesis, 4 liters, 5 liters. When we're in undergrad, we study that the amount of fluid that you must drain at a time is probably maybe 1.5 liters or max up to 2 liters. But when you do agonist cycles, it's like the more you drain, the more comfortable your patient will be. And secondary OHS is an even more dreaded thing. So that's why we have the freeze-all strategy now. So we look at this point through two case scenarios, this whole presentation. One is a 30-year-old lady with history of 3 miscarriages, and she was referred to us with severe abdominal distension and respiratory distress. She had tachycardia, and her oxygen saturation was dropping. It's at 90%. So there was reduced air entry into the lungs, and there was a severely distended abdomen with evidence of ascites, and she is a known case of polycystic ovarian syndrome, and she was on gonadotropin injections for infertility treatment, which continued even after she developed moderate fluid in the abdomen. So that's a sign. Received the HCG trigger 10,000 international units, and followed by a fresh transfer, which was almost 15 days ago. 8 days after ET, she developed uneasiness and got herself admitted, and that is how there she was treated for hypotension, again with a lot of IV fluid directly, and this aggravated her condition, and 6 days later she was referred to us. Now this is another case scenario, that is a 28-year-old egg donor, and with 2 living issues, and AMH is 3.5, and the ovarian stimulation was started from the day 2 of a scanty cycle, that is important, and 16 follicles developed eventually, and she was planned for womb pickup. On the day of trigger, we had fluid in pelvis and a picture like this. So what to do in such scenarios? So we are dealing with OHSS, or ovarian hyperstimulation syndrome. So it is basically ovarian enlargement and the overproduction of certain vasoactive substances along with the ovarian hormones, and you have the hyperpermeability state, which is what is responsible for this fluid accumulation in the abdominal cavity and sometimes in the thoracic cavity as well, and leading to the signs, symptoms and complication, and it is the second most complication, most common complication. Often it is underreported. Many a time we've got so used to managing it that we just manage it and we don't report it, and the severe OHSS, some of the data that is there is around 1 to 2%, and some hospitalization, that is for the severe OHSS, is around 0.3% according to some data. Currently, we have around a 1% incidence of OHSS put across all our clinics, at max 1%. So this is just picture showing all the hormones that are released, and these are the culprits. Basically, this VEGF is something that is produced through various pathways and which can cause increased capillary permeability, and you have the eventual capillary third spacing of the fluid, which will cause tissue edema, causing your ascites, hydrothorax, and hypovolemia. And this is where, like for the first case, she was pumped with fluid, and all the fluid was leaking out, worsening the condition. Yeah, so this is just an interplay of all this, the VEGF, HCG, increased VEGF, and your local factors, and that is how each of the drugs which have been used for management of OHSs come into play. So how do you classify it? I think all of us know how this is managed, means how it is classified. You have mild, moderate, severe, and critical. Based on various clinical and lab parameters like oliguria or anuria, the creatinine clearance or the creatinine levels, renal failure, thromboembolic phenomena, ARDS. So these are some of the factors which help us distinguish. Classification by disease onset, you can do the exogenous or endogenous. So exogenous is those cases where you've given an HCG trigger, and the endogenous ones are which happen due to the internal HCG levels peaking, and the high peak E2 levels may be more than 3,000 or 3,500, and high gonadotrophin doses means exogenous is always associated with this, and when you have the endogenous HCG, it is due to a singleton or multiple pregnancies. So this is more common in your fresh transfers. So what are the risk factors? A young lady less than 35 years of age with polycystic appearing ovaries with asthenic habitus and high serum estradiol levels more than 4,000, more than 3,000, 3,500 also, as the SRM says. And multiple stimulated follicles may be around more than 20 recovery, and also you can see a necklace sign on ultrasound with a pregnancy, or if you've given HCG for luteal support and GnRH agonist down-regulatory protocol where you've mandatorily got to use HCG trigger for follicular maturation, and a high serum AMH may be more than 3.6. 3.3, 3.6. So who are at lower risk? Basically older age, hypogonadotrophic with a higher BMI, a low serum estradiol, poor response to gonadotrophin, fewer antral follicles because your peak E2 levels would be lower, progesterone or no luteal supplementation, clomiphene citrate or HMG protocol. You can have these, but each case could be different. Now coming to the main topic, that is how do you prevent this? Primary and secondary approaches. So primary is basically it starts off at your first visit itself. When you plan your patient for IVF, you need to identify your at-risk individuals. You can go back to that chart. Mostly the PCO patients, you have to be careful with your doses. Earlier we had this theory that you give higher doses, get more oocytes, and there you do more fertilization, get more embryos. But today it's more of a quality-based thing than just quantity, because you are basically playing with the life of the patient. Now, choose your stimulation protocol wisely and more physiological trigger with shorter half-life, that is your DECA trigger. Now, stimulatory agents and OHSS, so similar incidents, whether if it is with FSH or HMG, lowest possible gonadotropin dose should be used. You can use hormonal guidance to decide the dose which will give you. So we are working on some of those protocols and we are incorporating AI into that as well. Now, agonist protocol with the use of HCG trigger has a high risk of OHS. This is what we were commonly doing previously, but now we have all moved almost completely to antagonist cycles. It's only in very certain scenarios where antagonist cycles have failed multiple times and we want something to do with quality that we sometimes go for agonist cycles. Otherwise, it's always dictum is antagonist protocol with GnRH agonist trigger. And if you are having a high E2 levels or you're expecting a high retrieval, in these cases, just stay away from your HCG. Now, choice of trigger. Your multifollicular development and high estrogen milieu, that is dependent on HCG for development of OHSS. So your HCG trigger will take at least 6 to 9 days to clear from the body. So please keep that in mind. So what can be done? You can give, so we, many a time, this is the only cycle that the patient may be affording. How can I go ahead? I should not have any loss of follicles. There should be maturation. So if you're worried about that, you should probably go for this or even lower dose you can go for maybe 1500 units. That may also suffice along with your DECA trigger. That is your recombinant and recombinant LH trigger. It is more physiological but not very well studied. Then of course you have your agonist triggers like buserelin, triptorelin. We commonly use triptorelin 0.2. You can use leuprolide as well. This is the basic hormonal profile that is there in a menstrual cycle. So you have your LH surge and you have the maturation taking place side by side. And if you look at this, your HCG, it takes quite a while to actually clear off from the body. So, and if you look at the GnRH agonist, you give it over here, you have a peak and then you have a fall, and that is is how it acts. So that is why it's a good option in these cases where you feel that there might be OHSS. Now, what is the secondary prevention strategies? One is, of course, early identification. So when you're doing an ultrasound, look for fluid accumulation, look for if the patient is getting uncomfortable, vomiting, a feeling of fullness in our abdomen, you should look for fluid in the abdomen. Cycle cancellation, we rarely do that. Probably what I would advise is see if you can manage it conservatively and then try to pull on the cycle, plan for a frozen embryo transfer. But of course, I agree with this thing, and the freeze-all strategy that is there, your lab needs to be that well equipped to give you a good thawing success rate. Because if you're thawing any of the media companies that are there, if you ask them what is an optimum success rate for thawing after freezing an embryo, so they'll say if you're able to retrieve around 90 to 95% of your embryos, then you're good to go. But if you find that your thawing strategies or your embryologist is not able to give you at least 85 to 90%, probably you should rethink it. Then in that case, what you probably could do, reduce the dose of gonadotropins and give a lighter dose of HCG. If you want, you can support it later with luteal support, and that way you can prevent the occurrence of OHSS. Now, what about this coasting? So coasting is a strategy that was earlier used. So you can go up to, there is evidence that it's a bit old, but there is evidence that you can go up to 4 days without hormonal stimulation. We occasionally do use coasting, that is cutting down, means avoiding the dose of gonadotropin for up to 2 to 3 days to bring down the peak estradiol levels and then triggering so that we can basically reduce the chances of your OHSS. Embryology strategies. So if a patient is showing an early sign of any sign or signs of OHSS at ovum pickup, fresh embryo transfer leading to pregnancy can be can lead to life-threatening OHSS and eventually death. And embryo cryopreservation, it will allow the self-resolution of OHSS, and transfer can be done 1 or more cycles later. Next, prophylactic use of, Yeah. So coasting, this is what I was talking about in patients with dangerously high serum E2 levels, say more than 3000 or more than say 25 to 30 follicles which are seen developing on ultrasound. And if the size of the leading follicles are more than 15 mm, generally these follicles will continue to grow. You don't need to you don't need to panic thinking that those follicles need the gonadotrophin. Without that, they are just going to go into atresia. They do not. So the larger follicles will continue to grow. The smaller ones will undergo arrest or atresia, and you can withhold the gonadotrophin till the E2 levels at least come back a little bit down, and then for up to less than four or up to 4 days does not compromise the cycle outcome. Like I said, it's a bit old piece of evidence, but it is still available. Prophylactic use of colloids. So now suppose you have seen that your patient, you have done your pickup, or your patient has done a pickup just 2 to 3 days back, and she has got significant fluid in her body. So what is the basic point in using colloids or hydroxyethyl starch or any sort of colloid solution? It's basically because the distension that we are seeing is due to the collection of fluid in your third space because of increased VEGF and increased capillary permeability. So your third space loss and intravascular volume depletion due to increased capillary leak, it is the hallmark of OHSS. So you want to expand this volume, use colloids. Please do not pump fluid seeing that the patient is hypotensive, because all that fluid is just going to leak out and you're going to worsen the situation. If there is fluid only in the abdomen, you're going to make sure that there is fluid in the thorax as well. So avoid that. So just use colloids, and you can use IV albumin as well besides hydroxyethyl starch. So that will increase the intravascular pressure, oncotic pressure, and it will minimize the capillary leak. And we, as a protocol, we use primarily the hydroxyethyl starch. If we don't see significant resolution in around 48 hours, then, or if the patient's symptoms worsen, that is when we actually think of albumin or eventually paracentesis. And 1000 ml of 6% HES infusion on the day of oocyte retrieval. This is something that we practice. Okay, then comes the common drugs which are available. One is cabergoline. So basically a daily dose of 0.5 mg per day for 8 days, starting from the day of trigger. It inhibits the phosphorylation of VEGF receptors, and that is how you can reduce the chances of having a very bad case of OHSS. Aromatase inhibitors, though not entirely recommended, it is letrozole. Basically, you will give it 2.5 mg tablets, maybe up to thrice a day, and it will decrease the circulating estrogen levels, and that could help you. Third is aspirin. A low dose aspirin from the day 2 of stimulation has been shown to have some effect. Calcium infusion, again, this is not something that has been very well studied, so not entirely recommended, but could help. 10 ml of 10% in 200 ml of physiological saline over a 40-minute period or on the day of the pickup, and around 3 days later, it might reduce your renin secretion and reduce the VEGF levels, eventually leading to resolution. But again, that is not your first modality of management. Next, your clinical ground diagnosis. Basically, there is no specific test for OHSS. Whatever you do is around it. You will be looking at the various parameters. You will be looking at the hematocrit, CBC, everything, because you want to prevent. Sometimes you see that patients are not passing urine or their urine output is decreased. So these are the things or the alarming signs which we have to watch out for, because a patient might have a greater, means they might feel that there's nothing much. It's just some fullness of abdomen. And if the symptoms are not communicated to you, then you might have a bad case at your hand. Important differential diagnosis which you should rule out. One is a pelvic infection, pelvic abscess or appendicitis, ovarian torsion or cyst rupture. These all would explain the pain and maybe some amount of fever. Bowel perforation and ectopic pregnancy, and medical conditions like pancreatitis. Yeah, so you will have to do a proper initial assessment, confirm your diagnosis, see the severity and decision whether to continue your outpatient management or inpatient. In our clinic, we do around 100 cycles a month, and in that around, you can say 100, 120 pickups a month. And we, I guess we have to maybe admit, maybe every 3 to 4 months, we might have to admit a patient for some sort of inpatient management, but that's also a rarity. Mostly we give them, the management starts from around the first day, that is on the day of pickup itself. Give some medicines, stay in touch with the patient, how are you feeling, take a follow-up every day. If you feel that she has some breathlessness Constipation is another symptom. Reduced urine output. Ask them to just keep a track of how many times she's going to pass urine. These are some things which you can do so that the patient is also comfortable and you are also comfortable. Clinical assessment, plenty of things to look at. What are your E2 levels, how many follicles, and if there was a history of HCG trigger, fresh embryo transfer, we hardly do it now. Symptoms like abdominal bloating, discomfort, pain, nausea, vomiting, breathlessness, inability to lie flat or talk in full sentences. So basically, how will you manage that? You tell the patient, go home, and when instead of lying down completely, use a pillow and be in a sitting position. Leg swelling, again due to the leakage of fluid into the third space, reduced urine output. And examination in general, you look for dehydration, edema, record the vitals, abdominal, you can do an ultrasound and assess for pleural effusion or pulmonary edema, that's rare. Investigations, of course, your full blood count, urea, electrolytes, to check for hypoosmolality, liver function test, KFTs, HCG to determine the outcome of the treatment cycle if you've done a fresh transfer, and ultrasound to do your ovarian size, pelvic and abdominal free fluid. So then you will categorize them into the various stages. And so what are we trying to do? Basically, you should have an OHSS free clinic. So if the ovarian stimulation, you do it according to new strategies available, keeping the doses low, working more on quality rather than just quantity of follicles or the oocytes that you get, and do using an antagonist protocol and induce the final oocyte maturation using GnRH agonist and cryopreserve all the embryos and then do a frozen embryo transfer later, you're more likely to hardly encounter these cases and have an OHSS free clinic. So coming back to these cases that we had seen about our lady who had previous 3 miscarriages. So in her case, yeah, so these were the red flags. She was a known case of OHS, of PCOS, and she had moderate fluid in the abdomen, which while she was taking her injections. On top of that, she received a 10,000 IU HCG injection, followed by a fresh transfer. So, and eventually when she had difficulty in breathing, and when she was in severe OHSs, she was pumped with a lot of fluid to correct her hypotension, but she should have been given colloids, and this is what aggravated her condition, and 6 days later she was referred to the hospital. And the other case scenario, your voluntary egg donor with scanty menses, so that is the first thing over there, and your 16 follicles were developed and they were planned for ovum pickup. On the day of trigger, there was moderate fluid in pelvis. Again, these were all signals that were supposed to be picked up. This was the picture on ultrasound on the day of trigger, and that means she was pregnant, and that's why she had those scanty menses. Probably a thin, not so thin endometrium, but she was stimulated anyway. Now, case discussion, if we go back to what is the serum beta HCG levels for around 2500, and the patient, since she was not keen on continuation of pregnancy, of course, you'll do the termination of pregnancy. But what if she wanted to? Then you would cancel your stimulation, do the ovum pickup, call a few days after a few days for MTP, do your ovum pickup and DNC at the same time. These are some of the strategies that you have to do. But suppose this patient, if it was a case of secondary OHSS, it is mostly supportive management. And the basic cornerstone of this is remove the source of HCG to prevent the progression of OHSS. Most patients, even of secondary, eventually settle down if you give supportive management. Now, what is the practice committee guideline? You have to identify your high-risk individuals, prefer antagonist over agonist protocol, agonist trigger preferred over HCG, embryo cryopreservation over fresh embryo transfer, use of cabergoline is recommended. Whereas the other points like which are not routinely recommended, or there is slightly less evidence with respect to this, is one is coasting, second is aromatase inhibitors, then aspirin, volume expanders, metformin and calcium gluconate. At our clinic, we generally give aspirin, we add metformin on a case-wise basis, and we do give volume expanders like hydroxyethyl starch on the day of the pickup, and we call the patient maybe after 2 to 3 days. One new avenue that has come up in the management of OHSS is basically that we prefer to give antagonist injections can actually reduce the action of your internal hormones. So maybe we could eventually study the use of oral antagonists like elagolix, which has come into play now. So maybe a 200 mg per day dose, which you could give for around 5 days, could actually reduce the chance of OHSS and give us a significantly OHSS-free clinic. Thank you. That's about it.
Thank you so much, Dr. Renoy. Thank you. That was a wonderful presentation. Next, now we have with us Professor Tayyab Tahir. He is a consultant psychiatrist at the University Hospital of Wales, Cardiff, UK. He would be discussing the topic, integrating mental health into fertility care, addressing the psychosocial challenges in infertility treatment.
While Dr. Shadab is taking the control, I would like to thank Dr. Shadab in particular, and I would like to thank Merck Foundation to invite me for the second year to talk about a topic. You've already heard my conflict of interest from my previous year's presentation. I don't have any conflict of interest in particular. I'm a liaison psychiatrist. I work in Cardiff, and this slide shows the beautiful city where I live and work. The program that has been set up is very important, and I was very pleasantly surprised to hear that mental health has been mentioned in many talks today. In particular, the previous speaker and the speaker on metabolic syndromes talked about mental health as well. What I'm going to talk about is integrating liaison psychiatry services within maternity services and in particular fertility services. If you do not have a liaison psychiatrist working with you, then you really need to consider liaison psychiatrists are that breed of psychiatry where we work with physical and mental health setting. And also when the speaker was talking about the fertility related metabolic syndromes, and it was important to think that a number of those things, especially the polycystic ovary syndrome, was something very close to my heart, and I've seen quite a few people and helped them with. What I'm going to talk about is introducing liaison psychiatry, fertility, mental health, and perinatal psychiatry and general management advice. I have to say that perinatal psychiatry and fertility is a global concern. It is across all cultures. It's not specific to any one particular culture. And it affects a huge proportion of couples of reproductive age, and hence, most of the speakers have already said that, and don't want to re-emphasize that. And it's important to raise awareness, and specifically when it comes to mental health and its related aspects, I think the less the more we can emphasize that there's a lot more to be done about it. It's not done as much as we think. For a variety of reasons, such as inaccurate self-reporting, there is a lot of other challenging issues. Research is not particularly helpful in this. Apology for a very, very busy slide, but the purpose behind this slide is to emphasize that there is some work that has been done on this topic, but it's also important to say that some of the speakers have already identified. So God works in mysterious ways. I was meant to speak earlier, but then after the last speaker, I think it's okay that I can re-emphasize that research shows that a diagnosis of infertility can be a tremendous burden for patients. The pain and suffering of infertility, and these few pieces of research that I've shown there vouch for that. That although neither the American Society for Reproductive Medicine nor the European Society for Human Reproduction and Embryology have formal requirements for psychological counseling for infertility patients, there's acknowledgement that incorporating psychological interventions into routine practice in infertility clinics is beneficial. It does not just affect women, it is something that affects the whole system around that individual. This is a picture taken not very far from where I live and work, and I was coming back from West Wales towards Cardiff, and I saw this little red car, and I felt that little red car is a patient with mental health symptoms going against number of barriers and controls. And then I also felt that this could be me as a psychiatrist working in a general hospital setting where there are lots of barriers. Complexity of problems is one, lack of understanding of the metaphors used, and that's why I was hoping to be in the room and interact with colleagues from Africa. I've done some work in Kenya around mental health education and with colleagues in Africa, and I was thinking that it would be good to talk about these metaphors and how we can demystify these metaphors. Sometimes patients choose not to tell doctors about their psychological issues, and hence they do not get an optimum treatment, and they also think that the doctors would not take their physical health presentations seriously if they start talking about their mental health problems. It is important to note, I have already shown this slide before, and this is an editorial which I read in 2001, and I thought that this was such an iconic paper written by Professor Kendall, who talked about making sure that we do not distinguish between mental and physical illness as two different categories, because it's important to note that these are archaic and deeply misleading terms. Hence, next slide, please. It's important to think of no health without mental health. This is a document which is really very important document as a liaison psychiatrist, but I think everyone should be reading this document and trying to develop liaison psychiatry services in their setup. Next slide, please. There are lots of barriers and there are lots of important points to consider, but social deprivation, and especially when we think of low and middle income countries, it's an important factor to consider. Social isolation, and when we think of infertility, social isolation could be a big factor, and hence employment, benefits, housing, social isolation, they are all important facts to consider. Next slide, please. Now I'm going to talk a little bit about liaison psychiatry. What do we do? Liaison psychiatry is a mental health service within general hospital setting. We deal with lots of interesting issues, such as psychological reactions to physical illnesses, organic causes of common psychiatric symptoms. And some of those factors have been talked earlier in this session and during the day. For example, thyroid or endocrinological issues, infections, and a number of other factors that can be considered. Medically unexplained symptoms and somatization is an important thing to consider. And mental capacity assessment and whether they understand what they're going through. Self-harm and suicide is an important factor. It's across cultures. It's not something which is very specific to one culture, but thoughts of self-harm and suicide are important screening questions which everyone should be familiar with. Just about liaison psychiatry, there are two parts of liaison psychiatry. One is consultation psychiatry and the other one is liaison psychiatry. In consultation psychiatry, we'll come, give an opinion and disappear. In liaison psychiatry, we'll be part and parcel of that team and help manage those patients. And sometimes we'll bring them to our outpatient clinic and see them there. Next slide, please. One of the speakers earlier talked about endometriosis, and I can't stress enough that endometriosis can, and this is clearly documented in research as well, that endometriosis can disturb mental health, specifically depression and anxiety, and decrease both the mental and physical quality of life of patients. Chronic pain could be a factor to consider, but infertility affects women significantly, and men, and also the wider system around them. This particular piece of research talks about the emotional and spiritual challenges of infertility, and more so in middle income and low income or different cultures. It's a very important factor to consider, that spirituality can lead to a lot of distress if not accounted for in an appropriate manner. And it is important to realize that the quality of life is affected. Recently, I'd written a paper, an editorial about duration of untreated illness. And in this guest editorial published a couple of months ago, I've talked about duration of untreated illness and how biopsychosocial spiritual model can be an important holistic approach to mental health, and also working with alternative sources of help, for example, faith healers or certain specific factors in Africa might be important to consider how to work with them to try and reduce the duration of untreated illness so that early treatment can be initiated. In Wales, we've worked on a very specific model with the caregivers and also with the service users. The roles of health professionals can be wide. It's important to consider how we can establish trust by good communication, empathizing with patients, but underpinned by respect and dignity. As doctors or health professionals, it's important to consider our duties as a doctor, but also as leaders, co-producing with the patients, their care plans and services, but be accountable in a very transparent manner with specific boundaries around health care setting and how we can challenge stigma. I've already said that health is not equally distributed, but it's and factors such as employment, isolation, housing are affected. And we know that health is influenced by power, resources, and influence. Same is the story with those who have problems related with infertility. So I'm going to now talk about some everyday experiences or illness beliefs and concerns and expectations. To explore that, it's important to consider a biopsychosocial model where we think in terms of what is predisposing someone towards developing mental health or psychiatric symptoms, what precipitates why now this person is presenting with these symptoms, what are the protective factors, what are the maintaining or perpetuating factors, but also the medications we prescribe and the iatrogenicity behind it. And iatrogenicity, I take more than just a medication. It's how we communicate with the patients. And I think that the 4P model or a biopsychosocial approach is an important way to investigate. So we can put the biopsychosocial approach in a grid format. This model is ingrained in my mind, and all my trainees, all my who are working with me, we think of every patient in this mind map of biological, psychological, and social predisposing, precipitating, perpetuating, protective, and iatrogenic factors. And I'm sure you will get the slides in a PDF format for you to revise and also to consider it as a way to work. How we can think of a management plan in a short-term, medium-term, and a long-term basis using a biopsychosocial model. Okay, so biopsychosocial management plan in short-term, medium-term, and long-term. And hence the psychiatric medication or physical health or the physical health reasons for psychiatric symptoms, they need to be considered with psychological and social factors. So a biopsychosocial management plan is something which can be used as a collaborative way to work with patients. Moving on to the next, from infertility to perinatal work, which sort of is a link between infertility, liaison psychiatry, and many other psychosocial issues. I think it's important to consider that if you do not have a perinatal team, you should consider a perinatal team in your area, because the perinatal teams talk about expertise and advice specifically related to women and families, women who are pregnant, and it offers assessment and ongoing support. So mental health disorders, Embrace UK, it's a document which is very important because it talks about maternal suicide in the first postnatal year is leading cause of direct deaths, and during within 42 days of end of pregnancy, second largest cause of direct maternal deaths. That should be an evidence enough for us to consider looking at the mental health of women who are pregnant and making sure that they get appropriate support. This document talks about the vulnerability factors and mental health associated around perinatal period. I'm not going to go into detail, but this little diagram within this document talks about about various factors such as poor housing, other major life events. Some previous speakers have talked about lifestyle. Lifestyle is underpinning mental health management plan as an integral part. We all know about the perinatal, just the ability to identify various perinatal psychiatric disorders such as perinatal depression or anxiety, postpartum blues, postpartum depression, post-traumatic stress disorder associated with the puerperal period, and perinatal OCD, bipolar disorders, and postpartum psychosis. The management around that, I've already sort of indicated, thinking in terms of a biopsychosocial approach, looking at what are the pre-existing mental health disorders, how they can be looked at during the pregnancy, but also thinking in terms of what support can be provided, and looking at a biopsychosocial approach, making sure the medication is prescribed in an optimal manner. Previous speaker talked about antidepressants, SSRIs, and SSRIs are the ones perhaps to consider as first line, because we not only have to, in puerperal and post-natal period, we have to think of breastfeeding and making sure safe medication is prescribed. Postpartum psychosis is something really very important to consider, because postpartum psychosis needs to be treated early on. Hence, in middle-income and low-income countries where you might not have psychiatrists at your doorstep, you should be familiar with what antipsychotics, what antidepressants or mood stabilizers to consider in that period. For example, one of the treatments that gets a very bad press is ECT, but that could be an important treatment to consider in that postpartum period if someone is psychotic or has psychotic depression, to make sure that the mother and baby recovers soon. Mother recovers soon to look after the baby at the earliest possible. So familiarizing with yourself with the psychotropic medication is important. In summary, it's important to consider of a perinatal team which is multidisciplinary, which has a psychiatric component along with midwives, psychologists, and social workers. It's important to identify symptoms early on. You should be able to identify a referral pathway locally so that those who show symptoms are referred early on, or if locally no one is available, then you should be able to pick up a phone and talk to someone to make sure that the right medication in an optimal dose and for an optimal period of time is prescribed. One of the speakers talked about drugs and substance misuse, and that's an important factor to consider as well, so that it contributes to healthier pregnancies, reducing the risk of postpartum mental health issues, and fostering an environment where mothers receive comprehensive support, positively influencing the well-being of both mother and the child. The aim in any of these situations, whether it's related to infertility or perinatal period, it's important to increase their remission rates, but gradually working towards preventing relapses, restoring physical functioning, and restoring social functioning. This is a collaborative pathway, and hence it's important to consider that the level of stress in infertility patient tends to increase as the treatment intensifies, and hence medications that are used to treat infertility should be considered as an iatrogenic factor in optimizing their dose or working alongside to identify the side effects. It's important to provide the right support. There is mixed information about impact of stress on IVF outcomes, but this is something to be researched. So general principles of management, it's important to think in terms of when we are working with patients, it's not just the patient that you're working with, whether it's a man or a woman, but it's also the family or the system they are in. As a psychiatrist, I have to also talk to the staff and doctors and nurses and make sure that I take into view what they have observed. And also at the same time, one of the roles for liaison psychiatry is to educate staff on mental health, much ignored area of treatment. Simplifying treatment protocols and focusing on infertility prevention and support lifestyle changes is important, and supporting patients who do not successfully conceive, it's important area. A lot of information is available around counseling, but counseling does not have any evidence base. Hence, it's important to consider goal-directed work such as cognitive behavior therapy. I've already sort of hinted towards the biopsychosocial short-term, medium-term, and long-term plan. This is just to re-emphasize a management plan which could look something like this. For example, if someone presents, you can talk to them about medication, their physical health, their lifestyle, about sleep hygiene, considering whether medication needs to be prescribed or what dose it needs to be prescribed, for how long it needs to be prescribed, along with goal-directed psychological work, but also working on spirituality, on housing support, debt management. So this is how a biopsychosocial plan would look like on paper for any particular patient. Just to re-emphasize that management has to be an integrated approach in fertility care. Hence, it's important to establish a liaison psychiatry service within your setting or have links with liaison psychiatrists. It's important to reduce the burden of treatments. Screening exercises could be useful, and shared decision-making with the patients and their system and the couples is important. Psychological interventions could be various, starting from progressive muscle relaxation exercises. We used to teach patients in person progressive muscle relaxation exercises, but those treatments are now available online on YouTube. There are a number of examples, but CBT or cognitive behavior therapy is a very useful, goal-directed, time-limited therapy. For moderate to severe symptoms, pharmacotherapy should be considered, but it's important to look at the drug-drug interactions. So things that we must consider for staff in general hospital to familiarize themselves are, and also with the fertility services, suicide and risks and self-harm risk assessment, what are medically unexplained symptoms, psychotropic medication, psychiatric services, what is available locally, substance misuse and alcohol. But it's important to listen to your gut feeling, whether you need to refer this patient to a psychiatric service or not. Delirium is an important factor. It's very close to my heart. It's 15% of patients who are in general hospitals suffer from delirium, and appropriate management of delirium can help patients and system around them. Something to think of is medically cleared. What might be medically cleared to send them from a maternity unit or an infertility unit home might not be medically cleared from psychiatric point of view, and hence that's a very vague term, and we need to have a more of a narrative around it rather than just simply saying this person doesn't have any medical health issues. So in summary, first of all, I wish I was there in the room and during these 2 days, but unfortunately, due to the global situation and flight delays, that was not possible. Maybe next year I'll try, and if I'm invited, I'll come back and talk about these things in person. But there's no health without mental health, and it's everybody's business. And mental health concerns can arise from subtle disruptions in normal psychological mechanisms that produce distortions. I thank you, Dr. Shadab. I thank you, Merck Foundation, and I hope everyone goes home safely and peace prevails across the world. Thank you.
Thank you so much, Professor Tahir. Indeed, that was a wonderful presentation, as always expected from your side.
I'm very grateful, very humbly accepted. As
Yes, please.
doctors, every day something happens that doesn't teach us a lesson, that humility is a huge factor that we must all espouse to. God has given us this opportunity to help patients in difficulty, and this is a great honor which we must accept as a humility to try and help people across the world, not just where we live. Thank you, Dr. Shadab.
Thank you so much, sir. That was indeed another learning from you. Thank you. Okay, we have a question for you.
Just a comment to say thanks for your presentation. And it's something that I always stress, the relationship between, it starts with infertility, then stress, and then stress continuing to potentiate the effect of the infertility, and it goes on and on and on. But I have good experiences when it just comes to counseling. Something that I would like to share. I think most often if we spend more time with our patients, especially the male and the female, is very important. You counsel, you talk, and this is one case that happened this year, and I would just like to read the message that the patient sent. She's from Lebanon, but she has her family history back in Saudi Arabia. She's 25 years old, and she wanted to get pregnant desperately. We did an IUI and it failed, and she went into depression. She went to America and got on drugs, and then she came back. But all along, I just counsel her every day, and we stopped the treatment, and I told her she was still young, and just the general counseling. And finally, she got pregnant when I was in Cape Town, and she sent me this message. She said, I did not get the chance to properly thank you for all your support. You always believed that I would get pregnant, and now I am. It still feels so surreal. I am truly grateful for your constant encouragement and faith in me throughout this journey. And I have had a lot of messages, but I continue to keep this one because I think it's very impactful. It shows the role of just support and emotional encouragement way after the failure of IVF treatment and the failure of conventional treatment. Thank you very much.
I salute you for what you've said. Thank you. Because talking to patients is very important, and explaining to them is very important, and counseling. When I say counseling has no evidence base, doesn't mean that it has no value. It has value on a very human level. But if someone has got major mental disorders such as depression or generalized anxiety or panic disorders, the evidence around CBT is very strong. And why I say so is that there's evidence that CBT can be as effective in certain cases for moderate depressive symptoms as antidepressants. And hence, it's important to think of evidence-based treatment. But yes, talking to patients and counseling is which everyone should be doing, and be talking to patients in a very, very elaborative manner. Thank you for your experience, sharing your experience.
Thank you very much, Professor Tahir, and thank you very much, everyone, for your participation. I understand that we have a lot to discuss about mental health, but we need to move on.
I will go on to the next speaker.
Hello, everyone, and thank you to be here. It is truly an honor to have this opportunity, and I would like to extend my sincere gratitude to the Merck Foundation for inviting me to share this presentation. It is titled Optimizing Medical Management Across the Menopause Stages, Bridging the Clinical Gap, a topic very critical yet under-recognized clinically. According to the World Health Organization, by 2030, 1.2 billion women will live above the age of 50 years. With increase in life expectancy, it is estimated that women will spend 1/3 of their life post-menopause. While we are adding years to the life, now it is time we add life to those years. A World Menopause Survey 2023 revealed that 70% of women experience moderate to severe menopausal symptoms. Yet, only 20 to 30% seek medical treatment. Why such a striking gap? There are several key reasons. The first, deep-rooted misconception. Many still believe that menopause is just a phase to endure, or that sexuality ends with the menopause. These myths lead women to suffer in silence. Then there is the cost. Even when treatment is available, awareness is there, cost make them unaffordable. In low and middle income countries, inconsistent supply of these essential medicines further limits its use. And finally, the fear of breast cancer, triggered from the 2002 Women's Health Initiative study, caused a lasting concern. So how do we bridge this gap? We need a multi-pronged approach. First of all, we have to empower healthcare professionals with the evidence-based updated guidelines so that they can deliver a quality optimum care to the women. Second, we have to raise public awareness by clear and trustworthy information so that they can understand it and they can act on it. Equally important is to make it affordable and accessible to everyone. And the fourth is institutional and national guidelines should include these newer drugs and should help in improving the approval to fasten the process of approval. And the fifth but not the least is menopause health should be considered as a public health priority. Then only the real change can happen. Today I am going to focus on 3 key messages. The first, don't miss the window of opportunity. The second, first line management for menopausal symptoms and to prevent long-term health consequences. Estrogen-based menopausal hormone therapy is the first line treatment. And the third, we have to adopt an individualized approach, keeping in perspective the clinical context, risk factors, and informed patient's preference. So, what is this window of opportunity? To understand that, let us see the 3 phases of ovarian aging. The first is reproductive phase, the second is menopausal transition, and the third is post-menopausal phase. During menopausal transition, menstrual variation starts initially with a 7 days variation that progresses to 60 days variation or so. And then the final menstrual period comes. And that is defined only retrospectively after 12 months of amenorrhea. So after the FMP, final menstrual period, post-menopause phase starts. That can be divided in 3, early post-menopause phase and late post-menopause phase. So early post-menopause phase, it lasts for 4 to 8 years. And this is the time if we start hormonal therapy, we can see the benefit for the long-term health, cardiovascular health, bone health, cognitive health, and even for genitourinary syndrome. This is called window of hypothesis, and that is the concept of timing hypothesis. And this is supported by several studies like DOPS trial, ELITE trials, and the KEEPS trial. And the reverse we have seen in WHI studies where the average age of menopause was 63 and hormonal therapy was started well beyond the woman past the early post-menopause phase. So what happens during these cycles? During menopausal transition, FSH level rises, estrogen levels declines and fluctuates, and these changes in the hormones causes symptoms, menopausal symptoms. Sometimes they remain unattributable to the menopause because women is still menstruating. After the final menstrual period, several physiological changes start silently. Like visceral fat, it increases by 8.2% even 2 years before the FMP. Within 1 year, blood pressure rises, carotid intima media thickness rises. Within 5 years, bone mass declines by 10%. Also, several other changes like muscle mass declines, lipid profile worsens, and metabolic consequences happens. So this is the basis of timing hypothesis that if we start hormonal therapy within this early postmenopausal phase, we can prevent these long-term health consequences due to estrogen decline. So let's see now how the estrogen decline affects the clinical domains. The most common symptom complex is vasomotor symptoms. Hot flushes, night sweats, and it varies in severity. It can also lead to palpitation, sleeping disturbances, and it affects the quality of life also. Neuropsychiatric symptoms, anxiety, depression, mood fluctuations, brain fog, sleep disturbances, and they remain in association with the vasomotor symptoms, but sometimes they can remain isolated also. And at that time, usually they are considered due to the stress of the midlife or increased responsibility. And third, musculoskeletal symptoms is still quite common. Muscle aches, joint aches, low energy, fatigue, and these are usually considered as a part of the aging. And genitourinary symptoms of menopause, usually they are mild during menopausal transition, but if they are not treated immediately, it can cause to severe genitourinary syndrome of menopause. It can cause vaginal dryness, irritation, recurrent urinary infection, recurrent vaginal infection, and even dyspareunia. So let's understand how estrogen decline causes vasomotor and neuropsychiatric symptoms. When estrogen level declines, it narrows the thermoregulatory zone, overexcites HPA axis, it disrupts the neurotransmitters, and the core mechanism is through NK3 receptor hyperactivation. NK3 receptor hyperactivation again causes narrowing of the thermoregulatory zone and disrupt the neurotransmitters. So even minimal change in the temperature or minimal level of stress can cause vasomotor symptoms plus neuropsychiatric symptoms. And studies have shown that if you give estrogen-based hormone therapy, it is affecting the root cause, it is attacking on the root cause. So we see 80 to 90% relief in the symptoms. While if we give NK3 receptor antagonist, which attacks on the core mechanism, it can give 50 to 70% relief. While the SSRI, SNRIs, they affect only on the last single mechanism, that is on the neurotransmitters effect. So we see only the partial relief. So in continuation with the previous slide, this NK3 receptor hyperactivity, it decreases serotonin and GABA, which causes depression, anxiety, insomnia, and mood disturbances. It reduces dopamine, and that causes lack of motivation, anhedonia, cognitive decline, and brain fog. It increases norepinephrine by increasing the sympathetic outflow, and that causes heightened arousal, irritability, and again the sleeping disturbances. So estrogen decline causes increase in visceral fat, decrease in muscle fiber type 2, which is responsible for our strength. It causes increase in pro-inflammatory markers, decrease in collagen synthesis, decrease in vascularity. All these changes causes cartilage degeneration. Simultaneously, increase in osteoclastic activity causes osteoporosis, and together all these causes structural and functional symptoms of musculoskeletal system. Estrogen decline causes decrease in superficial mature cells which are rich in glycogen content. So with its loss, there's an increase in pH that further increases vaginal and urinary tract infection. It also causes less vascularity and less collagen synthesis, and that leads to vaginal atrophy, and all these changes together causes genitourinary syndrome of menopause. And it can worsen if not taken care at right time. So if these menopausal symptoms left untreated, it can increase 50% lifetime risk of osteoporotic fracture, 2 to 3 times risk of coronary artery disease, 1.7 times risk of cognitive decline in Alzheimer's disease, and genitourinary syndrome can progress to 70 to 80% of the women after late postmenopause phase. With this understanding that estrogen decline is the root cause for all the menopausal symptoms, estrogen-based menopausal hormone therapy is the gold standard. The most recommended estrogen drug is 17-beta estradiol, which is a bioidentical hormone. It is available for oral, transdermal, and intravaginal use. Oral and transdermal both are equally effective for all the clinical spectrum as well as for prevention of long-term consequences. However, transdermal estrogen is safer because it bypasses liver, so it has less risk of stroke and blood clots. The another advantage of transdermal is that it maintains the stable serum level, which is very critical for alleviation of neuropsychiatric symptoms. Intravaginal estradiol is mainly for the local use for genitourinary syndrome. The other drug, estrogen, is conjugated equine estrogen, equally effective, but it has mixed estrogen hormones. So, safety point of view, it is considered second drug of choice. Although WHI sub-analysis and PEPI trials have shown its safety if used in early postmenopausal phase and women less than 60 years of age. Now, if women have intact uterus, these estrogens has to combine with progesterone, and the most safe and natural progesterone is micronized progesterone. Thus, if it is not available, synthetic progesterone, medroxyprogesterone can be used, and levonorgestrel intrauterine progesterone is another option, especially in women who need contraceptive effect also. In women who are intolerant to progesterone, there are two other options. Tibolone, it is a synthetic steroid, and it has androgenic, estrogenic, and progesterogenic effect. Due to androgenic effect, it has shown efficacy for the mood elevation and improved libido also. LIFT trials have shown its beneficial effect on the bone health. It is available widely and affordable also. The another molecule, TSEC, SMART trials have shown its efficacy for the vasomotor symptoms and bone protection. It is endometrial safe also, and also it has antagonistic effect on the breast tissue or neutral effect. So it could be considered as a second drug of choice in women having breast cancer risk. So here are few non-hormonal drugs. Fezolinetant is a NK3 receptor antagonist. It's approved in USA and UK in 2023 and recently approved in Australia 2024. Not available in Asian and African countries. It has shown very fast relief for the vasomotor and neuropsychiatric symptoms proven by Skylight 1 and Skylight 2 trials. It is affordable, it is expensive and not available everywhere. The other few molecules, SSRI, SNRIs, they are not approved by any drug agencies. It is used off-label, and recently FDA has approved a small dose of paroxetine for vasomotor symptom relief. So intravaginal estrogen is the first line drug for the genetic urinary syndrome, but in women who has estrogen sensitive tumors or relative contraindications for estrogen, there are few other choices like intravaginal DHEA. So Rejoice trial have shown that it gives very good effect in moderate to severe dyspareunia and for vaginal dryness. It works by intracrine mechanism and changes into estrogen and androgen vaginally, and it has none or minimal systemic absorption. The second drug is ospemifene in women who do not want to use vaginal drugs. It's a good choice. It also has antagonistic effect on the breast tissue, so can be used in breast cancer survivors or having high risk of breast cancer. OPAL trial has shown its symptom relief in moderate to severe dyspareunia. After discussing when to use and what to use, now few more key points. We have to start with minimal effective dose. Need to review. First review after 3 months and subsequent reviews 6 monthly to yearly. To stop, we have to use the principle of tapering and with observation of recurrence of symptoms. But in premenopausal and early menopausal women, we can safely use it until the average age of menopause. So here are few real case scenario to emphasize the individualized approach. So first case is 42 years old lady with mood disturbances, insomnia and vasomotor symptoms. She has hysterectomy with preserved ovaries 5 months back. Now she understands that because of hysterectomy, she can't get early menopause. But the studies have shown that even with preserved ovaries, hysterectomy can double the risk of getting early menopause. The second case is 48 years old lady with severe vasomotor symptoms. She has history of her mother having breast cancer risk diagnosed at the age of 65 years. Now we have to understand that breast cancer diagnosed after the age of 50 years in first degree relative does not increase her chances of getting breast cancer risk. The third case, 65 years old lady with severe vulvovaginal symptoms having VTE 5 years back after prolonged immobilization due to pelvic fracture. Now, provoked VTE does not increase her chances of recurrence for the VTE. So these cases emphasize that every case should be individualized, not to use a blanket approach. So I hope that this presentation has made these 3 key points very clear. Don't miss the window of opportunity. Second, estrogen-based menopausal hormone therapy is the first line management. And third, we have to optimize our approach according to the patient's clinical spectrum, risk factors, and patient's preference, informed decision. So these are few key references If you need any further information, please feel free to contact me. I'll be happy to share with you. So I will end my presentation with these words. Let's redefine menopause as a gateway for vibrant living. Menopause care is a health care, and health care is human right. Thank you for your attention.
Thank you so much, Dr. Hamdani. Indeed, that was a wonderful presentation. Let us just quickly ask our attendees if there is any question or if there is anything specific they want to discuss with you.
Mine is on the fear that is associated with menopause. How do we counsel patients and even educate the public on fear that is associated with seeking menopause treatment?
Thank you for your question. And I'm someone who was educated in India and working from last 2 decades in Botswana and previously in Zambia. I feel very much connected with this forum. Thank you for this opportunity. And for your question that how should we counsel our women against the fear of breast cancer due to the hormone replacement. So first of all, you have to be confident in providing these menopausal hormone therapy. That was the old paradigm that menopause hormone therapy increases the breast cancer risk. In fact, the new trials and strong evidences have shown that if you start estrogen based hormone therapy, especially the newer preparation, that is 17 beta estradiol, which is bioidentical hormone, along with micronized progesterone, it rather protects the breast cancer risk. And if it is given alone, estradiol alone, it can increase the protection almost by 25 to 40%. These are repeatedly proven by E3N French cohort studies and WHI sub-analysis. I can give you the mechanism that how it works. When we give estradiol, the bioidentical one, it rather, if we give it within the window of opportunity, because the oral one, it passes through liver, the SHBG and other binding hormones, it increases, which will make the estrogen hormone less available. So the estrone and estradiol ratio, that is the one which is important that cause the breast cancer risk. This ratio, if it is within the ideal like 1:1, it won't increase the ratio, rather it will keep the estrogen receptor unstimulated while it is working on other receptors in other part of the body. Like estrogen has a pleiotropic effect. It is affect the alpha receptor and beta receptors. They are present in different organs in bone, brain, and our arteries in different proportion, and they can remain inactive. They become inactive after 10 years of menopause, but within that time, they are still active. I don't know if I'm making sense because the time is too little for me to make you understand. But yeah, and we have to see this okay, this would be easier to make them understand if we do it in context with the lifestyle factors. Remember, obesity increases the risk by 90%, and your sedentary life and alcohol, just 20 gram per alcohol per day, it increases the risk of breast cancer by 45 to 60%. In that comparison, if we use these natural bioidentical estrogen and progesterone, it has either neutral or plus 10% protective effect. So we have to see in context with the lifestyle factor. This would be easier for you to explain to your patients. I hope I conveyed my message. Thank you.
Thank you, Dr. Hamida. this fantastic presentation. I went out briefly, came in and didn't catch all the bits you said. But I must say that today I've become a fan of menopause treatment again. In the 90s, I used to sit in one of the oldest menopause clinics in Scotland and met many women who had been on it for years and wouldn't want to stop. But then, as the years pass by, you get this new publication about this, another publication about that, and gradually it was defeating all the arguments that I had before. I moved on Tibolone for years. I still use it though, but I don't find myself an avid proponent for menopause treatment like I'm beginning to feel this afternoon listening to you. I think the question somebody asked, how we can get a link to follow you or get a little more into your teaching is one I would propose to get a rejuvenation of the facts as you've put it out scientifically. Because with that, you, the person providing the service, must be confident in what you're saying and be able to break the arguments of any false inceptions that people may have or have read. Because see, now everything is available on Google and on the internet. You go and you read something here, you read something there, but you've argued your facts so well that I'm very grateful for the opportunity to listen to you, and think I will be getting back to you to get more understanding and leads to sources of getting facts put together soundly to be able to argue for treating these women. We find today many women who are at the top of their business, CEOs, head of companies, are already in the menopausal age, and they need their head properly, need to be able to put these vasomotor symptoms aside and deal with their daily affairs. But they come to you, and then the confidence of giving estrogens, which you know as first line, the best, has been shattered over the years. But I believe you've made a difference to my thinking today, and hope others similarly would pick this up and will drive your message across and be able to help more women in this situation. Thank you very much for your presentation.
Thank you very much for such a nice compliments. I'm really glad that it is meaningful to you and it is going to help many more menopausal women in your practice. Thank you. And I will be always available. I'll be glad to help you. Thank you.
Thank you so much, Dr. Hamdani. We really enjoyed your presentation. Thank you so much.
Allow me to call our next speaker. This is Dr. Akanksha Tripathi. She's a postgraduate diploma tutor and also MSc supervisor at the University of South Wales in UK. She's going to discuss the current perspective of human papillomavirus prevalence and its preventive measures. We are going to run the video from Dr. Tripathi.
Hello everyone, this is Dr. Akanksha Tripathi. I'm a consultant OBGYN working at Paris Health, Udaipur, India. Today I'm going to speak on the current perspective of HPV, human papillomavirus prevalence and its preventive measures. Around the world, numerous epidemiological, clinical, and molecular studies have shown that human papillomavirus infection is a major risk factor for the development of precancerous lesions and cervical cancer. And some of the other cancers which are being inflicted by this particular virus are anal, oropharyngeal, and penile cancers. Human papillomavirus represents a major global health challenge no doubts about that, and it is associated with approximately 4.8% of all human cancers. It's a very small non-enveloped entity with a diameter of around 52 to 55 nanometers. It comprises a single double-stranded DNA of about 8,000 base pairs encapsulated within a protein capsid made up of 72 pentameric capsomeres. Its peculiar structure enables it to effectively infect epithelial cells, leading to a range of outcomes from benign warty lesions to malignancies, which include, as I said, cervical, anal, penile, and oropharyngeal cancers. And the sad part is that cervical cancer, which is second most deadly gynecological cancer among women worldwide, is particularly common among 15 to 44 years of age group, which is probably the most productive time of their lives. It's very necessary that we learn more about it and we learn more methods to screen it, to prevent it, and to decrease the incidence of these deadly malignancies. Globally, it is associated with 5% of all cancers at a range of body size, which tend to claim around 400,000 lives annually. So the burden of HPV-associated cancer, it varies, and it varies widely according to gender and part of the body infected. Most common cancer, as I said, associated with it is cervical cancer. Other are vulval, vaginal, anal, and oropharyngeal. And it is being said, or it is being studied, that 80% of cervical cancers are identified in developing countries which are closely associated with HPV. Some of the facts about HPV is it's the name of a group of 200 known viruses. They do not cause any concerning lesion in most of the people. They just stay there in their body and cause no harm. But infection with some high-risk types, there is high-risk variety and there is low-risk variety. So infection with some high-risk type can cause these warts or cancers. 90% of the people are able to control the infection by themselves through their strong immunity. But if there is a persistent HPV infection with high-risk type, it may lead to these cancers. And in 2019, HPV caused an estimated 620,000 cancer cases in women and 70,000 cancer cases in women, according to a study published in Lancet Global Health 2019. Looking at the distribution globally, the highest prevalence of cervical HPV among women is in sub-Saharan African region, around 24%, followed by Latin America and the Caribbean, 16%, while Eastern Europe and Southeast Asia share equally 14% each. Cervical cancer was the fourth leading cause of cancer and cancer deaths in women in 2022, with some 660,000 new cases and around 350,000 deaths worldwide. So they account for over 90% of HPV-related cancers in women, the cervical one. And the highest rates of incidence and mortality are unfortunately in low and middle income countries, probably because of the lack of awareness and infrastructural issues. If you look at this graph closely, so this is a standardized incidence and mortality per 100,000 of cervical cancer in UN regions in 2022. So you can all see the lighter gray areas representing the incidence, while the darker ones representing the mortality. Eastern Africa at the highest, at the number one position, followed by Southern Africa, then Middle Africa. There goes down the Western African, then the Southeastern Asia and Eastern Europe. Global HPV prevalence among women with the normal cytology is estimated around 11.7% with regional variations. So if you do a normal pap smear, and the pap smear turns out to be normal, you can still find HPV associated with them. The prevalence in sub-Saharan African region ranges from approximately 15.5 to 24%, with some studies reporting rates as high as 33%. Southeast Asia has an intermediate prevalence of around 10 to 20%, with higher rates in populations with limited access to screening for obvious reasons. HPV 16 and 18 are consistently the most common high-risk types, associated with over 70% of cervical cancer cases, as I told you. So there is a high-risk variety and a low-risk one. Looking at the HPV burden in the African continent a bit closely, so in sub-Saharan Africa, cervical cancer is a rising public health issue, with over 75,000 cases, new cases, and 50,000 deaths being reported annually. And the unfortunate part is the young women under 25 years of age are disproportionately affected. HPV prevalence can reach up to 43.9% in Africa compared to the global average of 19%. Within Africa, we have regional variations, with Ethiopia, a study conducted in Addis Ababa reported an overall prevalence of 9.72% among women attending family planning clinics, while in South Africa, research was conducted in Gauteng province, where they found a high-risk HPV prevalence of 48% among women attending gynecology clinics, with the highest rate observed in women under 30 years of age, probably because of multiple sexual partners, more exposure. While in West Africa, among women with normal cytology, the prevalence of HPV type 16 and 18 is estimated at 4.3%, but this increases significantly to 55% among women with cancer. Some studies highlighted the high-risk HPV prevalence and in a meta-analysis of around 3,075 women with high-risk HPV infection from 15 studies being conducted in various regions of sub-Saharan Africa. They concluded that HPV 16 was the most common, infecting 13.8% of the women, while HPV 52 stood second with 9.9%, and HPV 18 was third, infecting 9% of the. What are the factors which influence HPV prevalence? HIV co-infection. Women living with HIV are at a higher risk, obviously because they are at a lower immunity and more likely to have persistent infection with high-risk variety, further increasing their risk of developing cervical cancer. Socioeconomic factors play an important role. So unemployment, poverty, limited access to the healthcare services are associated with higher prevalence. Conversely, if you look at the married women, marriage has been identified as a protective factor, probably because of a single partner. If you look at Asia, the current estimates 2020, they suggest that approximately 351,720 new cases of cervical cancer are being diagnosed annually. And out of them, 1,99,902, almost 2 lakh, deaths from cervical cancer occurring annually. Cervical cancer ranks as the fourth most frequent cancer among women in Asia based on crude incidence rate. And if you particularly look at 15 to 44 years of age, then it is the third most common female cancer. The standardized incidence rate is around 12.7 per 100,000 population, while the mortality is around 7.05 per 100,000 population. Prevalence trends in Asian countries. The overall HPV prevalence is around 17.7%, with 13.1 classified as high-risk HPV and just 4.58 as low-risk HPV in China. Each specific prevalence revealed a bimodal distribution, with peaks occurring in very young women under 21 and another in elderly women over 61 years. There is a true cancer examination project being launched in China in July 2009, cervical cancer and breast cancer, implementing a free screening program for rural women aging between 18 to 65 years. Primary screening methods are cytology and HPV testing at 3 yearly intervals. The 2011-2020 Women's Development Program aimed for cervical cancer screening coverage. The aim was to reach 80%, but coverage in 2010 was 29% in urban areas with 16.9% in rural areas. So China has official national recommendation for this screening starting from 2019. If I talk about my own country, India, the problem is really grave here. So according to WHO, 4.1 million women in India have died from the disease since 2019. And if it continues in this fashion, without intervention, as many as 5.7 million will die by 2070. Incidence of cervical cancer is high, 1/5 of the global burden, with more than 124,000 cases and 75,000 deaths happening every year. According to National Family Health Survey, only 22% of eligible women have received cervical cancer screening during 2015-2016, which is quite low. In 2016, Ministry of Health and Family Welfare launched a mobile technology platform also for the screening, which supports implementation and continuous monitoring of these screening programs in each state. There is a national level training for mobile healthcare system being implemented in April 2018, with approximately 12,000 healthcare providers being trained across 24. Prevalence trends in Korea. So cervical cancer is the 7th most common malignancy in women, and the incidence rate is still higher than other developed countries. Since the introduction of the NCSP in 1999 in Korea, the incidence rate of cervical cancer has gradually decreased from 16.3 per 100,000 to just 9.1 in 100 per 100,000 in 2015. Prevalence trends in Japan. So it is one of the developed countries, but unfortunately, the incidence has increased since the late 1990s, in contrast to the decreasing trend being observed in most developed countries. So the age standardized incidence rate has decreased by 1.7% till the year 1997, but thereafter it has increased by 2.6% per year. This is probably due to increased HPV infection among young women or the absence of national HPV vaccination program. The target age for population-based screening in Japan is 20 years and older and with no upper limit. Screening with cytology is provided for free every 2 years. And if the cytology is not negative, they should receive a confirmatory test called positive with or without biopsy, which needs to be performed by a trained gynecologist. HPV triage can be performed for women with abnormal squamous cells of uncertain significance or ASCUS as a screening result. The results from all Japanese local governments are tabulated in a report every single year. Looking at Thailand and Indonesia, Thailand's cervical cancer is the second most common cancer among women, with an estimated 8,622 new cases in 2018. In 2005, nationwide cervical screening program has been started at 5-yearly interval to all Thai women aging between 35 to 60 years. Cervical cancer incidence has steadily decreased, so this is very promising, from 24.7 to 14.4% per 100,000 over the last 2 decades. HPV vaccination has also been introduced in 2017 as a school-based national immunization program only for 5th graders 11 to 12 years of age. In Indonesia, cervical cancer occurs in 24.5 per 100,000 women annually, and screening programs target married women aged 30 to 50 years. So what exactly are we aiming at screening? So we need to detect them early, so identify those precancerous lesions, which enables timely intervention. Total prevention of invasive cancer, since this is the only cancer which we can pick up before it really happens. So we totally want to prevent the invasive cancer, reducing the mortality and improving the survival rate through early detection and treatment, enhancing the quality of life by minimizing the treatment burden and invasive procedures. And overall, it will be very cost effective if we are able to detect them early and prevent them altogether, because treating an advanced cancer is very difficult for the patient. Like, she has to bear so much of pain and go through so many tests and surgeries, and it will add to the healthcare cost of that particular country. So, cervical cancer guideline comprehensiveness across SADC member states. So, the most common recommended screening method was naked eye visual inspection, which includes VIA, that is visual inspection with acetic acid, and BILI, visual inspection with leukocyte. Only 6 countries recommended HPV-DNA testing as the primary screening tool, or made mention of the planned transition to HPV-DNA testing as a primary screening, as recommended by WHO. The South African HPV Board in 2023 guideline recommended primary HPV screening for all the women at 25 years, followed by 5 to 10 years screening, regardless of the resource setting. But if we look at the screening compliance in Africa, the average score for compliance with the WHO guidelines was 8. Maximum possible is 13. Zambia scored the lowest, 2, followed by Mozambique with 4. Tanzania scoring 5, with Namibia and Botswana having the highest score of 11. Looking at the screening programs in Asia, most of the Asian National Cancer Center Alliance countries, member countries, 16 out of 21, have implemented national cervical cancer screening program. However, the coverage has been relatively low, which is due to this poor awareness among the general population. Although 52% of ANCCA member countries have introduced HPV vaccination, first dose coverage is still low, around 6% in Western Pacific region and 3% in Southeast Asia. If we look at the country-wise screening methods and their uptakes, so China, India, Indonesia, Japan, Korea, Thailand, nationwide screening are available, and they all have started early. Japan has started really early, 1962, and Korea in 1999. But after 2000, most of the countries have adopted national screening programs. Primary screening methods, it's cytology in HPV in China, it's VIA in India, VIA cytology in Indonesia, and cytology in Japan, Korea, and Thailand. But if we look at the uptake rates, which is really high in Thailand in contrast to India and Indonesia. So this is the area where we need to work. Look at this chart where I tried to compare the developed countries with the Southeast Asian region and Africa. Like, we have included Nigeria here. So the screening acceptance or participation rate is almost 80-85% in Sweden, falling to 70-75% in Australia, USA, and UK. While in India it is less than 30%, in Nigeria it is less than 10%, which is a very sad figure. All the countries are trying to target their young population. Everybody who's more than 20 plus age group is being included. Various screening methods have been employed, and it is very interesting to know that these screening methods are so simple, and they have, the time period after which it needs to be repeated is really long. So it's very feasible to do it. So if you take cytology testing, it needs to be repeated every 3 years. Simple. And if you're including HPV testing individually as HPV and individually alone, or if you're doing a co-testing, that is pap smear and HPV combined, you need to do it every 5 years. So that gives you a lot of time. So if we try and inculcate this particular point in our counseling, that you just have to get it done every 3 years or every 5 years, I think more and more people can be motivated, more and more women can be motivated to take up these screening tests, and they are minimally invasive and almost non-invasive testing. The usage of various screening tests among the countries, we have already seen a little bit about it. So cervical cancer screening programs often as a part of national cancer screening programs. And various methods, as we discussed, is cytology, most widely used methods, HPV DNA testing, separator along with cytology, and simple ones which can be deployed at low resource settings as VIA and MFFLI. The only thing is that it will also require some kind of training for the personnel to identify what is abnormal from looking at the HPV testing, various techniques like non-amplification techniques, including nucleic acid probe tests. Then there are amplification techniques, which are PCR based or signal amplification or probe amplification. I will not go into the details, but these are the various techniques available for HPV testing. It definitely requires a good lab. So pros and cons of various screening methods. Pap smear, yeah, it is a microscopic analysis. It is inexpensive, well established, but still needs a support of the lab and a lower sensitivity. If you compare it with HPV DNA testing, it detects high-risk HPV types, highly sensitive, early detection, but on a costlier side. Also requires a good lab infrastructure. Co-testing, expensive, limited availability. Visual inspection, where we inspect the cervix after applying acetic acid. It's a low cost, immediate results, but training is required and it cannot be that accurate. Villi, similar to VIA, but it uses Lugol's IoT, better specificity in some setting, same limitations as above. Then we have also self-sampling for HPV, which is self-collection sample for HPV DNA. It reduces the stigma, so that way it increases the uptake, but again will need education and labs definitely. What are the various barriers to effective screening? It requires coordinated regional efforts. Everybody has to work. In prevention, education, and access are the key. We need to work on these three areas. Low awareness and health-seeking behavior. Cultural taboos, all of you would agree with me. There are so many taboos around the examination and especially around the vaccination. And there is limited healthcare access in rural areas, sometimes a transport facility. They are so engaged, they're so occupied in their day-to-day life and they do not still take their health as a priority. And of course, shortage of trained personnel. Sometimes, the amount of trained people do not cater to the population, to the large populations. Lack of national screening programs in some of the countries. So one of the strongest prevention strategies is vaccination. So Center for Disease Control and Prevention have reported that HPV infection rates have decreased by 88% and cervical precancer rates have decreased by 40% since these vaccines are in use since 2006. In 2019, at least 100 countries included HPV vaccines in their national immunization program. The United States National Immune Survey 2020 reported 75% of adolescents aged 13 to 17 years from different ethnic groups receiving at least one dose of HPV vaccine. In Australia, 80% of 15-year-old girls have completed their HPV vaccine 3-dose schedule, which is such a promising thing to learn. HPV vaccination in African continent. Prophylactic vaccines are available in Africa, both the monovalent and the quadrivalent variety. A newer single-dose vaccine has also been approved and it offers an equivalent efficacy at a reduced cost, presenting an excellent opportunity for African nations. Although the first HPV vaccine, Gardasil, which has become commercially available in 2006, it took almost 5 years for the first African country, Rwanda, to incorporate it into its national immunization program in 2011. As of 2023, 29 of the 54 African countries have included this vaccination in their national programs. The overall vaccination coverage in Africa remains low at approximately 52% for first and last doses based on the available data. While in Asia, if we compare with Asia, nationwide programs as of 2023, 6 countries, Bhutan, Indonesia, Maldives, Myanmar, Sri Lanka, and Thailand, have introduced the HPV vaccine nationwide. India has initiated its vaccination in Sikkim with plans to expand to other states. Bangladesh has introduced the vaccine in the Dhaka division. There are planned introduction in Nepal and Timor-Leste have scheduled national introductions to the HPV vaccine for 2023-24. So if you look at the success of this vaccine so far, subgroup analysis shows specific low rates. India at 6%, Pakistan at 4%, and Bangladesh at 3%. HPV vaccination rate among adolescents in China is less than 3%, and the entire population is less than 6%. The low pool prevalence of HPV vaccine obtained in South Asia, 8%, highlights the substantial work still remaining. The challenges here are the lack of awareness and knowledge about the HPV infection, and that is what we intend to do here today. So to take this knowledge and just percolate it down your society so that more and more people are aware of this infection. Secondly, cost and accessibility, where the countries have to work together. They have to do some brainstorming to how to decrease probably the high cost or make it free for at least for the young girls. So because of the high vaccine cost, there is a limited access. There are less families taking up the vaccines. Then the cultural and social factors. So many misconceptions linking to the vaccine as far as the menstrual cycle is concerned or their sexual life is concerned. A lot of parents have their concern that this vaccine might just disrupt the menstrual cycle of their daughters. We as a gynecologist very often come to, we very often face such challenges. Healthcare provider recommendation. Now, look, we need to introspect. So there is a lack of strong recommendations from our side as well, from healthcare providers, which affects their decisions to vaccinate. So we really need to emphasize on its importance and how it works to prevent such a deadly disease and how it is so important to invest in health. So maybe together we can make this difference. India has recently launched its first locally produced version of human papillomavirus vaccine. And this quadrivalent vaccine has positive data so far from the clinical trials. And we have got an approval from Drugs Controller General of India in July 12, 2022, which is a milestone for us. And this is for both male and female individuals aging between 9 to 26 years, and it is funded by Government of India and it's distributed via state-run services. And India aims to vaccinate nearly 15 million girls between 9 to 14 years and plans to extend the availability to private providers, and we even plan to export it to other nations. This low-cost vaccine. There are innovations being done in this direction. One-dose schedules. Some countries are adopting WHO's recommendation of at least one dose to increase the coverage and reduce the cost. Local vaccine production. As I said, India has developed its indigenous vaccine. Community engagement, collaborations with community and religious leaders are essential to address the misconceptions and promote the acceptance. Then there is therapeutic vaccine research going on in this region, which is exploring mRNA-based therapeutic HPV vaccine, which would offer additional treatment options in the future, not just the prophylaxis, but the treatment as well. So I just hope I'm able to make some sense here. And I really thank everyone for your patient listening. Thank you for providing me this opportunity. Thank you. Thank you very much.
Thank you very much, Dr. Kanksha, for this wonderful presentation and the awareness on HPV. We are going to allow one question from the audience. If we have a relevant question. Thank you very much. We have a question from Dr. Mackenzie.
Thank you. I just wanted to find out which one is better, the one-dose vaccine or the three-dose one. Which one, from my experience, which one is better? Which one can she recommend? Especially for the sub-Saharan African countries where we see the prevalence to be so high.
Okay, so talking about the success, three-dose schedule is definitely better, but WHO has recently recommended one-dose schedule, especially for African or other low middle income countries, so as to decrease the cost and increase the, we can still have a good antibody titer if we give single dose. So even a single dose regime is quite cost effective. But if you'll ask me what is the ideal dosage, that would be 3 dosage. Again, depending upon the age group, from 9 to 14 years, it is 2 dose schedule, 0 and 6 months. And 15 onwards, from 15 to 45, it is a 3 dose schedule, that is 0, 2, and 6 months.
Thank you very much. I think that was clear for Dr. Mackenzie. And thank you very much, everyone, for your participation. We are going now to go straight to our second panelist discussion of the day. I'll ask our colleague to settle the chair for us. And for this afternoon, our topic will be Merck Foundation More Than a Mother movement, alumni impact on the fertility care landscape in Africa. Thank you very much. Our first panelist is Dr. Nurum Gori. Dr. Nurum Gori is a specialist family physician, healthcare practice, Oshakati and Merck Foundation alumni from Namibia. Our next panelist is Dr. Enid Chiwanga. I think she was there in the morning. Everyone can remember her. She's a consultant obstetric and gynecologist, fertility specialist, Dodoma Regional Referral Hospital, and Merck Foundation alumni from Tanzania. The fourth panelist is Dr. Richard Mogaka. He's a Deputy Director of Reproductive Health and Head of Department Maternal and Fetal Medicine, Chief Medical Specialist at Moi Teaching and Referral Hospital and Merck Foundation alumni from Kenya. Karibu sana. The fifth is Dr. Ndeye Kadi Sene, obstetrician and gynecologist, fertility specialist, and deputy head of maternity unit at Hospital Center Hell Ibrahima Niass, Kaolack, and Merck Foundation alumni from Senegal. Bienvenue. The sixth one is Dr. Mogane Irenge Jules. He's head of the infertility unit and deputy head of the gynecology clinic at Bukavu Provincial General Hospital and Merck Foundation alumni from Democratic Republic of Congo. Bienvenue. And our last, but not the least, is Mrs. Nilanda Kana Sebe, Senior Medical Laboratory Technologist, Andrology Unit, Pathology Department, Sir Siusagu Ramgolan, National Hospital, and Merck Foundation alumni from Mauritius.
So a very warm welcome to all our panelists. The topic of your panel discussion is Merck Foundation More Than a Mother movement, alumni impact on the fertility care landscape in Africa. And please tell us only about the impact and the success story that you have created in your region after the training with Merck Foundation. How has the training impacted your career, your patients' lives, and the overall healthcare landscape in your country?
Good afternoon, colleagues, and thank you for this great opportunity. As we have introduced earlier on, my name is Dr. Mugori, and I work as a clinical mentor in the region, but now I work as a specialist family physician in my own clinic. I completed my postgraduate training in sexual reproductive health in 2022, I mean, and after the training, I was involved more in capacity building of my colleagues, doctors, nurses, and pharmacists, more of transferring skills on various topics relating to sexual reproductive health. However, now I've left the Ministry of Health. I work on my own, where I also provide fertility care as one of the services among other services that I provide at the center. The impact is difficult to really be proud of, because when I evaluate the infertility tracking tool that I've registered all the clients, out of 24 clients that I'm following up, it's only 4 patients who were successfully conceived and delivered the baby. The rest, either I've referred them to other facilities, to specialists for further evaluations, but due to socioeconomic burden, they failed to move to that side because of the costs that are relating to IVF. So looking forward, the barrier that I'm thinking of doing further is to learn more on interventional fertility care, such as IUI and maybe IVF, just low-cost services to provide at the area that I'm residing. But overall, I can say with these 4 patients that I've managed, at least we have reduced the distance where they were supposed to travel, almost 700 kilometers to receive the best facility care in the capital. That's the little that I can say. Thank you.
Okay. Thank you. Should I proceed? Okay, good afternoon again. As I was mentioned, my name is Dr. Enid. I'm based in Dodoma, which is the capital city of Tanzania. My journey with Merck Foundation started back on 2017. I was inspired by, now he's not around, Dr. Nico. He's the one who inspired me when he went for the training at Bangalore. And then he asked me if I'm interested on it. And then in 2017, I went. That training was it was a game changer to me. You know, having trained on the OBS-GYN, you only concentrated with few cases, and then infertility was not a very big part in the, I think obstetrician they know. But that training inspired me, and it was a game changer, a big game changer. When I went back to my working place, it's a public hospital. It's not very big, so we do not have many equipment for IVFs, and then it was a very new thing because most of the people they used to go to South Africa, Nairobi, and other places. And back then we used to have only, I think, 3 centers, 1 in Dar es Salaam, and 2 were in Arusha. But after that, they became so many, and then as my colleague has mentioned, it's I think about 20, but we still don't have in Dodoma, because it's not a very big area. These centers are only in the big cities like Dar es Salaam, Arusha, and few in Mwanza. But the training has impacted me a lot of knowledge. I can see patients, a lot of them are brought to me. And the interesting thing is even male patients. I was interested to listen to the lectures, though I was a bit busy. But the male infertility. And in my area, you may find that even they can even send the patient who does not have history, any infertility concern. So long as he's a male patient complaining something about in the private parts, they bring him to me, as if he's complaining of fertility issues. But deep down, I have seen that I've impacted something in my colleagues back in my regional hospital, that they are now concerned whenever a male patient came to them and then complaining about something which is relating to fertility issues, they know where to send him. And as for me, collaborating with other centers which they conduct, they provide IVF services like where Mazgun is and some centers in Dar es Salaam. It's easier now. I reduce a lot of referrals. Most of the patients I'm seeing them in Dodoma. I'll start investigating them. Sometimes I even start with some few cycles and then send them to the centers where IVF is provided. And it reduces a lot of cost because they cannot stay like in Dar es Salaam for a longer time. They'll just go, they get treatment, and then they come back, and then I'll continue to manage them at their local areas. So the knowledge has impacted me a lot. I thank Merck Foundation for this knowledge, and I encourage that whoever have been trained, it's good to start with what you have. It's difficult to say that everybody will start in an IVF center according to the area and the limitation of the resources. But you can do something to the society. It's a big landscape of like other people, you can impact even knowledge So you gather patients and then they know where to send. You reduce referral from outside the country. They'll just go to the centers where IVF is provided within the country and they'll get treatment as according. Thank you.
Thank you very much. I want to pick from where she has left that you can do something. I completed my training in the year 2023. I'm from Kenya. I'm an obstetrician gynecologist, as already introduced. And I want to say that when I did this course, I had not really thought what it involved. Especially what I did has the aspect of embryology in it. And as you are aware, in our basic years training, embryology looks like something else. But in infertility, I got to learn that embryology is not the same embryology that we learned other than a few aspects. And the ART is an evolving thing in the region where I work. It's quite established at the big city in the country, and we now have 2 IVF centers in town. But looking at it, it has forced us to start thinking whether there is a possibility of establishing a public IVF center, and it has serious challenges with that because we've had to do a proposal which is being looked upon by the government for sponsorship. And we thought we should include maybe a genetic lab or something of that sort. But I want to say that when I got to school, I immediately thought that I needed to understand the kind of clients I'm dealing with. All infertility patients used to be lumped together with the other gynecological conditions. And there is this aspect of doctors writing requests like hormonal profile. And when they get the results back, they do not even know how to interpret them. So I began an infertility clinic above my usual duties. And initially, I thought I'll do it once a month so that it runs concurrently with the general gynecological clinic. I got shocked that the first booking had 22 patients. And I could not even be able to run the clinic considering that the amount of time you need to talk to an infertile woman is basically like half an hour because you have to convince them to understand exactly what you understand when they are already stuck in the cultural belief that they must always conceive irrespective of the cause of their infertility. And it became very difficult. Every time I ran that clinic, I could just go home. I never wanted to do anything, despite the fact that I also do private practice. I decided to increase the number of clinics to 2 clinics. And at least the numbers became a bit manageable because this was also extra work that I had to do. And indeed, I have learned a lot. I have seen all aspects of infertility, including Muralian anomalies, Meyer-Kusa's syndrome, vaginal agenesis, the things that in a general gynecological clinic you will not ordinarily meet. And it has even increased my appetite for surgical infertility. Those ones you think you can do something else surgically, including diagnostics, which has made me to, try to embrace other aspects of learning. And within that, I have also had to learn a lot of the social and the economic burden on infertile women. They spend a lot of time in the herbal medication. I don't know where it happens in other countries because they believe they should conceive in a natural way. And, while running these clinics, I have had to collaborate with some partners. There are those who have socially had to contribute some funds so that we are able to investigate some of these women. And we have also collaborated with the existing IVF centers. We are able to make a diagnosis. We are able to counsel those women who need IVF we are able to prepare them for IVF by doing some of the basic investigations and qualifying them and referring them to where there is IVFs, where we have IVF centers. Besides some in a teaching and referral hospital, and you see residents rotating in fertility, but they didn't have a set, kind of unit where they rotate. Now they have to sit with me and also have to learn a bit of this. And with some of the alumni, I have one from the region who also, we did the same course. We've had to organize continuous medical education around that town and also try to share with colleagues on what is going on. Besides that, I can say the impact we've had is that we have the knowledge and we have the skills. There are many cases that it's not every case that ends up in IVF. Most of the cases can actually be treated by a simple ovulation induction, which we can do, but you need those women in a specific clinic because even ovulation induction, it requires close follow-up. You need to know when their menses are going to begin. In the usual public general clinics, it's like to come again this date, and those women are lost. They come any other time. But since we established these specific clinics, I have noticed that, we have had some fair, good, even though it's not scientific, but some very fair success rates that we can be associated with. And of course, it has enabled me during those CMEs to encourage other doctors to take up these courses. I recently saw that one of my colleagues who graduated recently has taken up the course, and the Merck Foundation has been gracious enough to offer her an opportunity. So we'll be coming men, and hopefully with time we'll be able to set up that center that we have dreamt about. And I'm really indeed grateful of Merck Foundation. And we wouldn't mind continuing to increase in knowledge and in skills for the sake of the citizens of Africa. Thank you.
Good afternoon, everyone. It's a great honor for me to be there and to participate on this panel. So before doing this training, in our consultation, 10% of patients had fertility problem. Then this type of treatment was only available on the capital city, that is around 200 miles far from our area. And when we ask the patient to go there, they refuse for many reasons, like someone had nowhere to stay, or the tests or prescription were very expensive for them. Then they stopped their treatment. And after I completed my training, I directly create a medical unit in our hospital. I work in a public hospital, and currently the people can get treatment without even going to the capital city, except for IVF. And we had a good result. They get pregnant, and we hope we will have, we will start to do IVF very soon in our hospital. Our hospital is the second public hospital in a country where this type of treatment was delivered. So I would like to thank Merck Foundation for making it happen. With this training, I learned a lot of things, and now I am able to take care of our population. Thanks for that.
Good afternoon. As I was presented, I'm working at Bukavu city. It's in east part of Democratic Republic of Congo. Congo is the second biggest country in Africa. And we are very far from Kinshasa, which is the capital, and all of the facility which can provide IVF are in Kinshasa, even other kind of infertility treatment. So we were facing in Bukavu with a lack of fertility specialists, and then to have this opportunity with Merck Foundation to make this training was a good opportunity for us. And since it happened in 2023, and when we go back, it was a big result for us because it's permit her to set an infertility unit at our referral hospital and to strengthen our lab with creation of andrology lab. Then we can, since that time, we are able to make a good semen analysis and to make some advanced analysis in andro lab and to make preparation for IUI. And as we say, first transfer skill before transfer technology, because with those skills, we are now able to choose and to advocate with our manager what we are needed in our fertility unit. And at this time, we can offer a good assessment of infertility as well for men, as well and also for women. And then we can propose a good treatment before thinking about IVF, which is the next step of our progression. And it's a good thing for us because it also helps us to emphasize and to modernize our teaching skills and our teaching capacity for at our university and for our colleague from lab or doctor also. In the side of research, it's helped us also to improve our research, and in this area we have published a paper about microbiome and tubal factor infertility in BMC infectious disease that allow us to win the Merck Foundation Africa Young Research on the last year. And for the future, we are expecting to do more than this because we are very motivated and we have built for this time and for the other time everything which is necessary for that. Thank you very much.
Greetings, everyone, dear friends and colleagues. First of all, let me thank Merck Foundation, Merck More Than a Mother, Professor Adiga and his team for providing us with lectures and training sessions, hand-on training in clinical embryology at Manipal University. Right now, I'm working in andrology unit in the public hospital. I must emphasize that our public service in Mauritius, the healthcare service, is free of charge. So IUI, IVF, ICSI, very costly procedures. Right now we are doing only IUI procedures. We started last year, January 2024. We are a team of 5 colleagues, 2 in the lab, 2 gynecists with their team, of course, the midwife and nurses, and also 1 reproductive scientist who came specially from Canada to set up the andrology lab. But right now, lack of staff, we are only 2 working in the department. So IVF, ICSI, we are far from that. Maybe in the future, with the help of the government, of course. As I said, healthcare service in public sector, public hospital is costly. So we hope Prime Minister and the Minister of Health would help us for the future endeavors. hopefully, we want to introduce also cryopreservation and also oncofertility. But of course, funding is necessary. So we hope for the best. And despite our financial situation in Mauritius, we hope we'll have a good response. So thank you in advance for that. Yesterday we had our colleagues from the Ministry of Health who were here, not today, but hopefully I will have to pass the message to them for our future expectations from the Ministry. Thank you.
Thank you so much. Thank you to all our panelists for sharing their views and making this discussion worth our time. I would now like to open the floor for all our attendees to have a question and answer with our available speakers for the next 10 minutes only.
Congratulations to all of you for the immense effect you are having in your various places. It is always difficult to have a vision and see that through. But I think here again, Merck Foundation set the platform that you could step on and go on. It is always very difficult in the developing world when things are not planned and you see the vision and want to move with it. But I'll encourage you that the little that you can do, keep doing it. You would see the effects at the end of the day. I had to set up the IUI first when I started showing interest. I hadn't gone for any IVF training first. So I remember I went for 2 weeks training at King's College and then bought the equipment. I was my own embryologist and my own fertility specialist. So I'll do all those cases at the end of the day after finishing the clinic. Then I'll do my sperm preparations and then do my IUI. So sometimes I'm closing 11 o'clock, 11:30. There were 2 IVF centers in Ghana at the time. And I used to refer to the pioneer. He's dead now, of blessed memory. One day I sent somebody else to him and he said, "Look, doctor, I know you're doing very well out there. I can't handle all these people alone. Why don't you see this person, go for a loan, and get some equipment? They can be used equipment, you can start." I was so much humbled that somebody was asking me or advising me to come and compete with him in the normal nature, and African for that matter. People want to be the only one who does it. But that actually showed me that, look, there's wisdom in getting other people to be able to do what you can do. You multiply the effect of what you do. And that became my principle when I was pushing for setting up the Ghana Fertility Society and all that. And when the first group passed out, I told them that, look, they've had a much better training than I had, because after the IUI, this same man left his hospital, came and assessed biologists to select an embryologist, took 4 people to his center and ran them on the machine to see their eye-hand coordination and all, to see who would be best to be trained as an embryologist. And then I sent him ahead to King's College in London. And then after 3 months, I joined for another 3 months. And that was all the training I had, and so had to be going for conferences and updating myself. Google didn't have much in those days, but gradually, I kept going. But fortunately for me, when I was going to secondary school, the motto my mother gave me was, to aim high. So I'm always aiming at going the extra mile that I can. So when I was leaving King's, whatever they had there was exactly what I brought back in more newer terms. They were even saying, how come you're buying a newer version of this? I said, well, in my part of the world, when it spoils, you can't buy another one soon, especially if you get a loan. So you must get something that is robust to last a long time. But slowly, slowly, you would be able to get there. You need to be consistent. It's hard work, but be consistent and keep reading, keep applying the new things that you know. And the sky will be the limit. And don't be complacent and don't feel there's something too much. One of the things that I was very interested in for many years was helping people with carrier status of sickle cell to have children without sickle cell. 5 years ago, we started that in my center. So now, if you fall in love and you are AS, you can be sure of having children without sickle cell, because it's much more expensive looking after children with sickle cell than doing a fertility treatment that would avoid getting that. It's an investment, just like we spoke about. No, it wasn't this. I was giving another talk somewhere else about egg freezing and all that. So please, don't keep pushing. Don't limit the resources. Whatever you're going to do is going to benefit the people in your nation. So one way or the other, somebody will pick it up at some stage and come to help. And the more you do, the more they will see that it is possible, and they will open up for you. You are the pioneers in your area, and so push it on, and the sky will be the limit. And God is watching every effort you're doing and would bless it with success. So be encouraged and push it on. Merck Foundation has done very well for you. You have to lift it to the next level. Okay? All right.
Thank you so much, Dr. Edem, for your kind words. Thank you so much. Thank you, each one of you. Thank you. Now, as we come to the end of the session, on behalf of Merck Foundation, I would now like to conclude this wonderful session with a vote of thanks to all our esteemed speakers, panelists, and attendees for joining us today and making this knowledgeable session a huge success. We look forward to meeting you all again for more knowledge sharing and great learning opportunities in the future. Please be reminded to visit our website, merck-foundation.com, and download the Merck Foundation app from the Play Store or App Store to stay updated about the various courses available and path-breaking initiatives by Merck Foundation.